and 80s. The previous surgeries were all failing because the implants were not right, the material was not right, improper patient selection was there, polycomponent wear was there, loosening was frequent, dislocations were very frequent, and there was early conversion to TKA, and the revision rate was high, and then the procedure went into disrepute. Mobile bearings, as introduced by the Oxford group, really changed the era, brought in a new era of TKAs, and it was designed to increase the congruency of the contact area, hence decreasing the contact stresses. So, which is a totally new concept, different joint, different philosophy of the joint as well. The PFC Sigma partial uni has different goals. It is reliable fixation, normal kinematics, low wear, low bone loss, and easily revisable as well. And has a very easy surgical technique as far as TKR surgeons are concerned, because the steps are fairly similar. The femoral component has 6 sizes, 2 lungs, it has no keel. It helps, the asymmetric design helps in kinematics and helps to centralize the tracking. It has a moderate width of the implant. Divergence of experience from all over the world, primarily Europe, where the Oxford experience was brought in, and they showed very good long-term survival, 78 to 98%, up to 16 years, SWOT in a different series, and this is going back more than 22 years, showed 96% survival of Oxford knee at 20 years. Various registries from all over the world have quoted. Now, the interesting thing about this is, even though up to 50% of joints are eligible for UKR, all over the world, only from 5 to 11% of the cases are UKRs. That means the surgeons are reluctant to do UKRs, and they have not been taught to do UKRs. So it is very important that people learn. The survivorship, it varies between the process designs in most individuals, but majority of long-term studies have shown similar survival amongst the mobile bearing and fixed bearing. There is no great advantage of one over the other. So the opportunity is there to learn UKR and to do UKR, and it is very much possible to increase the numbers from 5 to 10%, going up to 30% worldwide. What is necessary is education of the surgeons, of the patients, and to decide whether fixed bearing over mobile bearing, or whichever one is acquainted with, one has learned with. The basic enigmas for UKR is whether to do a UKR or TKR, what are the real indications, pre-op MRI is necessary or not, minimal optimal incision, fixed bearing or mobile bearing, cemented, uncemented, ideal surgical parameters, whether ACL and UKRs can be done at the same time, cost effectiveness of the procedure, and how is the future going to be for UKR. So let's address some of this. Most important being patient selection. If your patient is well selected, you do the right surgery, you will get a good result. So Cousin and Scott in 87 laid down the initial indications for the surgery, and they were very categorical that it has to be isolated medial compartment away, age has to be less than 60 years, weight has to be less than 82 kg, angular deformity less than 15 degree, passively correctable to neutral, fixed flexion deformity of less than 5 degrees, and range of motion should be more than 90. And accordingly, if you go through these, the number of cases which you are going to select is going to be less. Then comes the physical examination of the patient, must confirm the location of the tendons along the medial joint line. There should be no tenderness in all the other areas. The varus should be correctable to neutral on valgus stress clinically, and ACL should be intact. The anterior draw should be negative clinically, even if the ACL is damaged or appears thickened or partially torn on an MRI examination, because MRIs will tend to show a higher rate of ACL damage compared to what your clinical test is going to be. So rely on the clinical test. And some series have accepted BMI even up to 45. They've done UKRs. So according to Cousin and Scott criteria, only 6 to 12% of patients would be eligible for UKA, with expanded indications which have come primarily from the Oxford group. Up to 50% of patients are eligible for UKA. Contraindications to UKA, when never to do active infection, of course, inflammatory disease. One should not do. Ligamentous instability, namely uncorrectable varus deformity, because the surgery per se is not going to take your knee into valgus. You are not trying to achieve valgus. So if it is an uncorrectable varus deformity, patient will not have pain post-operatively, but the gait pattern will not improve. So that is, in my mind, definite contraindication to UKR. Of course, absence of an ACL, previous history of HTO is going to make surgery more difficult as well. And severe wear of the lateral facet of the patellofemoral joint with bone loss and grooving should be a contraindication to TK. X-ray criteria for selection, it has to be a medial side bone-on-bone joint disease, and the lateral compartment should be good, and the involvement can be primarily on the femur side or on the tibial side, but this has to be correctable to neutral axis, and there should be good joint space laterally. The radiograph should show no greater than 10 degrees of deformity in all planes with no translation of the tibia beneath the femur, just to indicate that the ACL is intact. And the X-ray should show only the anteromedial OA. So get AP and lateral views done, it's very important, and the stress view should show good lateral joint with good lateral side cartilage. Bearing designs, you'll get fixed bearing design and mobile bearing designs. The philosophies are very different, the steps are very different as well. Survivability, long-term survivorship is same according to all the papers. So I would suggest that people who are going to start doing this surgery for the first time, and if you are a regular TKR surgeon, try the fixed bearings first, and then only do a proper course, Oxford course, and then try doing the mobile bearing, because basic instruments, philosophy of the surgery is very different. They cannot be compared as such. So, patient selection and expectation management is important. Much easier for a surgeon performing TKR to learn fixed bearing compared to mobile bearing. In case of conversion from UKR to TKR, positioning of the fixed bearing UKR helps in the revision surgery. Keys to surgery is, of course, surgical technique, appropriate balance, collateral ligament tension. Mobile bearing requires good surgical skill. Most require hanging leg position to do the surgery, so which is something new, one has to learn that. Fixed bearing is easier to perform, traditional TKR position, so easy for the surgeon and the staff. And the fixed bearing processes often have a flat tibial articular surface, which is technically easier to implant compared to a mobile bearing implant. Intra-op images, as you can see, the cuts are very small, the trochlear groove is left in place, the lateral side is okay. You do not flip the patella over to see how the patella is, and this is a typical fixed bearing implant there. Some post-op x-rays, easy to do, alignments are regained. Post-op evaluation is important. Make sure that you are putting your joints in the right slope, the right place in the femur and the tibia as well. Immediate results are fine. These are both patients at 15 days after surgery. They get back. This is the patient. Bilateral UKR done. First post-op day, patients can be fully weight bearing, and next day they definitely go home. Pre-op, post-op. Again, patient on the first post-op day. Walking. There's a lady whose was done 6 months ago, and look at her dancing at someone's wedding, totally oblivious that she's to ever take care of her knees. Very, very happy. So this is what happens when the expectations are met, which is not very difficult with UPR. Thank you.
Thank you for an excellent talk. Discussion? Anybody?
Here. I think you gave two ideas, like
typically Keep it down, and definitely do an MRI. Though as a screening test, it is not necessary. As a screening test, it's not necessary in all positions, all cases.
But ACL should be intact.
Clinically, it should be intact.
Clinically, it should be intact.
Yes.
As per the MRI, what we do like?
MRI, if it is completely torn ACL on MRI, then of course it's a contraindication. If it's a partially damaged or a edematous ligament on the MRI, I won't be concerned.
According to Chris Cody, what he says, MRI is not at all indicated. Even with X-ray, you can find out whether the ACL is intact or not. The posterior slope involvement, and it is not needed.
There may be on examination, it may be intact, but it may be weak, but radiologically, it may show the increased deficiency of bone in the posterior aspect. If it is there, it is a contraindication, they say. Even it is intact, it should be, the normal strength of ACL should be intact. Is it so? ACL, even it is intact, it should be thing.
So few questions I'll ask when operating. The first thing is, do you always take a stressing?
I don't.
Always.
I don't.
You don't?
I don't.
Okay.
If I'm bringing the knee to normal alignment cleanly in the outpatients, then I don't necessarily take a stress extra.
So obviously you take a skyline view and the
Yes.
Rosenberg with the
Yes.
single leg view.
Yes.
And how often is your UKS to tell and then go inside and convert it into TKI?
In so many years, I've done it only for one patient.
One patient. Yeah.
Though I keep the set and automated
Always.
and ready, and all the patients are told as well that if I am in doubt, I will thoroughly convert. And patients don't mind because the cost of the implants is the same. If the cost was going to change, in their mind it's a bigger concern. But since the cost is same, they are also happy.
Yeah, I feel in our place that selling UK is little more tough.
More difficult.
And they all want only a TKI, why do you want to replace
Yeah,
only
same
one?
money, yeah.
Same money.
Because their concern is that few years down the line, they will require to be converted to a TKR. Though that is not the case. UKR can be at the end surgery for a great majority of patients.
And what do you do? You do anything to the patella?
Patella, if there are obvious big osteophytes, I might nibble them if I can, but I will not evert the patella just to go after those small osteophytes. No.
So if it is very obvious, then probably.
Yeah, if it's accessible and if I find, sometimes you find a notch, a big beak of a osteophyte on the superior aspect, that I'll just take it with my nibbler. But I will not go after it in a big way.
So in the lateral aspect, if there are some fibrillations, you won't mind. The patella.
Some fibrillations I won't mind,
It's
some
only-
lateral aspect, osteophytes also I won't mind. Lateral osteophytes are not a contraindication for UKR.
Do you have any indication for HTO?
HTO, if I am not able to bring my joint to neutral, I will not do a UKR, then I would advise a HTO.
How often?
Not too often, not too often. You see, both HTO and UKR are more difficult surgeries to sell to patients these days. Even HTO, I find I'll have to make a huge effort to convince a person to undergo HTO. I find it much easier to sell them a UKR because immediate walking, the whole story is over within a couple of weeks, whereas with HTO, the explanation of a longer time period for recovery, they have to be patient, they have to be non-weight bearing for a certain period of time. But the difference between HTO and UKR is, for UKR I want it easily correctable to neutral, otherwise I would not ask for it.
How long can we expect UK
Their whole life as well. It's not a stopgap surgery. Definitely not a stopgap surgery. Because even in 75, 80-year-olds, when we do a TKR, we find that the patellofemoral joint, though it may have some osteophytes, but the cartilage is not bad. The lateral side joint cartilage is good. So there's nothing to suggest that a UKR done at 55 or 60 years of age will convert to TKR later on. And in practical experience as well, in 25 years, I've really not converted someone from UKR to TKR just because of advancing osteoarthritis. It's not a common thing. It's not a common thing.
Come across, there are certain papers who are presented UK with ACL.
Yes.
Come across, or do you do?
I personally haven't done. I would be a bit scared to do for just technical reasons because you're making a tunnel in the middle tibial condyle, so you're weakening the bone there, and then you're doing taking away the proximal 3-4 millimeters of tibia and then hammering in the joint there, making a key. So I would be a bit hesitant to do that.
After correcting by UKA, the progression of osteoarthritis is stopped. Because of the biomechanics, failed biomechanics, your progression of OA occurs. Once we corrected the varus deformity and other things, the progression of OA is diminished. It's very unlikely. We may think that it will progress to the lateral aspect and then we have to do a TKR. It's not very much.
You told the indications in the obese patient. So we have seen in our practice being a scope surgeon, a lot of these obese patients when they come to our clinic, we find the myxoid degeneration of the ACL, and also they have some root tears. Medial side is not a concern, but if there is any root tears on the lateral side, what about how to deal with the myxoid degeneration of the ACL?
Myxoid degeneration, again, I'm seeing them at all ages. Even 25-year-olds come in sometimes with myxoid degeneration, and some people have immense amount of degeneration. If I know it and it is there, it's a painful condition, then I would not do a UKR. Because if that is a cause of pain, it will remain a cause of pain as well. So that is a grey area in my mind.
You said there is no need for conversion from a UKA to total knee. If at all it takes a chance to convert or it happens to convert, whether it should be as a primary TKR or solution.
No, I've always done my conversion to a primary TKR. One case I put in a stent, but the rest have all been primary TKRs. And they're not difficult to do. I find hardly a millimeter of gap medially, which can easily be filled with cement. I've never had to use a wedge or a augment so far.
Good morning, sir. Have you seen any patients who had undergone TKA and had a failure of the ACL in the successive period? In that case, is there any specific techniques to handle, sir?
I've not personally seen it, but if I do see it, then I would do ACL reconstruction rather than a total revision in such a patient.
And is there any specific cutoff that beyond this degenerative changes in MRI that you will not do AKA, even though clinically the anteroposterior visibility is not there?
I would rely more on the clinical aspect.
In such scenarios, how do we distinguish between the hamstring tightness related restriction of anteroposterior visibility?
Okay. Then in that case, you have only the one chance in the outpatient to do a proper test. So make sure the patient is comfortable. You hold the leg in the right position. The hamstrings are relaxed. I actually feel the hamstrings with my left hand, index finger, and tell them, relax this particular tendon. And they all do it. And then that is a chance that you should test it. Because if you've done it a couple of times, then they will be tense. So the first time you touch the patient, do the test, you make sure they are completely relaxed. Then only do the test. And then you get the right answer.
Thank you.
Thank you, sir, for your excellent
Thank you.
talk. We will go on to the next topic by Professor Geriatrics, Director, Institute of Orthopedics, MMC Chennai. He is going to talk on role of HTA in early arthritis.
So, good morning to all. We have said I should thank the audience for having me to do this talk. So, after that excellent and wonderful talk on the beauty. So, if there is a 65-year-old male coming to the outpatient department, male having the outpatient department with osteoarthritis. And there are so many options that are available, and it is an acromial OA and
do an elegant unicorn knee, give them the best result, then that will be fantastic. So initially we have been doing a total knee replacement, and now we are also exploring the possibilities of a unicorn knee, and that gives the best result. And till the very recent they did not take up unicorn in a great way, and then they started doing it, and after seeing the result, it is amazing that you want to do more. So this patient especially, the way he walked, the way he climbed immediately, that is amazing to see. So that is possible. But imagine a 45-year-old coming to the outpatient department with a varus knee and medial joint pain. So definitely you don't want any procedure like a unicorn, because he has long more years to go. Though the physician says that 15 years, 20 years it might last a lifetime. Still we have not seen, and whatever we have not seen, we are always apprehensive. So we have to explore the other options. So obviously this talk is about a young arthritic knee, less than 50 years, severe medial joint and pain, and a varus deformity. So this is the time that we have to find out what else we can do to prevent this from progressing to a early tricompartmental osteoarthritis and going in for an arthroplasty. So these are the patients who will require high tibial osteotomy, correct the mechanical access to the midline as far as possible. You have to do it. So this is a very high demanding procedure. You have to plan it very meticulously. And once it is done, when the axis is shifted to the midline, then this knee should last the normal as how the normal knee should perform. So this high tibial osteotomy is a very well established procedure. And the most reports have shown that 80% satisfactory results in 55 years and 60% up to 10 years. And then also they can prolong before they go in for a total knee or anything. So the indications are very, very important. So less than 65 years, isolated medial compartmental OA with intact ligaments. That is very, very important. If there is any deficiency, if it is subluxing, then that is the patient whom we should not do. Non-smoker, because the osteotomy has to heal, you should not produce a fracture and then produce a non-union. BMI must be within the limits, 30. Range of movement which should be more than 90 degrees. So a stiff knee, don't try to do a high tibial osteotomy. The FFD also should be, can extend the indication up to 10 degrees. Patient should be able to use crutches, otherwise his motor system should be normal. And this is very important. Varicose veins, peripheral vascular disease. So these are the patients whom we should not attempt a high tibial osteotomy. So more than knowing about the indications, the contraindications are very important. Lateral tibial subluxation like this of more than 1 centimeter, a tibial bone loss, which is the arthritis has progressed beyond the cartilage loss to the tibial bone loss of 2 or 3 millimeters, a flexion contracture of more than 15 degrees, a stiff knee with range of movement not going beyond 90 degree, more than 20 degree of correction is needed. Of course, the inflammatory arthritis where the other compartment is also involved, don't expect the high tibial osteotomy to work. So the ideal indication will be more than in the joint, the varus deformity. If there is a metaphyseal varus, when you draw the epiphyseal and the shaft axis, when you draw that line, and if the varus is more in the metaphysis, that is more appropriate, because the varus is secondary to whatever the deformity the patient is having, and the shifting of the mechanical axis to the medial compartment rather than in the center of the knee joint. So this is a very ideal scenario for that. So a case like that, if there is a metaphyseal varus, you can see that the joint looks almost nearly normal, but there is a gross varus which is happening just below the metaphyseal region. So this is a very appropriate condition. So what are the aims of planning? You have to calculate, because this is a very highly precise procedure. For that matter, everything is, it should be done very precisely. But here all the more so, unlike many other conditions, because the survival might come down very drastically if you are not planning it properly or not executing it properly. So you have to locate the deformity. You have to exactly plan what is the deformity to be corrected. But most important of all is whether you are able to execute it, whatever you have planned. So all this precision is very, very important when you are doing a high tibial osteotomy. All these correction procedures. So if there is varus deformity like this, we take a stress view to find out that the lateral compartment is intact, the ligaments are intact, the cartilage space is there. So when we establish this is the patient we have to proceed for planning. So full length X-ray is very important. You have to find a way, devise a way that full length standing X-ray, proper X-ray from the hip to the ankle with the magnification marker. You have to take it. So this is a Miniatis method which I will try to, there are so many methods. So this Miniatis method is, so draw the mechanical axis from the center of the hip to the center of the ankle. Yeah. So this you draw from the center of the hip to the center of the ankle. You calculate the length of this line, and then this is the center of the tibial spine to which you want to shift. So you draw the next line of the same length. Yeah. This is easier rather than taking the pointer using the mouse. So you draw the second line which is of the same length going through the center of the tibial spine. Once you have done that, you have to plan the exit point of your high tibial osteotomy, which is we normally now do only an open wedge osteotomy. The exit point is the head of the fibula, the top of the fibula, where it has to exit. So this osteotomy is planned. So you have to draw a line from the line which you have drawn along the actual mechanical axis where you want to establish, and from the previous existing point to that same point. So this is the angle of the correction what you have to make, and then once you have calculated, that has to be replicated here, and that is the angle where you want to, how you want to do. So for example, in this case, you have planned for this line, and you have drawn exactly the same length line, this yellow line which says, once you have done that, then you have to mark the point. This is the point where it exits. So that point has to be connected by the original line from the center of the ankle, and also the line where the actual mechanical axis where you want to bring. So these two where it meets. So once that is done, that angle is you have got. So that angle and where it exits in the medial side, that is the actual distance to which it has to be opened. So this is the method by which you can do it. So there is also a calculation this table for easier access. When the width of the tibial proximal tibia is known and the angle of correction what you want, then you can have the exact base of the wedge what you want to open. So the surgical technique, so everything must be very, very clearly marked. So a medial incision what is done, and medial soft tissue release up to the medial collateral ligament you have to go. So the proximal entire tibia is exposed. Once that is done, you have to take the wires where you are proposed osteotomy. It has to go exactly to the top of the head of fibula. The wire, two parallel wires. So this is the plane in which you want to make the osteotomy. So once that is done, you have to carefully protect the posterior structures, because this osteotomy, the posterior vital structures are there. So if it is a radial lucent retractor, then it is better. So this is a radial lucent retractor, and this is the saw which is going inside. And the second most important thing is you have to maintain lateral 1 centimeter of the cortex intact. As you are opening, the saw must not go up to the lateral cortex. This hinge is very important, and you have to open it like an osteoclasis. So this is very, very important. So these two wires are there, your retractor is there, and the saw is going, and the saw should go exactly to that point. Then the calculated wedge is taken, and that it is opened. You can see that still the lateral the cortex which is not opened is still intact, and it is progressively opened. Then it has to be fixed. So this is a biplanar osteotomy. So you have to take it, and the last 2 centimeters in front of the tibial tuberosity, it has to be angulated, and in this plane. So this is one plane and this is other plane. So this you can, the cortical contact must be maintained as it is open. So this gives stability to the osteotomy. So this prevents change in the tibial slope. because tibial slope must be maintained. Once you are opening the medial side, the posterior side, if the anterior side, if it collapses and if the tibial slope is altered, then the entire biomechanics of the knee joint is altered, and that doesn't produce a good result outcome. So for you to get the good outcome, the tibial slope, what is native, it must be maintained as long as the anterior cruciate is intact and the ACL and the PCL are intact. So you fix it. So you can fix it with if it is elegant fixation you can do, or whatever if the patient cannot afford because it is prohibitively costly. So if you want to do it also with a normal plate, but these principles must be followed. So this must be opened. This should be parallel, and this contact of the osteotomy surface must be maintained. So this is open. It is not necessary initially when the osteotomy was done. It is not necessary to put anything in between. So the osteotomy closes from the intact lateral side medially within 6 weeks. So this implant allows immediate weight bearing, partial weight bearing in practice, and within 6 weeks the entire osteotomy, opened osteotomy fills up. But we are apprehensive and we don't want to, so you can put in some graft, because I always do that. So a substitute can be put. So once that is done, so this is pre-tensioning of the osteotomy. So once this is fixed, you can use a cortical screw, and then once you are lagging it, this produces tensioning here and compression here. So this is also another important. So each and every step is important. Once you have fixed it, you fix it with the cortical screw in the lag mode, like just compressing. This produces compression at this, and then the locking screw can be applied. So this you have to always make sure at the opening of the osteotomy whether you have brought it in the middle of the tibial spine. So this is the center of the femoral head, and this is the middle of the tibial spine, and this is the center of the ankle joint. So at the end of opening, you have to establish that you have brought the mechanical axis to wherever place you wanted to keep it. So this is the post-operative, and this is 6 weeks and 3 months, the entire osteotomy getting consolidated. So even if you don't keep it, this is so stable, the angle stable locking compression plate. So this produces that stability, but still you want to be very careful. This osteotomy closes from here progressively within 6 weeks. So this is the follow-up. This is another patient, and this is the follow-up. So this tibial slope, as I was saying, it has to be maintained in whatever position it wants. If there is an ACL deficiency, then if the tibial slope is reversed, so that prevents the tibia from coming forward. So in some indications where ACL is not planned, or if there is minimal anterior instability and varus deformity, you can still do this tibial osteotomy without an ACL reconstruction, and then see also with a reversal of the tibial slope. And if there is a posterior instability, the slope can be increased. So this prevents the posterior subluxation of the tibia, and then you can have the correction of the deformity. The ACL reconstruction, the scope surgeons, I am not a scope surgeon, but I went through the literature. There are so many reasons for failure. Apart from the surgical technical failure, around 10 to 12% of the ACL fail within 1 year or 2 years. So when those cases are studied, when the surgeon was not at fault, when there is the slope, if it is the varus or valgus, if it is there, if there is a varus deformity, then that causes more incidence of failure. So there are papers which are coming that correction of the varus along with the ACL reconstruction, that increases the survivability of the reconstructed ACL. So along with ACL, in an young individual, if you are doing combined tibial osteotomy and ACL reconstruction, that also increases the chance of the ACL survival and having a normal knee joint. So these are the papers which say that a young individual with an ACL reconstruction is possible, but I have not done, and it is only the literature which says that. So to conclude, identify the deformity where it is, a meticulous planning, it cannot be more stressed, and whatever you have planned, achieve the planned correction for a successful tibial osteotomy.
Thank you, sir, for the excellent explaining about each and every step. Actually, it is difficult for me. And it is better for a UK, it is easier.
Less than 50 years, it is always better to do a osteotomy and you reserve the GPA high procedures, higher procedures for people who are more than 10 arthritic still joint conserving procedure is better. I don't have. So people have been doing and producing excellent results. So whatever way you achieve, the only thing is you have to plan meticulously, and if you are able to achieve maintaining the tibial slope and correcting the mechanical axis, I think it should be wonderful. So people have done wonders with this, but I don't.
Sir, have you used any special plates like with wedges for the opening the osteotomy, where the wedges fills the gaps in the open area?
Plates which is containing wedges. So it is only the calcium phosphate what the bone graft substitute can use and which gets incorporated. But in the initial day, one patient I did and I was having my heart in the mouth when I till the osteotomy site closed, but it went on for union. But after that, I've never had that. I just wanted to put the graft. Okay.
We asked for the voodoo plate. The plate was more of an indigenous made, and as he said, a lot of infections were there following the voodoo plates. Why?
If not such plates were used, sir. As an arthroplasty surgeon, I was having a very common doubt, like after the plate removed, what will happen to the gap?
So, but even if it is removed properly, initial days, because the bed is not going to occupy the entire space, it is going to only maintain the space. Our mechanical stress according to everything will remodel and come. So that should not be a stress right there. But anyway, you may have to add a stem to prevent.
Doubt is there is a gray area between 50 to 60. I was saying UK and you are the HTO. So in that gray area, when the patient is 55 years old, still the age seems to be intact. More of a middle compartment. The active male, the sedentary female. So what will be your child in both?
So this is always a debated and always a very interesting question. Yeah. So the ultimate consensus in my practice personal is different. The ultimate consensus is if it is a young, 55 it is only the chronological, but physiologically it is very young. Still you have to give a high-degree osteotomy and give a chance for the nativity because he is active and athletic and doing. But the characteristics of the patients who are coming to us are not up to that. Even if he's a male, the activity level is not that much. So, given the bearing options, have tribology have improved so much with the poly and the survivorship. What we are seeing in the registries across with the fixed bearing, the way it is being executed, and the ease with which you are able to do. Definitely, you have to need any technique very meticulously. But once you are able to execute, I feel that still UPS got a chance. Even though I am speaking about HTO. So for those specific patients who are very young and athletic and they are high demand patients, probably high-degree osteotomy. But most of the cases are about 55 arthritic, still a UK. Thank you, sir. Thanks.
Thank you very much, sir. I'd like to invite the speaker, Dr. Prashant B, for the role of arthroscopy in early arthritis.
Morning, I thank you, Dr. Sukumar and Steve, for inviting me for the talk.
There are few definitive indications where arthroscopy navi arthritis helps. So otherwise, as a general joint lavage and simple cartilage debridement is not helpful for an early arthritic knee. That's what the literature says. Okay. So in arthroscopy for an arthritis, what exactly it means? There are many procedures which are done arthroscopically for an arthritic knee that include cartilage debridement, lavage, chondroplasty. Basically, they can be divided into three categories: arthroscopic lavage and debridement, and second is malacstipulation of the cartilage and repair technique, and cartilage transplant procedures. Arthroscopic lavage, what does that mean? It means we withdraw the synovial effusion wherein the inflammatory chemicals will be there, and we irrigate the joint. And it includes removal of cartilage debris and other inflammatory agents. And it mainly involves removal of mechanical irritants. That can be a loose body, a meniscal flap, root meniscal tear, or a buccal tear, and some synovectomy. So this is what lavage and debridement would do. And indications. So these surgeries, when done in properly indicated patients, they are useful. So these surgeries then mainly to delay your arthroplasty, say around 1 to 2 years. Yes, if properly chosen patient, this is our aim would be achieved by delaying the surgery for a few years. So what are the indications? The symptoms, mechanical symptoms should be of short duration, so that the arthritis would not progress to next level. And there should be minimal mechanical malalignment. So what was earlier sir was expressing, and the mechanical alignment, if the alignment is not good, then your arthroscopic debridement will not help. The symptoms are mostly because of alteration in the mechanical axis rather than the problem in the knee joint. So absence of flexion contraction. There are studies which have shown if the person has having more than 10 degrees of flexion contraction, arthroscopy will not help at all. And most importantly, when you're doing these procedures, we are trying to delay our definitive arthroplasty procedure. This the patient should be understanding nicely. So if the patient should have realistic expectation. So patient should not tell that surgical procedure is done, after 3 months again I am having pain. What is this? So you should explain the patient what is the reality and then proceed with this kind of procedure. In a well-indicated patient, surgery results in decreasing knee swelling. How do you assess the results? That the amount of knee swelling would come down, his walking distance and walking ability would become better. So what are the mechanical irritants? Mechanical irritants are usually meniscal fragments and the toe meniscus, and many of the time the root meniscal tear, where the patient has like difficulty in walking, initial few steps of walking, after that he will be comfortably walking. And there are loose bodies which patient would appreciate, and synovitis. So there are a few studies which have shown that. So in a 49 patient, when the debridement is done in a well-indicated person, they would get 52% of results.
And better results are obtained in less than 1 year duration for mechanical symptoms. If the patient has mechanical irritation, locking episode, they have better results. So that's why mechanical irritation, if they are there, this surgery is useful. And they repeatedly it has been stressed that if the mechanical alignment is not good, arthroscopy will not help in these patients. And there are other studies which are also substantially the same. So there is one study which strongly objects arthroscopy as a treatment for arthritic knee. So it is a double-blinded prospective study which did not show benefit of arthroscopy or placebo. In that study group, they are divided the patients in 3 categories, wherein in one group they did arthroscopic lavage, the second group it was arthroscopic debridement, and in third group it was sham procedure, where incision was put, some plain tissue plates were elevated, and then it was just closed. So the results in all 3 groups were not statistically significant. Means the placebo groups has done equally good as an arthroscopy group of patients. So, but later on the study was questioned basically because the indications were the patients were less than 75 years with OLE, which was treated conservatively, and the patient was not done arthroscopy for 6 months. So there was no specific indication stating which requires an arthroscopy. Like patients were not selected according to the symptoms. Where if they have mechanical symptoms, they are taken for the case. So it was generally taken a patient who is less than 75 years who has osteoarthritis. So since the selection criteria was not good, probably this study was not that important. But this study result shows that there is no difference between placebo and arthroscopic group. So next comes the cartilage repair technique. Cartilage repair technique where the cartilage does not have a blood supply, so it does not have the capacity to regenerate. So we drill to subchondral flow so that mesenchymal cells can migrate and a cartilage-like tissue is prepared. The tissue is formed, that is fibrocartilage, which would have more of a type 2 collagen and allows. This is what cartilage repair technique. So there are many cartilage repair techniques that use abrasion chondroplasty, subchondral drilling, microfracture, and the autologous or allogenic cartilage transfer, which include OATS and allogenic osteochondral transplantation. And there are other newer techniques which include growth factor and biologics. In the barostimulation technique, see, these are techniques which are basically designed for a traumatic cartilage defect, not for an arthritic knee. Patients who has emphasized arthritic knee, these would not give good results. Okay, so these are isolated for 1 to 2 centimeter defects, and knee there should not be significant malalignment. The main disadvantage is patients should be non-weight bearing or using crutches for a period of 6 to 8 weeks. So which is difficult in an arthritic person. As I said, these are useful in isolated lesions. And abrasion chondroplasty, where you operate the damaged cartilage and stimulate the subchondral bone. So this is also not shown any significant benefit over an arthroscopic debridement. Subchondral drilling, yes, these are useful when there is a contained defect. For an uncontained defect, this is also not that useful. Microfractures, yeah, microfractures, the mechanical advantage is no thermal injury involved, and with that, now this is also proved that where the surrounding cartilage, if it is not healthy, the amount of tissue produced, fibrocartilage produced, is not that good. So that's why it is limited indication in arthritis condition. And autologous cartilage transplantation. So this is you take a piece of cartilage from the patient and grow that cell outside and later on implant. So earlier it was a 2-stage procedure, and in the next methods they have made it as 1-stage procedure. But these are also useful only in contained defect. So in arthritis, their usefulness is limited. So it's a 2-stage procedure. Now in second generation ACI, the cartilage cells are impregnated in bioscaffold, so there is no need to take a periosteal flap. And in third generation, they are shown as a pellets. So these are the next methods of ACI. but definitely in arthritic knee, they have not shown very good results. Oats is a subcontractor product harvested from a non-weight area and is kept on a defective area, weight bearing area. So this procedure, if done arthroscopically, the results are not good, mainly because the graft has to sit perpendicular to the cartilage surface. So that's why it is many of the time it's an open procedure. It's contraindication in patients more than 50 years. Mechanical involvement, instability, it cannot be done. And when this is in combination with HTO or other corrective procedures, the results are not that good. Okay. And allogenic osteochondral transplantation, these are suited for larger defect. And these, yes, definitely can be done for an uncontained defect. Most of these are tried in trauma setting, not for an osteoarthritic knee. So wherever it is done for osteoarthritic knee, the results are not that good. The main disadvantage is the risk of disease transmission is there with it. And growth factor and biologics, yes. Now recently, what is called human umbilical cord blood, there are desencable stem cells. So they are in the market, and it is already been in the market with the name RT stem. So they claim that these harvested, like this is done like a oats. These harvested stems, when they are impregnated in the defect in the cartilage, they produce hyaline cartilage. It is not hyaline like cartilage. They are producing hyaline cartilage itself. But these are in a study phase. I don't have my personal experience with them, but they are promising. So I came across an interesting study which shows, like it was done which arthroplasty done in person who has undergone arthroplasty at an earlier age to postpone the surgery. So in these patients, 5.9% of the patients who had done arthroscopy, within 1 year, they were requiring knee replacement surgery. And roughly around 10% of the patients, they would require knee replacement surgery in 2 years. And roughly 17 to 18% of the patients would be requiring knee replacement surgery in 8 years. So they are of the conclusion that doing an arthroscopy for an arthritic knee to delay arthroplasty is not cost effective. It should not be indicated. That's how the result shows. In a normal population with the ONE in the age group of 30 to 40, doing an arthroscopy increases the chances of doing a replacement surgery 17.18 folds. It means actually the patient is indicated for arthroplasty, but you are doing arthroscopy. So that's what the impression is. In a population over 50 years, if you are doing an arthroscopy, then there are chances of he getting a replacement surgery in next 2 years is around 80 to 90%. So that's why a person over 50 years, arthroscopy is not good thing to do for an arthritic knee. Thank you.
The questions will be, or the session will be taken after the live surgery, sir. Thank you, sir. Thank you, sir.
Now we welcome Professor Dr. Ashok Kumar, Preethi KNee, Professor A.D. Shanmuganathan, and Dr. Anand Srinivas. Our next session is live demonstration surgery by Dr. Satish Patel. We welcome Professor Singala Vadivelu, Dr. Rashid B.A. and Dr. Rajkumar to moderate the session.
Hello, Dr. Satish. Good morning. Can you clearly then? Okay, so this is the patient, a 60 male. I just shook X-ray. These are the standard standing X-rays, the right side and the left side, and of course the stress X-rays in varus where you can see bone on bone disease, and the valgus strain in which you can see that the knee comes to proper alignment. There is space medially, and the space on the lateral side is also well maintained, which shows that the lateral cartilage should be fine in this case. Of course, there is a skyline view showing the patella, no major osteophytes around the patella. There is osteophyte on the medial femoral condyle, as can be seen here, and in the AB views as well. This is the lateral view of the left knee, you can see here. And you can see that there is slight depression compared to the posterior side anteriorly, but overall a good joint selection for UKR, and that is the standing X-rays showing the alignment of this. So we are going to be operating on his left knee.
Actually, we think that there is posteromedial tibia.
Yes.
Is intact. I think that there will be degeneration extending up to the.
There is a slight osteophyte right at the posterior aspect there, at the beak you can see, but other than that, I don't think there is any depression, bony loss there. Now, I'll show you the patient. We just opened up the knee just to make sure we get the bleeder. Okay, 20 days now. Just give me a wash, please, once.
Your Dr. Satish Rajkumar here.
Yes.
So your position, can you just
yeah.
Whether you use a holder or
free
handling?
Okay, so this is a typical TKR position. There's a high thigh tunicate and knee can be bent up to support on the table is so that I can keep the knee 90 degrees. This is a standard position. There's side support as well, so the leg doesn't fall down and no one has to keep holding the leg throughout. So it's the same position as we would take for a TKR. Okay, so
you always stand on the right side?
I always stand on the right side. And
usually your incision size is this big or
no, slightly smaller than this, but because we have cameras to show the live surgery, it's important that everyone can see what I am doing at the moment.
Once you open, do you visit the lateral side?
Yes, I'll show you that as well. Just give me a second. I just erased just the proximal there, so I can put a spike in this area, which will be handy to protect my MCL later on. Okay. Meantime, okay, let me show you the trochlea. This is the femoral trochlea. Looks good. That looks good. When I will not overturn the patella, but I can see there is fibrillation on the patella medial facet as well, but nothing too major. And I'll show you. The next what I do is I make sure and see the ACL now. ACL is intact.
Okay.
ACL is completely intact. So I just lightly put a spike there, and the lateral side of course completely intact. Is there. I've taken out the anterior pad, and this is going to be what I need to see.
Sometimes in the lateral side, if you see any small ulcer, like it's not a full-blown ulcer, but still there is something very minimal. Do you at that point of time think twice?
If it's worry about it, if it's a major bone loss, of course, I would convert to a TKR. If I find the cartilage very bad, then I would. Otherwise, this is a case like this where everything is intact. There is a antero body there which I have just taken out. Then I can show you the medial osteophyte is there along the femoral condyle. I'll take a osteotome and take that out first because that is going to influence my selection of the sizing. So I'll just excise this at this stage. And making sure that my MCL is not disturbed in any way. Great. I've not removed my menisci at this stage. I'll do it later after I take the tibial cut. Because there is no way I'll be able to remove the meniscus posteriorly at this stage. So I don't make an attempt to waste time there. Good. Now I'll start with the this is the top of the tibia. I can see where my ACL is. That is clear. My ACL is great. I have to see the intercondylar notch. So my cut is my vertical cut is going to be there, and I have to make sure I don't damage any part of the ligament. So this area has to be clean before and all it needs is taking away a bit of the anterior fat pad. I do not damage the patellar tendon in any way. Okay. So let's get the tibial jig in. This looks like a standard TKR jig, nothing different about it. Align it with the shin. Okay, I'm going to be taking 2 mm off from the medial joint. Okay. Let it go down. Okay. The first pin is in the vertical slot, which gives us a little leeway later on if we increase our cut. So this is all we need to do. We put in a tibial jig. We can use a angel wing at this stage if we want. Not necessary. Take away the two questions that coming in. Dr. Satish, two questions. Hello, Dr. Satish. Yes, tell me.
Yeah, two questions. One is that you are putting in the vertical slot at the top of the slot. So if you want to bring down, it may not be possible. So
this pin has been put up too much superiorly. Yeah. The reason was the skin was coming there. So if I need to change it, I can extend the skin slightly and put another pin underneath. Another pin. Yeah.
The second is, how do you decide your slope? Because your native slope, how do you
check? Take 3 degree slope for two reasons. One, I do not want the reversal of the slope. That is one thing. And second thing, majority of our blades are going to drive up superiorly. This is going to be, as we know, it is always going to be a strong bone here because the weight bearing bone. So I tend to keep it for 3 degrees because our blades are not as reliable. So I tend to put 3 degrees.
So you don't want to get the native slope. You want to get almost perpendicular or 3 degrees.
But it will come down to the native slope. It's not. I just don't want a reversal of the slope. In the meantime, I feel with my pottery, my intercondylar eminence. Sure, I do not go too far medially or too far laterally in this case. I mark it with a pottery to delineate my vertical. So it's the vertical cut which is going to happen first. I usually go straight without putting the saw on. Make sure I have proper access to the posterior before I start cutting it. Okay. I just make sure I'm there, and I make sure that my blade does not face laterally of the posterior. I do not want to damage any part of the ligament. That is the vertical cut. I take out reciprocating blade and just put it by hand in its place so my horizontal cut does not extend laterally. Just a guide.
Now, Satish, is there any inbuilt slope in the implant?
No, we have to put it in.
I have not got it right. So the native slope is around 7 to 11 or 7 degrees in east.
Okay.
Right?
Sorry?
No, the native slope of the tibia is around 7 degrees.
Yes.
So this is posterior cruciate is there.
Yes.
So you want to replicate whatever slope the patient has already.
Yes.
So if you are doing 3 degree and if it just keeps off and then it results in a native normal 90 degree,
Yes.
then there is no slope inbuilt. So how do you ensure that you are taking a slope?
Okay. Before we go there, I'll just show you what we have cut off as well.
Yeah, I've got a beautiful
This is what the Oxford guys call a biscuit. Now, if you look at the cutting, it seems adequate. Posteriorly, there's hardly any bone which has been taken off. Anterior, because of the osteophytes, of course, is going to be appear. It is going to appear bigger. So my instrument is still intact. Let me see how much of a cut I got and how loose or how tight this is, because we have option to take more cut if necessary. We start off with these spoons. These things. We have to be clear that our menisci are still intact, so it may appear tighter now compared to when the menisci goes off. So let's see whether this goes in or not. This is appear very, very tight. So I think I will take.
How easy or how tightly does it go inside? The feet?
Yeah, with 2-3 fingers push, it should go in, but it's not going in, which means posteriorly it is still too tight.
Because in Oxford you mostly rely on the feet.
Yeah, it is the field, just the 2 finger. 2 finger it has to be in Oxford. So let's get the tibial stick back again. Like this.
When you are fixing the tibial disc at the lower part.
Yes, just putting another pin there.
No.
Put this in front.
Do you do any cuts at the ankle level to improve the slope?
We can. I've not done it yet. I've kept it at 3.
No, that is your.
So I brought that down slightly. Okay. More, please. That there as a protection.
So you are taking another 2 mm.
Remove the pin, please. Now let's try number 7 again. Okay. That's sitting well. Not difficult. And once the meniscus comes out, it will go.
So totally how much thickness you have removed on the medial side?
Total with the cartilage and everything, this is size 7. And the amount of bone I removed is about between 3 to 4. Or like 3.
Okay.
So it is sitting in properly. Now we are going to take the distal femoral cut. This is the handle. This is the handle which comes. It's a very nice, easy to use piece of instrument. Put it in, lock it into place, and this is our distal femoral joint. Now the cut surface here has to sit flush with the tibia in full extension, and then we put in the 2 pins superiorly. Remove the handle and we get a distal cut now. The normal. Okay. Remove both the pins now. So when I show you the amount of, this is the amount of bone I've taken away from the femur. So
do you measure that?
Essentially just the damaged cartilage. And if I turn it over, there's a very thin layer of bony surface.
This thickness totally relies on your tibial cut.
That's right. That's why the tibial cut is done.
So you don't measure anything.
No, we don't measure it.
Now you check the gap.
Yeah, we can, but yeah. Let's see the gap in extension. Sitting in well, I don't think I'll have to revise the distal cut.
Okay.
It stays in extension. It looks good. Now we do the rest of the preparation for the femur. We've already taken off the osteophyte. Putting osteophyte here. Suction. Now this is the pre-cut thing for the femoral jig. This is the size 2, and this is the try size 1 and 4. See how they fit.
What is your steps to select the size?
This is just going to be a trial and error method. I'm just going to put it on, see if surface better. I don't want it hanging, overhanging. At the same time, I don't want it undersized as well. So let's try with a size 1 first and then go up.
You don't check the
flexion gap and extension gap before taking the femoral cut and then add shins and then take the cuts?
We did check the flexion cut.
No,
Flexion gap
flexion
there.
is, but you didn't take it with the extension for adding whether you have to add any detail or femoral shim and.
Sometimes I do. If I feel with my cut is going, if I've taken too much of a cut, then of course I do. But in this case, we've taken very minimal cut, which we had to revise by 1 degree as well. So that's why I didn't check. We check in this case. So, okay, I'll try with size. This is size 1, size 2, please. Size 2, female. It covers the condyle even better. Okay. I think I'm going to go with a size 2. Looks very good. Held by 2 oblique pins. Hello.
What exactly you are looking at when
I'll just show you once I put in the pin. I'll show you. Let me remove this. The flat surface of the give me hand as well. The femoral shape, if you see, this is for the condyle, the posterior part, and this is for the distal part. This is the cut we have already taken.
Okay. Any landmark you use?
Yes. So this has to lie completely flat against the cut surface, and this has to be in touch with the condyle. Now, I want the cut surface to be covered, possible, not cut too much. Plus, I'll check there can be a jog of movement in a rotational aspect as well. So I have to err on the side of external rotation. I won't want it internally rotated. That is. Okay. Okay. So this is a well fixed take. Now I'm going to take the posterior cut and the chamfer cut. Yes, I'll take that. Yes. And give me the impingement. Then I take a gouge. This is for the well teaching of the tip of the plant, which should actually just sink into the bone then.
Okay.
And then I make the 2 love roots. This is essentially our femoral preparation over. This is a posterior cut. And this is from the chamfer. So minimal bone cuts. We are going to clean this up and make sure we can take away as much of the meniscus as possible before I go on to protect the. This is the right way to try to get to the meniscus. as much as. Just bear with me for a second. The view difficult to get when I'm doing this. Now I've got one of the.
The mostly is not an application.
There it is. Okay, that looks good. So now I'm going to be putting a trial. This is the handle for the femoral implant. It holds the implant well from both the sides. There are 4 prongs to it. As you can see, these are the lugs. And the tip of our femur is well into the joint. Factor now, if necessary, we can use this. Shows the, again, so we go back to our size 2x7. Okay, remove everything. Sorry. Now see, going in without any hassle. Let's check it in extension. The extension. You can see the leg is in neutral, it's not imbalanced as such, and it's easily in full extension. It's not staying in fixed flexion deformity. So there's good flexion, good extension. Now let me see, do I need to use this one size bigger? Unless we do it, we won't know it. Okay, show me size 8. This goes in, let me see whether the knee goes to valgus. It's something I don't know. I'm not trying to make a valgus knee. Neutral is what I want, and plus one or 2 degree of field joint working is what I want. I don't want it to tight the joint because that will take it into valgus. And then promoting the fusion the valgus of the lateral joint. So I'll stick to size 7, which I found was good. Okay, now let's remove this femoral component.
Femoral osteopathy, we also look at osteopathy for that.
Posteriorly, I just put one on the tibia. I pushed my osteotome with my hand.
No, the knee is there.
Yeah, that's all I did. And I can't feel any more because my assistant lifted the femur, lifted the finger joint around, and it's perfectly fine. No osteophytes there.
No, medial osteophytes. Because
Even osteophytes again can be felt. The foot is
on the medial side.
yeah. What I do is I use this. There's an instrument feel for that as well. The right angle. This one. Yeah. They got a nice hook. You can go there. You can't feel it. Second thing, another thing you can do is you can put in your size 7, try to go pick out that stick, whether it's going too far posteriorly, you'll also know that because we don't want it to go too far back, and then you can feel for occupied. And if it is there, you can take it out, but no need to go madly and look for them exactly. This is for me. Okay. Now, when you open the scope, you have to make sure it covers the bone completely. We don't want the underside. Tibial base plate, underside is more likely to stay in. We want it to rest on good cortical bone. And same thing if it is oversized, it is going to irritate the MCL. And that will be a cause of pain later on. Both ways we have to make sure that the thickness, the width, medial to lateral is just perfect. That we need a clear view of the bone. Take away any have to go overboard, putting in a distractor. So that critical section medially only as much as is necessary, nothing more than that. Now we'll go with the
size based on the jig what you
the button, the biscuit which we took out, we can put this on top of that and check as well whether we are undersized or oversized. That always gives us a good biscuit there. What we first taken out. So if I put this on it, I can get a very good idea whether I'm in size 2 or size 1. This is a good guide. It's always a good guide. Just turn it around and see.
And
size 2.
Dr. Satish,
Just right angle. It has markings as well.
Okay.
Which is going to guide us. Make sure that we were the right size. Yes, sir.
And we can see your gap here very nicely. And there is some posterior osteophyte or a cartilage, whatever. Do you remove that now or don't remove that? No, posterior. Okay. Okay.
For that 2 months. Then I might use a curve osteotome and make sure I take those out. But in this case, not really. Okay, let's get the table preparation. It shows us, yeah. Okay, now this is the size 2 tibial base plate which has these prongs, the sharp prongs which go into the bone. So we align this. So we align it with the cut surface there and lightly tap it in. We don't want it to go too far. Perfect. Looks good. Now, whether this is in the right place or not, what we do is we use a laminar spreader. There are these built-in small holes in the base plate. So we put that there and the top one goes against the femur. And again, you can see the gap beautifully there. Now, we'll take the right angle, which I showed you earlier, and see from posteriorly. I can see for the coverage there. If I am too far behind, too much anteriorly, just adequate bone posteriorly there. Okay. This is a guide to where my tibial base plate is going to be. Then I use this goes on straight. Okay, we leave that there. Now is the time to make the slot for the heel, but then I want my blade, the reciprocating blade, to make a initial mark. No, give me Lightly, you don't want to go too far deep, so make sure you got good control. Just to store the bone. Okay. Then comes our, this is known as a tibial scratcher. So I put it in, take it all the way back. Okay. And then bring it forward. So the cutting side is in the front, in fact. The cutting sharp blade is in the front. So taking away, making sure drop is nice and sharp. All the extra bone is out. Now when I remove this, you'll be able to appreciate it much more. So this, make sure all the loose bone comes out. There. Okay. Now the next step is of course to make sure I can easily put in the heel jig. It goes in very easily. I'll again do it with the base plate in place. There. Good. Put in my heel, and this is the punch hammer. Start punching from posterior, bring it out anteriorly while yeah. So that's sitting completely. It's not lifted anywhere. So my drop is complete. My tibial preparation is over.
The depth is gone.
Yeah. Now I'll put in the tile. Again goes in my femur. Give me the hammer, please. Okay. So again we put in 2 by 7. That goes easily. Remove everything. Yeah. Yeah. Then inflection, extension. You won't be able to see completely, but that's movements. Patella stays in its place. Doesn't get it placed anywhere. I'll make couple the femur just for cementing purposes and wash out, give my local injection and cement the joint in place. Yes, punch. And give me a drill bit if I can. Okay, yeah, okay, give me a drill bit. This is a very nice laminate spreader which they have with sharp tips. So it holds the tibial plate and the femur apart very well. Okay. I like to make a couple of holes in the femur just for extra cementing. I don't want to make too many and weaken the bone either. Okay, that's about all.
Tibia, do you make?
Sorry?
Tibia, do you make that kind of hole?
Tibia, because I made that big hole as well.
Enough.
And the heel is there, and I don't think I need to make too many holes. Not in this bone, because it was not particularly very sclerotic either. So I don't need to. Okay. Yeah, show the implant sizes. Check. So we're using a size 2 femur, size 2 tibial base plate, and the insert is 7 millimeters. Okay. Open the implant, take the cement, and give me that injection which we have prepared. Okay. I like to inject all my joints. There is sensor tape, 5%, 20 ml, 20 ml normal saline. There is the antibiotic 1 Zostan and steroid as well.
What is
Kenacort.
Post-operative relaxation protocol?
Exercises from today evening.
Okay.
Knee exercises, ankle exercises, static quadriceps from today evening. And then the patient will continue to do on his own every hour as far as they are awake, and from tomorrow morning full weight bearing walking, either with support for the first time, whatever support is necessary, and hopefully by tomorrow afternoon they'll be able to work unsupported as well. If they are confident, their balance is good, pain is well controlled, then they can walk holding someone's hand or walking unsupported as well. And my patients normally discharge will be day after tomorrow morning. Give me a size 18 needle, please. I'll just inject first and then wash and then we'll do. So yeah, after I wash and yeah. Okay. Implants are all out of place. Yeah. Sure. Can you give them? These are the three implants, as we mentioned, that's the femur, right? With the two lobes. Okay. Then of course we've got the tibia, which we prepared. As you can see, it has a receptacle for the plastic. Plastic is of course, this is the part into the base plate, and it is a flat surface, yes. Absolute flat surface as compared to the Oxford. Yes. The needle, please. I'm just going to inject first, then wash up, and then straight away select. Okay, let's wash out now. Very small. Okay. Okay, start the cement mixing, please. Show me the spikes. We have reflectors. One second spike. Where is the second spike? Okay. And the hammer. Before. Okay. I like to cement the tibia first, always. Okay. Because then I can take away the posterior cement if there is any. I don't want to leave that behind. Makes sense. Check that out. Sorry? What was that?
Cement, what cement you're using?
We're using a CMW 1 cement, and normally 20 grams is enough, but the company never bring 20 grams.
The cost wise almost same.
Almost same, yeah. So I think it's just for the inventory. Sometimes I put the cement on a
The 20 gram comes with only with an antibiotic.
Yeah. I don't want to load up too much cement posteriorly because then it's going to come out posteriorly as well. I like to pressurize with my fingers as well. Plus, is put on cement behind the implant, so that's plenty of cement. For I'll be busy taking out cement. Please. I bring out my yes. Yeah, keep it. Okay, fine. Take away this first. Let me take away this. Yeah. Take away the cement posteriorly from the middle aspect as well, so we get a good view. Maybe then full black. Okay. Come on. Once again. Yeah. Okay. That's better. Good. Give me small gauze. How many gauze, please? No? Here. Give me small gauze, please. Just clean it up. Take it away. Now it's oh. Oh, that's fine. Okay, let's do the femoral cementing. Usually I take some cement in a 2 ml syringe, just put it in the lug holes first. Fill that up with cement and then do the circle. In the syringe. And then spread out some cement because he's going to put it on the implant as well. So they don't need too much on the surface. Okay, give me the circle. Chemo. Okay. Now this goes into place. Good. Fine. Take away the extra cement. The course much easier compared to the tibial surface. Okay, let's hammer it in again. Good. Take away the rest of the. Okay, up here. Okay. Give me the pencil. And we will say. Size 8. Size 8. I'll do it with that. Okay. I can do it with the size 8 and pressurize it properly. Hold it there for a minute, let it get pressurized properly. I will be putting a size 7. This is just for good pressurization of the cement. Cement coming out at the stage from below the tibial implant. So that's why pressurizing with one size bigger is a great idea. The implant will be well cemented.
Okay. Knee is in 30 degrees of
20 to 30 degrees, yeah. So I've just taken off the whole procedure, extra osteophytes from along the medial condyle. There is a little osteophyte here, nothing much to write home about actually. Just because we see it, we take it, otherwise it's not going to come in the way in any way at all. Live or bone there, nothing major.
Yeah, the implant is very much beneath it. So
Yeah, yeah. It's not going to cause any impingement there at all. Nothing to be done to the patella, no. Patella is okay, as I said, there are no osteophytes, no overhanging osteophytes, and we've seen there is some fibrillation of the cartilage, but we don't have to touch it at all. Okay, any questions at this stage?
almost audience, any questions you know? Anybody?
Yeah, I've seen it when I put in the trial implant.
So
You'll see it on the X-rays as well, because I don't think you are going to get that great a view throughout, but we've seen the congruency of the femur and the tibia. This is not, alignment is what I want, yeah. I don't want to overcorrect it. One has to hold oneself back there, because you go into valgus, you'll be very happy looking at it, but then this is promoting the lateral joint degeneration earlier.
Since Satish,
Yes.
Since you are doing both Oxford and
yes,
yes. Do you randomize or are you doing any study in your cases or
no.
how do you select?
How do I select which one to do? I do both. Both of the companies have major issues about implant availability. So that changes my mind sometimes. I do both of them. The only thing which comes to my mind against Oxford is because there are incidences of dislocation of the bearing surface, not immediately, but the first dislocation can be a year or two down the line at all. And then that gets you thinking, why did it dislocate when it was a perfectly functioning joint for 2 years? But that's what I went back to the literature, read the papers. All surgeons have had that experience that it may dislocate, does not dislocate immediately.
Any specific reason?
Nothing has been cited. It is just some rotational movement can dislocate that implant, and if it does dislocate, the bearing surface does dislocate, which means another surgery. another surgery for the patient, and loads of explanation coming in from the doctor's side, why it happened. And then the next question they ask is, why didn't you do a total knee replacement at the first go? And this is faced by all surgeons. Not that the incidence is high, but in your career you will come across one or two dislocations. And because the patients are so comfortable, they do all activities, including squatting, sitting on the floor for feet, plus offering namaz and everything. They tend to do everything. So it has to be a rotational movement from squatting position when they stand up. That is what causes the dislocation. But again, it puts the surgeon on the back foot.
So if both implants are available, any selection criteria you fix it for either Oxford?
I think I'm going more and more towards fixed bearing. Yeah. And as you can see, it's a very easy surgery, minimal instruments required, and very quick surgery as well. Not much bone cuts. We don't have to touch the normal ligaments. Most of them we don't even touch them. We don't need to see them. We don't stretch them. So most of the recovery is fast, safer, faster. Pain relief is good. And the hardening surgery, and I know this will never dislocate. Very easy for the staff in the OT as well. Not getting used to the other position. 70%? Yeah? Not that yet. Okay. Let's see. Now, do I need to take any more? 50%. I'm going to remove this. Give me a wash. Give me a hearty person, please. Yeah. Okay, once again, please. There, which I loosen up. Take that out. Yes. Yeah. So this is hiding there. So this is the right space to take that piece out, give me a wash, and then we'll put in the insert. Okay. Now I have on the cement out. Give this insert. Okay. Something is holding us back. I have to find out that. Okay, give me the. Sometimes water is nice. Not there. It's a little bit soft tissue there. Right. Let me just take that soft tissue. Yeah. Hold on. Let me just take away bit of the hanging tissue.
Check the size of income. Is the 7 or is 8? Not logic. All these things have a really right demo. So, also case.
Yes. Done. That's what I've been checking for. There is no overlying bone as such. Nothing that is holding it in place.
Can you?
Okay, let me just make sure. Make sure the size is right again. Size 2 7, yeah. Size open and focus. Okay. Maybe looks okay. There is
There is something in the posterolateral aspect which is preventing the infection.
it is not dominated from the front side, but there's nothing that maybe I don't know when
It is not locked in front. Maybe it is not locked in the posterior also properly. Posterolateral. Is there any rasp to just rasp the lateral aspect of the bone?
Here, yeah, I think that the insert is over, I think we can come back also. Okay. We will tell you what time. Yeah, yeah. Shall we proceed? Yeah, good. Yeah, yeah. Will be over in a minute. I don't think it's not taking much longer.
Thank you, Satish.
Thank you.
Thank you.
Any questions on early opportunity regarding the role of arthroscopy? Dr. Prashant. before proceeding to inauguration, we'll have a discussion on case after the yesterday by Dr. Rajesh Mandokar.
Yes. Yeah. So this is the preoperative X-ray, and you can see that there is medial joint completely collapsed with bone loss, weakening osteophytes both on the femoral side, tibial side. As Dr. Rajesh explained about the gross opening on the lateral side. So like a proximal metaphyseal varus is there. So it's posterior osteophytes, petulofemoral osteophytes, severe or tricompartmental severe OA with medial collapse with bone loss. So it's more of, it doesn't, it's not like a simple OA knee where you have to, here you have to go and address so many issues. We saw that yesterday in the live surgery. Yes, Satish.
We changed the insert, and then when we saw the insert we were trying to put in, it has a damaged locking mechanism.
Oh.
So we just discarded this and changed another one. We'll just start in its place without handling.
So luckily you had one more 7.
Yes, yes. Okay. So now, if you want to see the alignment, great.
Excellent.
Full extension.
Once again.
Full flexion as well.
Can you just
Good call.
little balance and then
Yeah. Okay. Okay. About 1 millimeter of opening of the joint.
Yeah.
Yes. Nothing too much. But a well aligned knee.
Yeah. Very good.
Great. Thank you.
Very well demonstrated.
Thank you. This is number 120.
So we saw an excellent demonstration by Dr. Rajesh Mandokar. Now we'll have the post-operative.
To say about it, the alignment of the knee is really good. The sizing of the femur, the offset which has been produced, removal of the entire osteophytes, the posterior osteophytes, which are very important. You have to be very, very careful in getting that done. The medial defect which was there, the tibial defect, both grafting and fixing screws, and that should be protected with a stent. So the patellar osteophytes have been removed. So obviously it is a very well executed totally replacement. Most important is the getting the knee straight and management of the bone defect. So if the bone defect is more than 5 to 8 millimeters, it has to be managed, and if there is a toggle in there, definitely it has to be supported adequately by the stem, a short stem.
So this was, as you can see, we have put in a size 4 femur, and that was perfect anterior-posteriorly, and still it is somewhat narrow. Given the adequate lateralization, you see a medial femoral underhang. So that is the thing. We could have taken a 5 tibia, but then we undersized to 4. So there was a question with the 4 femur, you can take a 3 tibia. And that might have taken care of that small bump there. But then my apprehension was that the medial bottom of the tibial plate would have almost been in line with the medial cortex of the tibia. And my apprehension at that time, though, that would have made the surgery easy and faster, my apprehension was that if I take out that much of bone, triangular, I may not land up with an over-released and we have a laxity on the medial side. So I think I would just write on the ligament balance side. You see, it is coming up to here. This has to match here. So if the one size smaller comes to here, that would have almost tended to notch it something. So, and then once it was all balanced, I can concentrate on. On the other side, this side you had seen the component is fine, it's little posteriorized. We used a stem because there was a big defect here. In fact, this defect took us by a surprise on the table because when we looked at the APN lateral view, it did not look like. We have done sufficient clearance. If you remember from the pre-op X-ray, there were huge osteophytes there. There is sufficient clearance, and the joint line looks fine. The patella looks okay. There is a very small osteophyte left here. Well, it wasn't easily appreciable. So I would welcome any critical comments because it's also a great learning experience to sit together and assess the X-rays after the surgery. But I have a suspicion that the long leg weight bearing X-rays are going to be fine. Although it's not bad on the other side either. Gen 2 was done. That the femur was in slight valgus tibia was in slight varus. But that was because of the bowing. Now that bowing is not so evident here. If you see the pre-operative standing X-rays, there was a good, bowing here, the extra-articular deformity. And that's why on the table I was trying to show that when we made it perpendicular to tibia, the cut was looking almost like this on the table. Gradually we did the releases and the reduction of osteotomy, some releases, and then that's how it. Very often in a situation like this, you will find that the joint space is narrow here, and that is not at all uncommon. That's because we know that in extension, it is the posterior part of the semimembranous and the posterior medial structure which are tight. And in flexion, if it is showing narrow, it's either because of the PCL layer or because of the anterior part of the MCL. I don't think anterior is ever under release. So it's usually if you have left the PCL there. So the point which I made was I like the insert which does not have a box or a peg or something like a UC or a tube kind of insert, because then we can do this clearance very well. So I always sort of take a curved osteotome, I shoot the cortical ring size, from there lift up the osteophytes, erase the capsule with the mop. Then it becomes easy. In fact, there was a visitor from UK. He went back and told a lot of people that I just saw this technique where they do a posterior clearance. Because you see, you have to restore these recesses on the medial and lateral. If the capsule remains adherent to the posterior medial and posterior lateral side, the patient will not get flexion. So that's again something which needs to be done. We need to get the through these. But I'm very happy to take any.
Well aligned knee. I would like to really, because yesterday we were talking about the alignment, how much of traction, how much of most operative alignment we need to know. Even though there is not a full length X-ray, but here in this X-ray it's a very well taken X-ray. We can appreciate the alignment is almost 0 degrees. So this should be the target, and it should not go more than this or anything. So it's like perfectly aligned knee now, 0 degrees. And I think it's reasonably well balanced in a cruciate retaining. Even though the insert is a deep dish insert, but this patient will have a very good flexion extension movements. So well done X-ray and well done procedure, and X-ray is fine.
Another thing I would just like to comment is, whether it's a UKR or a TKR, if you Oxford, you put in a rod. So in today's fixed bearing, you don't have to put a rod. Oxford or this, if you look at this peg and how it aligns with the posterior, that tells you that your entry has been good. Because if you enter it like this, you will extend the femoral component. You enter like this, you will flex. So it's not only varus valgus that you are deciding by your intramedullary rod, but also the flexion extension of the component. So one way to cross check that is, with this peg, being straight in line means that, and you should carefully look at the preoperative X-ray and mentally think where you should enter the condyle in order to be in the center of the femur. So get used to looking at the X-ray mentally or doing that. You see, if you want to enter here, you would have to enter somewhere here. But in a valgus, you'll enter far more medially. So you should always take a look at the alignment. So the point which I was trying to make was, if you look at this looks like an ordinary valve. We are taking a cut here should not leave. So I had an option to take a deeper cut. That would have done a few things. It would have reduced the defect. It would have maybe even allowed me to put in a smaller tibia. And also the fact is that it would have released everything quite well. But our theory is that you should try to take have as much of as large a size of tibia as possible. And look at these osteophytes. These were the osteophytes which I showed would give rise to internal rotation of the, because this osteophyte on the medial side will lead to internal rotation when you are putting 3 degrees. But this doesn't look like the defect which we encountered on the table. That was somewhat a misleading feature.
Scleros, which I was struggling yesterday to get into to make some drill hole. Because of the sclerosis, that overlapping is not very obviously visible. That is why it got missed here. And one more small tip I will suggest is always you ask your X-ray technician to take a true lateral view, because that true lateral view, even if you miss on the AP view, in the lateral view, this kind of big defects you can appreciate very nicely. So a true lateral will always help. So make it as a routine to take that.
And anytime there's lateral subluxation and this much of opening, if you cut more, you will land up with a very big insert. So I was told right in the beginning that we don't have an insert bigger than 10. So I was anyway very cautious. I would normally take a very conservative cut, but once you don't want to land in a situation where you don't have the right implant.
Regarding the reduction osteotomy, important thing what I would say is establish your flexion extension gap with spacer. And when you are trying the trial and when you are trying, you see that it is not covering and whether I can compensate the defect by just undersizing it. That is the time when you take it, as I was mentioning, that you will lack the NCL and then that will result in a medial lag, which is not at all good. So you have to decide before, and before releasing the medial side, it may be a good idea to do a reduction osteotomy, but to a certain extent. But once you have done that and you have got your flexion gap and extension gap correctly with your MCL balance, then don't try to do anything beyond that after you have done it.
That's an excellent point. The point essentially here is that the reduction of osteotomy is done to balance the soft tissue, because to reduce the medial tightness. So once you got the balance, after that the only thing you might land up with the imbalance, and then the medial collateral may become lax.
Next is our inauguration session. We invite all the dignitaries to come forward to the dais. I welcome our chairman, Professor Dr. R. Shivakumar, our head of Department of Orthopedics, Professor Dr. Chidambaram sir, Indian Arthroplasty Association Secretary, Dr. Raj Kumar sir, and I welcome our chief guest, Professor Singaravadi sir, TNOA President-elect, Dr. Rajesh Malhotra from AIIMS, Delhi. Welcome Paediatric Orthopedic Society President Dr. Veeran Ganjwala, Dr. K.N. Subramania, immediate past President, Tamil Nadu Arthroscopy Society, and Dr. Shoma Shekhar, our Organizing Secretary. prayer is life without power. Let us all stand for the prayer song. Now I welcome Dr. Hema Shukman, our Managing Director, and all the dignitaries to come forward and light the lamp. Profusely elated to invite Professor Shivakumar, Organizing Chairman, to present the welcome address.
Dignitaries of the day, or for the day and of the day, respected chief guest, Professor Singaravari, who is now the President-elect of Tamil Nadu Medical Association, which is the second largest association in India, following Uttar Pradesh. Respected President, Pediatric Orthopedic Society, India, Dr. Kiran Ganjwala, who has come from Ahmedabad. Respected Rajesh Malhotra, Head of the Department of AIDS, All India Institute of Medical Sciences, and with the past President of AUA. contacted Dr. Rajkumar from General Hospital. He is holding the post of Secretary Indian Orthoplasty Association. And Dr. KNee, who is the immediate past president of the Indian Orthoplasty Society, Dr. KNee. All the faculty from all over India. I wanted this inauguration function to be short and sweet. So let us don't think that all people will be speaking during the inaugural function. So I think I will be felicitating them. Dr. Rajesh Shah, Dr. Satish Patel from Ahmedabad, Dr. Vidyasagar, Dr. Prashant, Dr. Hitesh Shah, Dr. Harish, Professor Alivathan, Professor Shubhi Shivakumar, Professor Danapan from Madurai Medical College, Professor A.V.S. Shanvanathan from A.V.S. Hospital, Madurai, Professor Rajkumar from Punjab Medical College, Dr. Suravanam Samandi from London Orthopedic Specialty Hospitals. We are very, very happy to welcome you all as faculty and Truly, the knee 360 was planned in such a way that it covers all the dimensions of the knee, right from the geriatrics to pediatrics. This was the evolution which we had, the team Preethi we had, so that it covers the joints. So we would have the focus on the joints, and that's really good. And what the recent developments which develops the joints, arthroplasty. At the same time, whatever the other aspects of the knee, like trauma, scopy, and also the pediatric orthopedics. So this coverage has been done in this knee 360. We are really happy and proud on behalf of Team Preethi. I think all the consultants also have come here. And, we welcome you all, delegates. We welcome all the delegates, the aspiring delegates, the young consultants who have come here. Definitely, this CME, this knee 360 will be very, very good. A short briefing of the Preethi Hospital. Preethi Hospital, since its inception from 1997, we have been into the academics. And even yesterday we were telling we have had a live demonstration of the knee with the weights and long back 12 years before itself. So we have been into the academics, and so to say, we have the DMB orthopedics past 4 years post-doctoral fellowship from Benjamin University for past 10 years, and the Department of Orthopedics is well run by Professor Chidambaram sir, who is here for the days, and all the senior consultants, Dr. Somshekhar, Dr. Subhi, Dr. Dr. Bharat, and all the other junior consultants also. So with these few words, I wish that this knee 360 degree to be a grand success. It has been so. There are so many registrations. Maybe we didn't expect so many registrations. Somewhere around 148 to 50. Although the operational crowd is around 100, but 150 registrations. The colleges welcome, and I wish you to utilize the opportunities and all the deliberations that have been delivered by the faculty be useful to you in the future. Thank you very much. Thank you. So 2 presentations we are not able to do yesterday. Let us do a presentation of the chief guest, Dr. Singaraveer, who is a faculty, and the president-elect of TNOA, and also Dr. KNee.
Now we invite Professor Singara Vadivel sir for chief guest address.
Respected senior people and dignitaries on the dais and off the dais, very good morning to you all. Professor Shivakumar said that because of lack of time, we are not going to have. But as chief guest, I think I have a little liberty in talking 2 minutes. And at the outset, I wish to thank Professor Shivakumar and team for having invited me for this wonderful CME. So Knee 360 is a very unique program. We started Knee 360 and Knee 360. And as this, the uniqueness of Dr. Shivakumar, this also is proving to be with the gamut of faculty and so much of scientific deliberations which is happening. So to be very frank, the acquaintance with Dr. Shivakumar, I never had before because we never studied together, we have never worked together. But somehow the alignment which happened, it has happened because of the same frequency, the academic pursuit which we all had and Dr. Shivakumar had. When he said that he is going to retire from the government service, I really felt that the service is going, that the students are going to lose one good teacher and how much applause it is going to be. But he has never failed in his pursuit and he has always been continuing his academic pursuit and the passion for teaching and imparting knowledge to all the youngsters. Even after having started and growing to this extent, he continues to do that and he has got a lot of programs, not only 1 or 2 programs just for the namesake, but he is continuing to do a lot of programs. I really wish to congratulate Professor Shivakumar and the entire team, Madam Shivakumar and other people who are always here with all the academic programs, whatever which is happening, which is very nice to see. So I wish that more and more such programs will continue to happen in this part of the state and the country and spread this knowledge. So thank you once again and I wish all the success for this CME and coming forward. Thank you.
Now I welcome Professor Singara Vadivel sir and dignitaries to issue the certificate for our past fellow doctors. Postdoctoral Fellow in Arthroscopy, Dr. Ajay Gautam. Postdoctoral Fellow in Arthroplasty. Now I invite Dr. Somashekar, Organizing Secretary of the CME, to wind up this inauguration session by giving vote of thanks.
Good morning, teachers and my dear friends. My pleasure and honor to give vote of thanks to this August gathering. To start with, for any conference or a CME to be successful, I feel 3 important things. One is the teachers, the other one is the delegates or the audience, the third one is the organizers. To start with the teachers to spread the knowledge, because without them, they will not be able to learn the new techniques or the methods of doing surgery or what are the small pitfalls that we encounter. They'll be able to solve our pitfalls during that CME. So first of all, I'd like to thank all the teachers, especially Professor Geriatrics, Dr. Rajesh Malhotra and Dr. Satish Patel sir, who did live surgeries, and also the senior faculty, Dr. Singara Vadivel sir, Dr. Dhiran Ganjwala, Dr. KNee sir, and all the teachers who are with us to share their wisdom, experience, and knowledge with us. My sincere solutions to you all, sir. Second, delegates to receive the knowledge. I would like to thank all the delegates who have come from different parts of Tamil Nadu. Hope this CME benefits all. And the third, the most important one, the organizers. We are the bridge between the teachers and the delegates. So I would like to thank Dr. Shivakumar sir, Chairman of PG Hospital, Dr. Hema Shivakumar, Managing Director, and Professor M. Chidambaram sir for their continuous unwavering support in this endeavor. I would like to thank my dearest colleagues, Dr. Prahlad, Dr. Sudhir, Dr. Vinod, Dr.
Bharat, Suri, and Dr. Balaji, along with all my fellows who are there to help us out. Last but not the least, I'd like to thank the hospital administration team, Artificial Peter, and the Deputy Johnson and Johnson for supporting this event. Thank you, one and all.
Let us all stand up for national. We will start our second lecture session of the day on pediatrics and arthroscopy. I request Professor V. Sivakumar, Dr. Ashok Kumar to chair the session.
Good morning to all. After a nice demonstration of unique toddler knee replacement, we are moving on to the next session of pediatrics arthroscopy. So I call upon Dr. Vidya Sagar to talk on coronal plane deformity, physiology and rickets.
Everyone, and I'm happy to be in Madurai. I thank Dr. Shivkumar and Dr. Prahlad for inviting us and being such a nice host. So my topic is coronal plane deformities in the knee with rickets, because rickets is quite extensive. I'll just touch upon the nutritional and then go further. Yeah, so we all know the physiological development, how the changes happen in the knee. Initially, about till 2 years, there is a genovarum which corrects and then becomes genovalgum from 2 to 4, and then normalizes to adult value almost by 6 to 7 years. And basically, we want to know what's physiological and what's pathological. So X-rays later, but clinical examination any symmetric genu varum within 2 years. And then the cover-up test, we cover the distal part and see the tibiofemoral, that white line which are drawn there. If that is valgus, then it's most likely to be physiological. This is the Drennan angle which I have tried to draw here, metaphyseal-diphyseal angle, which should be less than 11 degrees. This is the same result. Girl follow-up, severe genu varum, but we waited and watched. We corrected in about 2 years' time. It was symmetrical, MD angle was less than 11, and cover-up test was as shown in the last image. So now on the right hand side is a pathological one, where we see that cover-up test shows that there is a virus or a neutral alignment sometimes. The Drennan angle is definitely more than 16 degrees. This is again pathological because it's asymmetrical and it's way too much in a 3-year-old child. So whenever we have that metaphyseal angle more or a cover-up test, neutral or virus, we should suspect pathological bolus. Coming to physiological knock knee is common between 3 to 7 years, and it should be again symmetrical, and intermallar distance they call less than 9 centimeters, but depending upon the age it may vary. Whenever there is asymmetry or extreme genu valgum, we should look for other causes which is not physiological. So I will not go into causes. And assessment wise, we should take a good history, early walking, onset, progression of the deformity, any trauma or infection in childhood, and family history is important in especially hypophosphatemic rickets, as well as dental abscess history. On general physical examination, you look at the weight of the child, the BMI, stature of the child, as in the second case of Smith's dysplasia. He's 10-year-old compared to his father, you can see the stature. This is a severe genu varum with obesity, very high BMI, and I'm showing the knee laxity on the right hand side associated with this blobs. Again, we quantify intercondylar or intermallar distance and check the torsional profile also, so that it will be useful for when you go for surgical correction. That's the great test to see the femoral torsion, and this is the quantification of genu varum and thigh-foot angle to see for tibial torsion. Now coming to rickets, we get windswept deformity also sometimes, which is a combination on either side. So rickets is mainly the manifestation of defective mineralization, secondary calcium and phosphorus imbalance, affects the growth rate. Osteomalacia is one which affects the matrix. Infants and adolescents are at risk because they have increased demands during the growth period. This slide basically shows the histopathology of a normal and rickets spices. So as we can see here, the number of hypertrophic chondrocytes are more, and they fail to undergo apoptosis and secondary mineralization because of the calcium and phosphorus imbalance. That's what leads to flaring and widening of the pies, cupping, lipping, and all the changes we see in rickets. This is a girl, 2-year-old, who has rickets. See the frontal bossing, the pot belly, widening at the wrist, and then genu valgum. This child has ichthyosis, dermal problem, because of which he had secondary vitamin D deficiency. The middle child has hypophosphatemic rickets. You can see the dental loss of enamel. The last one has a similar windswept deformity. This is classical, especially post-COVID, inability to get up from squatting position, which indicates proximal myopathy, and it's a clinically very relevant sign. The same child waddles. And that last video was sent by the mother. Child almost has a carpal spasm, if we see, and she had calcium of about 4.8 when we checked her calcium level. Vitamin D was about 3 or something. So we should look for that. And this is a case of vitamin D receptor dysfunction. Alopecia should be seen in the family. This is typical in this such cases. And another case of familial hypophosphatemic rickets. This is the case of renal rickets. We see that nephrocalcinosis with typical windswept and facial widening and rickets changes. So I'll skip the signs and symptoms in infants because mostly pediatricians handle that. What we basically see is generalized bone pains, gait changes, weakness in squatting and climbing stairs, and then deformity in the lower limb. And non-osseous changes would be carpal spasm, delayed dentition, then dental abscess, myopathy, seizures rarely, We had a child who had bilateral neck of femur because of seizure sitting in a car because of hypocalcemia. So IIP recommends vitamin D level of 400 to 600 based on the age, and vitamin calcium elemental from 200 to about 800 again based on the age. So what IIP considers as a vitamin D deficiency is anything less than 12 nanogram per liter or 30 millimole per liter is defined as deficient. So we evaluate after suspecting radiologically, get the X-rays, and obviously the classical changes are widening at the physis, lifting, and fraying of the metaphyseal ends, and some irregularity in the physis, which is generalized. Then Thatcher et al. Has tried to give a severity score based on the wrist and knee X-rays, which radius ulna count as 2, and then femur and tibia count as another 2 bones. So 10 is the maximum score. Highest score will be the more severe. With healing, the scoring decreases. So when we have a suspected case, we get the X-ray finding and get the alkaline phosphatase. And next, what do? Is we measure BPH, phosphorus, and then calcium. Basically, what we are trying to see is whether it's a hypophosphatemic or a calcipenic rickets. And we consider calcium as the most important mineral, but turns out that phosphorus is the most important mineral rather than calcium for the whole mineralization process. Because in hypophosphatemic rickets, basically calcium is normal. So if calcium is normal or low, the phosphorus is normal, it's calcipenic rickets. And the middle one where phosphorus is low, it is classified into phosphopenic. And the last one, when everything seems normal, it could be case of recovery or hypophosphatasia. What do we do when the calcium is normal, phosphorus is low, and the phosphorus is normal? So the calcipenic rickets, again, we look for 25 hydroxy vitamin D. If that is low, it indicates vitamin D nutritional deficiency or 25 hydroxylase deficiency. And if it's normal, we look for 125. If that is low, then it is probably 1 alpha hydroxylase deficiency. If it's normal, calcium deficiency. And if it's high, it's probably hereditary resistant to vitamin D. That's the receptor dysfunction. We saw the patient with alopecia. So again, coming to management, there is a STOS therapy for non-compliant patients, single dose units, but I generally routinely use 60,000 units weekly for 6 weeks, followed with calcium also, because it can lead to hungry bone syndrome otherwise. And then after the intensive phase, we should also continue for maintenance phase at least till 3 to 4 months, and then evaluate 6 monthly and yearly. How do we monitor them? So why the monitoring is required is to see for efficacy and any adverse events, especially when we give the STOS therapy, which is a high dose vitamin D, which can lead to hypercalcemia. So at 3 months, we look for serum calcium, BTH, vitamin D, and X-rays to look for radiological healing. And if by 3 months, case which you have been treating as rickets doesn't correct in any of the biochemical or radiological marker, then you should suspect as a vitamin D resistant or other kind of rickets. So coming to phosphopenic rickets, generally I take a nephrologist and endocrinologist opinion in these cases because I feel they are the best at handling the metabolic situation. But again, there is again urinary and amino acids, bicarbonate and glucose which is found and it's high. It could be renal Fanconi syndrome, and other would be if it is normal, it is usually either phosphate wasting or phosphate conserving type of rickets. So I will show that. Important thing for us would be any surgical corrections. Metabolic correction is important before that to predict outcomes and to prevent recurrences. And then younger child, we can wait and watch for improvement spontaneously. Skeletal maturity growth modulation before can be done, and after skeletal maturity this can be done. So enzyme deficient rickets, calcitriol is the best and it yields nice treatment with that. In hereditary vitamin D receptor function, this is the one which is most resistant to any kind of treatment, and IV calcium has been tried as a last resort in such cases. Hypophosphatemic rickets has so many classifications, basically FGF mediated or non-mediated. We have a wonderful drug for FGF23 mediation, that is this Geriatrics, which is a monoclonal FGF anti-FGF antibody, which gives good result along with the oral phosphate supplementation. And renal rickets, again, basically we manage metabolic acidosis, treat secondary hyperparathyroidism, and preemptive kidney transplant can be considered. So this is a child has rickets, treated with the same regime which I described. We waited because she had enough growth period, and in the growth spurt she recovered almost fully. So take home message is differentiate between physiological and pathological knee deformity. Vitamin D deficiency is very common, and if you don't find any improvement, I think we are looking at the persistent type of rickets, and we must have our endocrinology or nephrology. Thank you.
Thank you, Dr. Geriatrics, for that wonderful lecture with the atlas of clinical cases. The paper will open for discussion with the delegates and any burning questions. Okay, if not, we'll go for the next topic. Wait, Dr. Education for this talk on frontal plane deformities in older children.
Morning. Vidyasagar has made my job easier because he talked on the physiological and pathological. I'm going to emphasis more on the pathological, the coronal plane deformity, that is valgum and valgum, forum and valgum. So these are my objectives of my talk and should be considered for the growth modulation or osteotomy. What are the variables we should consider for the growth modulation? Principles, managements, techniques, indication, contraindications, and the limitations. So all of us know that if you draw a mechanical axis from the center of kidney and ankle, it should pass on the center of the knee joint. And if you divide into the 4 different zones, when the center is not falling on zone 1, then it's okay. But if it is zone 2 and the patient is symptomatic, it requires a surgery. And in a zone beyond the zone, it is there in a 3 and 4. If it is causing MED, mechanical axis is falling, then even though it's asymptomatic, the child will require the surgery. So before growth modulation, we need to understand what are the things we need to consider for the growth modulation. It's very simple: A, B, C, D, E. A for the age, B for the bond, C for the capacity to grow. D is disease born, and education and follow-up is very, very important. If patient is non-compliant, we should not do about the growth modulation. A for the age, it is always on the skeletally immature patients. If it's skeletally immature patient, we should not do that. At least 2 years growth, active growth would be left before considering for the growth modulation. Bone, again, it is a fast-growing bone like distal femur and proximal tibia. It should be not possible to correct with the non-growing bone like elbow or any other bone, distal end of humerus or proximal end of the The capacity to grow, it should be very well active in the active physis. It will not be useful in the sick physis or the physeal bar. When irreversible damage to the physis happens, the capacity to grow, it will not happen. You should not consider for the growth modulation. And disease, again, it is, as the Vijayasagar mentioned, many disease. One of the things which is having sick disease like hypophosphatemia rickets and infection or mucopolysaccharidosis. Growth modulation do affect, but it would be slower than the normal physis. So if it is, these are the disease we need to consider if patient is having, whether it is a normal physis or sick physis or a disease. The most important is the education and follow-up. If patient doesn't turn up for the surgery, it will go overcorrect. It's a very powerful tool, and that is the reason we need to consider for the education and follow-up. It should be considered as first rather than anything else. If you see about the physis, as the normal physis will grow the longitudinally. So what is the principle of the growth modulation? If you use about the non-locking tension bend principles, and then if you use the extraphyseal fulcrum, as like that, we apply it about the one side of the place, and the opposite is going to grow, and that's how it is going to work like that. It's a normal, the angulation, where we can see that lateral side of the physis, we can apply to the growth modulation. Opposite sides gets growth, and it slowly gets straight, and that is the ideal principle of the growth modulation. So the selection of implant should be the extraparietral, extrafacial, flexible and easy to insert and easy to remove. There are 3 different ways. Very commonly, previously 30 years back, staple was used. Then Matizio comes there. That's recently this very popular and simple is the clip plate. So the few points on the surgical technique. It is simple to localize the first about the physis and put the center of the physis. Put about the plates proximal and distance with the right sleeve. We can do for the drilling of the proximally and distally. You can use the first the epiphyseal screw, then use about the metaphyseal screw, and that can use about cannulated and non-cannulated. So this is one example that we can apply on the genovalgum. So the opposite side is going to grow and it will get it corrected. It's simply to get it corrected. The one more important technical point, screw should not be parallel. It will be the convergent or the adjoint. It doesn't mean always require the parallel screw. But safety, it should not penetrate the physis, and correct size of the physis, the hardware should be there. It will be on the midline of the bone or width of the bone. And it's very important is the follow-up. For example, the child present with the bilateral genu treated with growth modulation on hemiepiphyseal on the lateral side. Both sides, we can see preoperative mechanical axis is deviated medially, and the final follow-up in 24 hours, 24 months, that's what's corrected. It's clinical pictures. Another example, the child has got the genovalgum. Mechanical axis was laterally. After the 12 months, got corrected, and it's the clinical pictures. That's genovalgum and vara. Another example, the child has got a windsweep deformity following the hereditary multiple exostosis, one side valgum and one side vara. Mechanical axis was one side medially, one side laterally. It's treated with the one side medial hemiepiphyseal on valgus side, lateral hemiepiphyseal on the valgus side. Then it's got corrected. In the final follow-ups after the 12 months, it's got corrected quite well. Another advantage over the osteotomy that it can be applied for the metabolic disease where the osteotomy is contraindicated, like a renal defects, where we can see about alternate hospitals. It's not common. This is one of the examples in active defects, as the Vidya mentioned, that applied with the medial hemiepiphyseal and the final follow-up is what's corrected. Few important points before doing about these surgeries. Many times people are having severe pain, sometimes it's kind of a leak because of the medial side, sometimes it can lead to the back out, and sometimes overcorrection. So one example, the child has got a hip problem and the knee problem, is going in valgus. The hip was corrected along with the medial hemiepiphyseal was done, but the patient did not turn up, and we can see it went into the varum. So varum got corrected with this lateral hemiepiphyseal, and fortunately growth remaining was there, and we got it quite good correction. Another important point is that physeal, whether it can lead to the premature physeal. It's very unlikely unless we can drill about the physis or the periosteum is damaged. Growth resumes generally, it's once plate is removed. One important point is rebound for growth. When we should remove that, it's very important. This time with the exostosis, hereditary exostosis, about the valgum and treated with the hemiepiphyseal. He got it straight and removed the implants. And if you see that it's after a few months, it went into the recurrence of the same problem. So we have to treat it again with the hemiepiphyseal. So rebound growth is also possible. So it's every child need to be followed in skeletal maturity. Few contraindication for the surgery. Whenever we see the physiological, as Vidya rightly mentioned, we should not do the growth modulation. If there is a multiplanar deformity, sagittal, coronal, and horizontal, we should not do a growth modulation. And there is a rotational component, should not do the growth modulation. If the child is skeletally mature or irreversible physeal bar, we should not do the growth modulation. In those cases, the osteotomy is one of the important options, and we get correct the mechanical axis by doing about optimal level at the femur or a tibia. This is an example for the osteotomy. To conclude, growth modulation is safe and effective option to treat the angular deformity. The is needed in selective cases in the sick physis, in skeletally mature patients, and the physis is not working well. Thank you.
Thank you for the wonderful lecture highlighting all the important principles in growth modulation. I have two small questions. If you told that you have to place the plate exactly in the middle,
your experience, if you place it slightly off, is any better way of propagating?
Yes, yes. It should be the exactly on central. If it is on anterior aspect, it can lead to the recurvatum. If it is on posterior aspect, it can lead to the procurvatum. And I have some examples of that. So it is always we need to pay some attention from the surgical.
Sir, one more question. You showed some place where you use the A plate and some other plates also you use silicon plate for DC plates. Does it matter? Is there anything?
Yeah, actually, I have mentioned about the eight plate, but we generally now do with the recon plate, and we are published also is there. So the results are almost same. So if there is a eight plate is not available, we can use the recon plate, but we make sure it will be very smooth.
So what age you can have?
Up to 2 years growth left. So in case of the boys, it will be 1 up to 40. In case of the girls, by and large.
Thank you. Thank
you. Yeah, thank you.
Next, I call upon Dr. Geriatrics again for Brown's disease.
So Blount would be one of the pathological reasons for genu-virum. Yeah. So we'll see the whole spectrum in a while. Nomenclature-wise, it is called as tibia vera, but there is procurvatum, there is intorsion to it. And in late cases, there is shortening as well as joint depression. So attention should be paid what is what, define the deformities. Etiology, it's multifactorial. However, early walking, obesity, and vitamin D deficiency has been associated with Blount's. Again, Langenstewart has given us 6 stages and how the disease progresses with age. So till type 4, they call it as reversible, and usually 5 and 6 are irreversible and recurrence rates are high. So again, we don't know in 2 and 3 which may progress, which may not progress. Lamont has given us through his paper an idea of which cases may recur. So type A is where there is a metaphyseal lucency. Type B where there is a depression with the upgoing tibial slope. And type C is a depression with downgoing tibial slope. So the type C is a variety which has high recurrence rates. Before we go, we should know what is metaphyseal diaphyseal angle, mechanical axis deviation, tibiofemoral angle, and the posterior slope to calculate the procurvatum. We should also calculate the lateral and the medial tibial and femoral angles and the plateau depression, that is the hemi angle in late standing cases. Basically, Blount's is of 2 types. Some people call it 3 types also. Infantile is less than 10, and then adolescent is more than 10. This is early onset, severe deformity. Distal femur has usually valgus, and then knee instability, bilaterality is common, and it can be resolved in early stages fully. Whereas, on the other hand, late onset would be less severe deformity, femur varus is there, no knee instability, and it's generally unilateral, requires surgery most of the time. So Sinohara et al. And Weber et al. Has given us a natural history. In early stages, most of them correct spontaneously, but there is no way to predict which will progress and which will not correct. So they recommended if it is progressing or persistent, then probably surgery will be required, otherwise just observation. Coming to bracing, generally can be tried in less than 3 years with stage 1 and 2 in unilateral cases. And risk of failure is more with obesity when there is a varus thrust more than 3 years, bilateral and severe disease. In literature, there is no consistent evidence of efficacy of bracing. Then what is the other option? Surgical option, usually resorted in progressive deformity, age, stage of the disease, number of deformities, previous any procedure is done, psychosocial factors and facial bar formation, and the surgeon experience will count here, depending upon what to choose. Growth modulation has been tried in early phases, infantile Blount stage 1 or 2, where there is a progressive deformity and the child is less than 4. Adolescent Blounts, definitely yes, provided growth is remaining, to prevent recurrence in the later stages. So this is a 11-year girl with the adolescent Blount, and she had enough growth remaining based on her own age, and so we did a growth modulation. And in a year's time, she corrected almost to normal. Coming to the systemic review of how the growth modulation efficacy is there, there is a lot of undercorrection and poor reliability, especially in the older kids, and obesity is known risk factor for failure. Another paper which compared the efficacy, they showed that 78% of the limbs normalized, but failure rates were again somewhere between 11 to about 57% with growth modulation. So, what are the other options in older kids with a increased virus? This is a obese child, 3-year-old. You can see bilateral is there, but the right side is more. And that's on standing, no torsional deformity. And that's stage 2 on right and left stage 1. That's the mechanical axis deviation. So what we did was a RAPS osteotomy on the right and left side, we did a growth modulation. And that's after a year, things were looking normal. Again, he had recurrence on the right side, for which again we did growth modulation and implant removal on the other side. So we have to monitor them further, and just can't be done away with one procedure. When do we choose a corrective osteotomy? Usually more than 3, any stage, progressive deformity, failed bracing. Basically what we do in a corrective osteotomy is it's a osteotomy. We do a valgus, lateral translation and then derotation. Goal is to achieve 5 to 10 degrees of valgus, then 25 degrees external rotation, and align the medullary canal to create a lesser problem for future. When 5-year-old girl, unilateral Blount's, and there was intorsion, and cover-up test can detect that also. So coming to staging, like stage 3, Lemon type B, which is probably a better prognosis. Did an arthrogram, see that thickened cartilage on the medial side, there is no gap actually. We did a growth modulation as well as osteotomy here. And I removed the plate after some time, 6 weeks post-op, 1 year post-op. This is 2 years follow-up girl. This is 5 years follow-up. So how does the type of osteotomy affect? All types of osteotomy have the same results provided with all the basic principles. And again, recurrence is high with osteotomy with stage more than 4, biceps bar formation, stage more than 3, involvement, and a severe virus. So when do we do bicep bar resection? That's also been there in literature. Never done in isolation, always as an adjunct to osteotomy in stage 5 and 6. At least 4 years of growth should be there. This is a 9-year-old boy, high BMI, already operated at birth. Bicep bar resection and growth modulation was done at a young age. And then clinical examination obviously has high BMI, surgical scars, high foot angle was minus 30, knee laxity was there on examination. Both in extension and 30-degree flexion, we should examine for that. What did we do? We did a hemiplateau elevation as well as a metaphyseal osteotomy. And that's the post-op. We put a fibular graft there into the medial side. It's after 3 months, we started walking on one side, and then we staged and did the other side after some time. And that's the knee laxity, how it improves spontaneously without doing anything after surgery. And then that's the about 4 years follow-up. So this is called as a double osteotomy, plateau elevation. It is usually done in later stages, more than 8 severe virus, and where there is a plateau depression. And either it can be done acute or gradual based on the shortening and psychosocial factors and surgeon experience. Each has its own merit and demerit. This is another girl, 7-year-old, same obese, severe Blount, waddles and has a thirst. This is post surgery after 1 year, and after 4 years she had a mild recurrence on the left, and then she lost to follow. Same Blount's, operated 4 times before, still has a residual virus left, but there is some virus on the right also. She came for left, and we did a similar procedure, osteotomy and correction. After the first procedure, we had good correction on the left, right side was unmasked, so we did the right side also. That's our final follow. So we did about 8 limbs of 5 cases. We had 4 superficial infections, 2 inadequate corrections, 1 articular cartilage breach, 2 implant breakage. And I'll show you that. This is the articular cartilage breach, and that's the implant breakage, and we have to drill the screw wide hole to remove. However, this articular cartilage breach healed in about 6 months' time. This hole got covered in again 6 months' time. Thank you. We'll take any questions.
Well, so from the post point of view, if you say this is or there is a subtle junior
Yeah, so first my talk was there where we do a cover-up test, and if the child is less than 2 and the cover-up test shows that it is valgus, tibiofemoral angle, then probably most likely it is physiological. Another thing, if you get X-rays, we should look at the Brennan angle. More than 16 is definitely blown. Then 11 to 16 is a gray area. Less than 10 would be a normal physiological.
One more thing, sir. That case where the boy is 4 years follow.
Yes.
The boy had an internal rotation after 4 years. Was that a recurrence or was that inadequate?
No inadequate correction.
How to assess for the proper amount of external?
Yeah, that's thigh-foot angle, because most of the deformity comes from tibia. We put the patient in prone position, we look at the thigh angle and the foot angle. So any external deviation or internal deviation is calculated and compared on the other side. Usually, if it is intorsion, it will be around 30 to 40 blounds. That needs to be addressed in the first stage. Generally, I use a medial upright, like a KFO, which extends above the knee with a medial straight bar. There is a new device similar to that mermaid splint. Unhinged. In the literature, some people have tried full day, some people have tried only daytime, some people have tried nighttime. But as long as I think half the day should be enough, mostly nighttime, to provide unhindered activities in the day.
There is a lateral burst. Borderline clowns.
So that it will help prevent mechanical damage.
What is the advantage to use when the child is on, or is the advantage to the child is?
Mechanically speaking, yes, when the child is walking. Seems it makes more sense to use the brace, which doesn't allow that burst. Anyway, I don't have really belief in bracing. Just more for a parent satisfaction than.
I think you need a really compliant patient. Parents as well. You should understand the.
Most of my patients whom I have prescribed the brace, at least 90% have not.
It's also a that all the braces should be lightweight and comfortable.
Most of the new braces are lightweight, but
when they say that is one of the components, one of the factors which help for the complaints.
Importantly, if the child wants to play,
Pieces so that when they go to the exam, they can answer.
so any device which will allow playing and correct would be the best.
With all designs and like they look make it appear like jeans pant or something. The designs, printed designs. So that a lot of things will improve the compliance.
Now then we'll stop.
How long that brace has to be first tell the counsel the patient. Is there anything? We cannot say.
Yeah.
Till the virus starts will go. In case of the post-operative, because metal laxity is there, so we put about the face, or the conservative treatment also we put the face. So till that virus starts go.
Roughly say that around 6 months, 1 year.
Well, actually, in my experience, it will take around 12 months to
12 months.
Despite braces, if it is progressing, probably 6 months would be the cutoff.
Thank you for the great discussion. Now I call Dr. Hitesh for his talk on clinical pain.
So we have discussed on the coronal plane deformity. We will come back to the sagittal plane deformity. And it's basically on the flexion deformity of the knee and general recurvatum. So objective of my talk is then what are the deformities in sagittal plane? What are the different etiology of the sagittal plane deformity in child? Variables. What are the variables we should consider? What are the different options? You cannot apply the same option for everything. And few cases to show that. So basically, as I said, that it may be flexion deformity or it's a recurvatum deformity. And I'm not going to add the conclusion on the multiplanar deformity. I'm strict to the only sagittal plane deformity, flexion deformity, and recurvatum deformity. So what are the etiologies on that? We can get the flexion deformity or recurvatum deformity. Commonest is that growth arrest. Either the anterior growth arrest can lead to the recurvatum deformity, posterior growth arrest can lead to the anterior growth arrest of the distal femur or a proximal tibia. Whether the anterior posterior of distal femur and the proximal tibia. So depends on that. Whether it's anterior deformity, anterior growth arrest, it can lead to recurvatum. And posterior, it can lead to the flexion. Second is the capsular laxity and contraction. If there is a posterior capsule is tight, it can lead to the flexion deformity. If posterior capsule is lax in the gross ligament laxity, my child may have the recurvatum deformity. May have the soft tissue contraction. Whether it's like this child with the pterygium contraction, whether it can go from the skin to the tip to the bend, it can lead to the flexion deformity of the knee joints. Very common, and fortunately we don't see any polio, but other than the polio, there are the other neuromuscular disorders like the cerebral palsy or the multiple congenital contraction. We do see the flexion deformity, and most of the time, or very commonly when there is a quadricep paralysis, that can lead to the flexion deformity. So if somebody is asking what neuromuscular condition, that is the flexion deformity due to the extensor paralysis or extension weakness. Flexion is working, it can lead to the imbalance between flexion and extension, it can lead to the flexion deformity. Secondary to hip, knee, ankle, other problems with the limb line discrepancy, I'm not going into detail for the complexity of the etiology, but these are the different etiology for the flexion deformity and recurvatum deformity. What should be our aim? Aim to get the correct deformity, get the normal alignment in sagittal plane, ensure that there is normal limb length, and prevent the progression of deformity and restore the normal growth. And that should be the goal for any child. It should be followed till the skeletal maturity. So what are the variables we can consider? First and foremost, as I said, it's an etiology, whether it's infection, trauma, facial bar, capsule contraction, or laxity, whether the age of presentation is a child with the 4 years or near maturity. If the near maturity, the option for the osteotomy would be more. If it is younger child, growth modulation would be very important. Anatomical side, whether it's at the femur, tibia, or a knee joint, whether it is the location of bar, whether it's a central peripheral or the size of bar, if it is a facial bar, whether it is associated with the limb line discrepancy or the lengthening or the shortening, whether it's a one-plane deformity or a multi-plane deformity or rotational deformity. What we need to check is the clinical status of the physis and the capsule, whether how can we differentiate between capsule and muscle contraction. If there is a recurvatum deformity with the laxity, we can able to extend it fully, flex it fully. If it is only the facial bar, we can able to do that. The arc of motion would be maintained, but the opposite movement would be restricted. That's how we can able to detect by the clinical aspect also. What are the options to treat with the recurvatum deformity and other aspects? One of the important aspects is observation. If the child with the physiological hyperextension with the ligamentous laxity, it doesn't require most of the time treatment, or very commonly FFT at the time of birth doesn't require a treatment. We need to do follow-up. The brace, where there is a laxity, it's excessive laxity, hinders in the normal walking, it will require the KFO or sometimes a brace for the 3 months to 6 months. If the facial bar, if there must be less than 30% on anterior aspect or central aspect or peripheral, it will require the facial bar excision. If there is a soft tissue contraction, either the flexion contraction, it will require the flexion lengthening. If the extension like in the quadricep contraction can lead to the recurvatum deformity, it requires about the soft tissue lengthening procedure. The temporary or a permanent growth modulation. If there is a growth issue is there, we can do about the growth modulation. On the metaphyseal osteotomy, whenever we see about the fixed deformity and a bony deformity, it's required to do about the osteotomy. Shortening severity of deformity is it's 90-degree of flexion deformity with soft tissue contraction. We need to shorten to align the get it straight. Show you some of the case on that. So it's very important is that it's physiological or the laxity. If you require observation whenever there is the brace is needed, when there is a ligamentous laxity is causing a problem with walking. What are the surgical principle of the established deformity growth modulation? It's like a flexion deformity growth is there as we applied about the growth modulation on the anterior aspect, as in sagittal aspects. In the posterior get it corrected area to get it straight. That's the basic principle. Or if it is a skeletal measure, we take out the wedge on the anterior aspects of the flexion deformity and get it straight. And that's the extension osteotomy. You can fix with the plate screws. Depends on the child's age. So that when it is required to do growth modulation, it will prevent the progression of deformity. And whereas metaphyseal osteotomy, it will correct the mechanical axis in a normal line, and it should be done at the maturity. The few examples for the flexion deformity. This is the child, adolescent child following a trauma. You can see the posterior growth. So their extension was not possible. So these are the different options which already we discussed on that. Ultimately, child was treated with the supracondylar extension osteotomy. Anterior epiphysiodesis to prevent the progression. And this is the final follow-up which got straight. The final follow-up child has got some amount of the shortening, but no effect. Now another case with the facial bar, you can see the central facial bar. But on CT scan, it was more than 60% of the license. So it was treated with the osteotomy. It was the flexion deformity, so it's treated with the CAMs, and the final follow-up. Another case with the popliteal division, the child has got almost 100-degree of the flexion deformity. And for operating, we can see it's getting it up to the 90-degree. So it's just treated with the posterior soft tissue release with the extension osteotomy, with the shortening osteotomy. And the child has got almost straight. All of the child is walking quite okay with the brace. And it's a independent ambulatory child, was not walking before because of the bilateral, so multiple congenital contracture with the bilateral popliteal division. The child is walking quite well. Another case, severe flexion deformity with the deformity of the multiple joints, flexion deformity of hip, knee, ankle. It was treated with the serial surgery. Child is treated with the extension osteotomy, with the shortening osteotomy, and the final follow-up, the child is having a good corrections, getting it straight. Few examples for the recurvatal deformity. The child has got the facial arrest and as near maturity, where we can't do about the growth modulation. Child was treated with the gradual correction of the deformity by the external fixator, and we can able to see that it's slowly getting straight, followed by the lengthening procedures. So it's the final follow-up able to do extend fully, flex fully, and gymnast get corrected. Younger child presented with the recurvatum because of the facial arrest on anterior aspects. So this child was treated with the sequential surgery, the facial bar excision first, then this is the facial bar excision. We can able to see the central bar has been excised, and then serial follow-up still it did not get corrected fully because the growth has not catching. Still we can say about the extension deformity was there, it was corrected with the gradual with the external fixator and it's got it straight. And the final follow-up, the child is quite straight, but still he is immature. So he has to follow up with the skeletal maturity to prevent the defects. The last but not least case, the child is the 14.5, presented with the general recurvatum following the trauma and having the infection, has got the severe cortisol contracture. The child was treated with the cortisoplasty. You can see the scar tissue, and with the cortisoplasty is one of the longest incisions. And final follow-up is quite good. There is no extension leg, and if you see the posterior condyle is also going to be remodeled. In conclusion, the assess the etiology of deformity, assess the projected deformity, check the status of biceps, capsule, muscle imbalance, and treat the growth deformity accordingly. Growth modulation is simple, can be applied for reversible problem. Deformity is required for the Any questions from the audience side?
And secondly, the severe flexion deformity like in the pterygium, you're going for a shortening with reflection from the osteotomy. Anything than for the pedular tendon for extensor lag, advancement or any.
No, actually, if there is a flexion deformity, we should not touch on the both sides of the knee joint. We can correct first deformity and see about the quadricep. Let the quadricep act. We can put about brace for the long period of time. The popliteal region is the highest chance of recurrence. Highest chance of recurrence. So we have to follow. Yes, it is very important, and that is the reason we need to shorten it. That is important issues I have addressed in the shortening in case of the flexion deformity and extension. It's mostly common in a flexion deformity. So in case of the cerebral palsy, when it is more than 40-degree FFP is there, we always do not only extension, we do the short. So we cut the ball, get it overlap, so the neurovascular will get it relaxed, and the overlap point we do the short.
So in the initial case of, do you have any abnormal neurovascular bundle?
Yes, yes, and we have seen very commonly when we go and openly on the posterior aspect, it's just under the skin, it will be there. It's just under the skin, except when we cut the hamstring next to that, it's very, very superficial.
You have any capsular contraction?
Yes, in this case and all the cases, we address about the capsule, everything except the neurovascular.
There are no other questions. Let's go to the trauma topic, the fractures around the knee joint by Dr.
So I thank the organizers for giving me a opportunity once again to be here. So injuries around the knee, I will be focusing more on the facial injuries around the knee, because that is more important in a growing child, and those are more common than articular injuries. So if you look at the comparative incidence of injuries of the lower limb, so the distal femur proximal tibia contribute to a lesser extent compared to those around the distal tibia. But still it is very important because we have to pay special attention because of the great amount of the physis which is involved, which is there and which contributes to a great extent of the lower limb length, and also a high risk of neurovascular injury. So we all know that the physis of the distal femur proximal tibia is undulated, it's not a straight physis. So what happens when there is injury in this area? Large area of the growth plate is susceptible to damage, and this damage, when it happens because of the force, these are high energy injuries, and the fracture can happen not in just one zone, it travels through different zones. So the fracture line can pass through different zones of the cartilage. So if it involves a germinal zone, that's the main dangerous zone. So it's called as a wrong side injury. So it's not because it travels to different zone, and it's also subjected to shear, compression, and fissure as well as shear and scraping. So the prognosis based on Salter-Harris classification will not apply here. So we have to consider the amount of displacement, the mechanism of injury. In addition to that, Salter-Harris type is what we have to consider. All traditional that type 1, type 2 are better prognosis, type 3 and type 4 are more prone for facial damage. So in addition to that, we have to consider the mechanism of injury and initial displacement. So coming to the distal femur facial injuries, so these are high energy injuries, most commonly following a motor vehicle accidents or sport related injuries, especially in adolescents. in newborns and young children, they can have type distal femoral facial separation, something like this. And if you suspect a toddler with bilateral injuries, you have to suspect a child abuse. So it can also happen in neurological causes like cerebral palsy. We are already osteopenic and the faces can get separated following a seizure or a physiotherapy. It can lead to this kind of injuries. So these are the different patterns of sartorius injuries which can happen in distal femur. So another type what is described by Peterson where the fracture involves the metaphysis which can extend to the physis and also be seen in these areas. Sometimes we can have, following a very high velocity injuries, we can have these kind of injuries where the metaphysis as well as the physis is comminuted. So we have a strong suspicion of something happening around the knee, but radiologically mean on X-ray it's normal. So do not hesitate to get an MRI because you can throw up a surprise by showing a facial injury. So this is especially happens when there is no metaphyseal plate, the dorsal prolonged fragment in type 1, 3 and 4 injuries. So in addition to that, there is high probability of facial bar when there is a contusion of the bone in the metaphysis. This is what we call it as a type 5 facial injury. So this at least we can tell the parents that there is something around the injury of the knee. You can expect a late deformity or a ligament disturbance which can happen. So the varus valaris displacement is more common and often it's a type 2 sartorius. So displacement can also happen in a sagittal plane, something like this. But whenever you see this, you have to be aware of a vascular injury because the optical vessels are very next to that. So the tips in treatment, always consider as soon as you see the check and consider reduction under anesthesia. Do not try to reduce without anesthesia. So the principle of 90% traction, 10% leverage has to be followed. So this is a technique how you do. So if you put it in animation, so you just don't just correct the angulation. What happens is the spike of the proximal fragment can scrape the physis. So this should not be done. What you should do first, you give the traction, okay? Then maintain the traction after restoring the length, you lever and correct the deformity. Once it is done, you fix the metaphyseal fragment, and if you want, you can do the fixation across the both plane. So this is how it was done. So if you see a late presenting fractures and facial injuries, you have to consider really whether you have to do a reduction or not. Exception to this is when the articular cartilage is involved, that is type 3 and type 4, where you have to give more importance to the joint rather than the physis. Facial, if there is any facial bar subsequent to a treatment, you can always correct with the osteotomy, but if the articular cartilage is incongruent, then it can lead to early arthritis. So, late presenting type 3 and type 4, you still have to consider anatomical reduction. So, whenever you try to reduce these fractures and if it is not reducing properly or there is asymmetry of the physis, it's unstable, always open the fracture site at the physis because there will be a periostal interposition. So if there is a periostal interposition left, then it can lead to early facial bar. So whenever you do a fixation, even though you use a smooth pin, so try to minimize the number of attempts you pass the wire because it can also lead to a facial bar, something like this. So in communicated metaphyseal fractures, aim is to restore the anatomy of the articular surfaces. So if possible, the physis too. So open section is required in these like any other articular fractures, and you can do different combination of fixation, either a submuscular plate spanning the physis, where you can remove the physis plate early, or a cannulated screws, wires, or etc. So this was a metaphyseal fracture like Peterson type, where we fix the spare the physis but span the plate across the physis. So and we did an early implant removal. So aim here is to restore the length and anatomical axis, I mean the mechanical axis. So if you look at the complications of distal femur injuries, the more common is the facial injuries related to. So this was a child with a type 2 injury, but still he developed a facial bar. He was treated elsewhere conservatively. He presented to me 2 years after injury. You can see that there is a facial bar on the lateral side. So why it happened in type 2? Because the proximal fragment has scraped the physis. So if you look at the proximal tibial facial injuries, it can be, you can roll up the entire physis or you can happen in the tibial tuberosity or the tibial spine. So whenever you see a proximal tibial fascial injury, these are more prone for vascular injuries, because as even in adults, you see a proximal tibial fractures, we are worried about compartment syndrome and vascular injury. Same thing holds good for pediatric child also, pediatric patient. So surprisingly, these fractures are very unstable in spite of good muscular and ligamentous attachments. These fractures are highly unstable. So these are the various fracture patterns which can be seen. So always check for neurovascular injuries. The treatment, you consider that we have to follow the same principle of 90% traction and 10% linkage to correct the angulation. Aim for anatomical reduction, it involves the articular cartilage in the epiphysis. So this was a child with type 2 injury who was treated with a close reduction. So in case if you are not feeling, you are not able to reduce, or if there is a gap on the epiphysis, so you have to open and check for the periosteum position. So it's a child who had a type 3. So if there is a type 3 and type 4, you have to open the joint, reduce the articular cartilage. What you can do an arthrogram and drop, and then reduce the fracture and fix it. So this was a boy, 14 years of presented with the type 2 post-medial displacement. He was, even though we could reduce it, but it was the fracture, there was more gap on the middle side, so we made a small opening. So we removed the periosteum on the middle side. So once we reduced it, and we fixed it with 2 wires. So what I do is I usually try to pass the wire from metaphysis to epiphysis. The reason being, if I have to change the direction, I am passing from the hypertrophic zone to the germinal zone. If I pass from the epiphysis to the metaphysis, I am passing from the germinal zone. So there is more chance of damaging. If I pass the wire repeatedly, there was no chance of damaging the germinal layer if I pass from proximal to distal. So try to pass from metaphysis to epiphysis. So in child, this fixation was done in 2 cross cables. It was stable. We just gave a slap for 6 weeks. So another 30 years boy presented about a week or 5 days after the injury, treated with same principle. So this boy didn't open the legs, instead the post periosteum. The 4-year-old child presented just about 2 weeks back. So these are the injuries which will really scare us, because there's high chance of neurovascular injury. But fortunately, this child had no neurovascular injury, but swelling was more. So we treated with this is a type 2 injury. You can see there is one transverse wire and one oblique wire. So the fragment was too small for me to put a screw. So that's why I put a wire. So surprisingly, these children can have some amount of knee instability at later age and can lead to degenerative joint disease. So coming to the tibial spine, these can be undisplaced or displaced or completely displaced fragments. So treatment. So what I want to importantly you have to see is what appears like a tibial spine avulsion may not actually be a tibial spine avulsion, anterior tibial spine. So it can be a PCL avulsion. So we have to print out, get an MRI, or it can be a sleeve fracture of the patella. So this is something which can be very easily missed, the sleeve fracture of patella. So most of these tibial spine avulsions can be treated constantly, especially the type 1s and type 2s. If it is completely displaced, obviously you have to open joint and either to open or arthroscopic assisted reduction fixation. So when you are doing the fixation, you have to try and spare the growth plate. So usually these injuries have good prognosis, and some amount of asymptomatic laxity can persist. So wait a couple of minutes. So what about tibial avulsion fractures? So it can depend. This usually happens around the adolescent and skeletal maturity, because as the physis grows from anterior to posterior, so the junction of that is weak. So usually the result from a sports injuries. So most of these have to be managed with the open reduction, especially rather than the type 1A fracture. So I want you to remember these patellar sleeve avulsion fractures, which we have to rely more on clinical findings, because they can have very subtle findings on X-rays. So you can see the arrows there on the left side. There is a superior sleeve avulsion. On the right side, you can see the inferior sleeve is avulsed. So this was one such child. Clinically, he had a patellar fracture, but X-ray was essentially normal. So why this happens is, you can see this is an improper picture. So the cartilageous fragment is avulsed from the the main fragment of the patella. So this is visible as a very small flex. You have a high index of suspicion and you have to correlate with clinically. So once you have made a diagnosis, it's like treating like any other adult fracture. You have to fix with attention management. So to summarize, injury involves the major growth plates around the knee which contribute to almost 80% of the lower limb growth. So we have to be very cautious in assessing and counseling the parents, explain them about the possible limb-line discrepancy as well as the angular deformities, and we have to restore the anatomical alignment, especially in case of type 3 and type 4 fractures. Thank you.
Thank you, Dr. Suresh, for covering the entire spectrum of isolated injury. There are any other questions? Tradition have used a fiber wire. Is there any difference instead of using a metallic wire?
There.
Lost metal sleeve also.
No, I didn't use fiber.
It was not a fiber.
Stainless steel, etc.
The irritation between you remove.
It's like an adult as early as.
If you use a fiber wire, is there a need to remove?
No, fortunately, unfortunately, I don't have the experience of using fiber. This was a child who was operated in a district hospital. So getting these implants itself is difficult. Fiber, but maybe others are using, they can share that. With the bond?
Green color antibond or the white pill, the number 2 white pill.
Yeah, I think, yeah. So the heal pass. Advantage of white pill is I think it absorbs, antibond remains, so it can cause some irritation. So you can use a thick white glass because the soft tissue is just if it's there for 6 weeks, that's more than enough. And anyway, in this it's immobilized for some time.
Fiber wire we are using. Fiber wire we are using it regularly, not just to fix it. Facial avulsion we are regularly using.
Yes.
Just one question about this type 3 tibial tubercle avulsion.
Yes.
If you reduce very anatomically, what's the chance of growth correction?
Type 3 avulsion.
So,
but because if you pass the fixation entirely in the epiphysis, what we call as intra-fixation fixation. That is not, but how do you cross that physis?
The physis is not disturbed. So one screw goes over the epiphysis, another goes like the metaphysis.
You mean tibial spine avulsion or
tibial clavus?
Yeah, that tubercle cross. Okay. Yeah, we can pass it. Because usually what happens is in that age, entire posterior physis is already fused. Only the active part is remaining. That's why these pattern of fractures happen, tubercle avulsion. So it doesn't matter. Only thing if we do it in very early in children, we are worried about developing the recurrent deformity. That we have to be very careful. If it's older child, really speaking, there's no problem.
Thank you, Dr. Krish. Now I would like to invite President of Pediatrics Orthopedic Society of India, Dr. Dhiren, for a talk on pathology.
Okay, good morning. So this is going to be a topic between trauma and non-trauma situation. So when we talk of the particular instability, it's not moving. Yeah, now it's so it's a wide spectrum. On milder end, we have asymptomatic maltracking. Means patella is maltracking, but it's not creating any problem to the patient. And on the extreme side, we have habitual dislocation where every time the knee flexes, the patella dislocates. So I'm not going to cover the management of the whole spectrum, but we are going to take few situations which are important for us for understanding the concept. So the first point, the factors which leads to instability. So it's a balance, and when this is balanced, the right and the left, they are equal. So when in a normal person, when patella is tracking, means moving normally, the factors which are pulling medially and laterally, they are symmetric. But when there is a tilting, the first possibility is the one on on a left is heavier. So let's understand that situation. Usually patella maltract on the lateral side. So usually there is an increased pull on the lateral side. And let's understand the factors responsible for that. So the reasons for more lateral pull, either genuine valgus, that's the first possibility. Like she has a genuine valgus, and why it leads to more pull on the lateral side, that we will see in a minute. The second possibility is the tibial tuberosity, where the patellar tendon inserts is situated laterally. Ultimately, both things they work in the same manner and they have the same abnormality. So we will understand that. So let's see that the quadriceps mechanism, patellar tendon, and the tibial tuberosity. If there is a straight alignment, in that case, the quadriceps mechanism and the patellar tendon, they are in a straight line, and then there will be no deviating force. But if there is a genuine valgus or tibial tuberosity is situated laterally, in that case, if we draw a line joining the quadriceps tendon and the patellar tendon, they are not in a straight line, and there will be a resultant force which will be taking the patella on a lateral side. So the question is how to assess this genuine valgus and the laterally situated patellar tibial tuberosity. For genuine valgus, it's very easy. Already Dr. Nitesh, Dr. Vidyasagar, they have explained that we need to take a standing X-ray like this, and from that we can find out the malalignment. We draw a line joining the center of the femur to the center of the ankle, and if it passes on the lateral side, then it suggests that there is a genuine valgus. But the second concept I would like to explain in slightly detail because that's a new concept. Those who are in the field of arthroscopy, they know it very well. But for the other audience, it will be slightly new concept. So I would like to explain that. It's called trochlear groove to tibial tuberosity distance, TTTG distance. So what is that? If we take a groove, the trochlear groove, the white line, and if we draw a vertical line passing through the tibial tuberosity, what is the displacement or the distance between the two? That is called the TTTG distance. For that, we take a first cut either by CT or by MRI at the trochlear groove, shown as white dot. The second axial cut is at the level of tibial tuberosity. So let us understand how it is calculated in a situation on the imaging. So this is an axial MRI image taken at the level of trochlea, the femoral trochlea. And from the lowest or the deepest point, we draw a vertical line which is perpendicular to the posterior femoral condyle. So the horizontal white line is through the line joining the posterior femoral condyle, and the vertical line is through the trochlear groove. Similarly, we take an axial cut at the tibial tuberosity level, and we draw a vertical line, and the displacement between the two is the TTTG distance. If it is more than 20 millimeter, then it's definitely abnormal, and that can cause patellar instability. Okay, now coming to the second point, when we see this situation, most of the time we are thinking that it's because of the heavy weight, but we need to understand that it could be because of the less weight on the right side. So what are the factors for that? The factors are less medial pull, and the factors or the causes for that is the VMO, vastus medialis obliquus. It's giving a medial pull, and if it is weak, the pull will not be adequate. The second is MPFL. MPFL stands for medial patellofemoral ligament. It's a ligament which is joining the patella and the femoral condyle, and it's important structure to provide the stability on the medial side. If it's ruptured because of the injury, then medial pull would not be adequate, and that will allow the patella to displace later, like this. The third factor is shallow trochlea. And how does it work? This is a normal trochlea, try to understand the cycle chain which remains in the groove because of the depth. If on the other hand, if we see this a shallow trochlea, it's not holding the patella in that groove, and patella has a tendency to shift. These are the X-ray which shows that there is a shallow trochlea. But more reliable thing is axial imaging. So this is a normal depth of the trochlea. This shows a shallow trochlea. Now, how do we measure it? For that, either we take a CT scan and or MRI, and then we take an angle like this, and that gives us an idea about the depth of the trochlea. If this angle is more, then it suggests that the trochlea is shallow. Another factor in this category is patella alta. How does it affect the alignment or patellar instability? When the height of the patellar tendon is normal, the patella is in front of the trochlea. So it's articulating well with the trochlear groove. On the other hand, when there is a patella alta, means the patellar tendon is longer, the patella is not in front of the trochlea. It is at higher level where already the groove is shallow. So for that, to measure the patella alta, we have two indexes, the insult solvability index and the caton threshold index. I'm not going into the depth of like how to measure it, but this will give us idea about the height of the patella, and if it is more, then it could be the reason for incident. Coming to the management, asymptomatic maltracking does not need treatment because patient will not get convinced for any treatment because they are asymptomatic. But the another condition which is very important and it has to be treated well in the first time, there is a first time dislocation. So when the dislocation takes place, it can lead to osteochondral injury, and I will try to show you how actually it takes place. So the mechanism of osteochondral injury. Let's understand that when patella moves laterally, dislocate for the first time, either it can cause damage to the articular passage of the patella, or it could cause injury on the lateral femoral column. How to diagnose it? It cannot be diagnosed with X-ray. So the best thing is to get an MRI. And if MRI shows large osteochondral fragment, then we need to fix it. If fixation is not possible, then we need to take help of our colleagues, particularly those who are expert of autologous cartilage implantation. We need to take their help. What are the chances of recurrence? We need to look for the risk factor. If there is a trochlear dysplasia, these are the risk factors: the patella alta, skeletal immaturity, and history of contralateral dislocation. How do we decide? If there is a zero factor, the chances of recurrence are 14%. We don't need to suggest surgery. If there is one factor, the chances are 30% for a recurrent problem. If there are two factors, again it's half, and we don't suggest surgery because that would be unnecessary surgery for 50%. But if it is 3 factors, then there are 3 out of 4 cases will likely to go for recurrence, and in that case we need to consider for surgery. And when there are 4 factors, the chances are really pretty high, and we should consider for this thing. So I'm stopping at this point, and the message I would like to give is like whenever we have a patient with patellar instability, we need to treat it well in the first time, otherwise it will go for a recurrent problem. Yes, we can definitely tackle that, but it's always better to tackle the problem when it is for the first time. So with that, I will be happy to answer your question.
Thank you, Dr. Geriatrics, for your wonderful lecture, simplifying all the complex concepts. Now, for the audience, you can ask the questions to Dr. Geriatrics.
Okay, a good question. If we are not able to get a full flexion without dislocation, then we need to find out the cause. and the treatment depends on the cause. I am not covering that part because of the lack of time. I have few slides remaining, but I'm not covering that. Like how to go for when it's dislocating, whether it's a recurrent dislocation. But what I suggest is like find out the reason for that. And sometimes it may be the quadriceps tendon which is short, and we may need to lengthen that to prevent it. So it's a a la carte approach. You can't have a one technique which fits all. We need to find out the cause and we need to treat accordingly.
I think you have to have systematic approach.
Exactly.
There any ligament problem is there or not? Look for trochlea, then try to address that issue.
Exactly. Most of the people they ask like give us a prescribed format. You do this, and that. So that does not work over here. We need to find out the abnormality, the reason, and accordingly we need to treat.
I think in simple terms, MPFL, tibial tubercle, or trochlea. These are the three factors we have to address.
Yes.
And you have to identify where the pathology is.
Exactly.
Maybe combination of those things.
Exactly. Yeah.
Just to answer your question, we are talking about habitual dislocation. Most often it's because of the tight lateral structures as well as the short quadriceps tendon. So if you do a gradual release, if there's any quadriceps tendon, if you release the adhesions, usually you can get back to normal track. So it's mainly because of the soft tissue. It's habitual dislocation is mainly because of the soft tissue contractures in the lateral.
Just for the audience, like I'm showing you few of the slides, what Harish said, if it's a habitual dislocation, in that case, the first thing we need to do, usually we need to do 4 things together. The first thing we need to do, carry out extensive release, because the tissues on the lateral side has become short. So we need to release them. That's the first thing. Then we need to release the medial structure because they have become lax. So unless and until you release them, they will not allow the patella to come in the center. Then we need to carry out a medial transfer of half of the patellar tendon, like this. We take a half of the little part, shift it medially. So again we are giving the medial pull from distal. And the last thing that we need to do, because now medial structure has become lax, we overlap them over this. So ultimately that gives a full alignment thing. The one thing which is remaining, what sir said, is like the trochleoplasty. Usually we don't do in pediatric population, but in adult we need to carry out that problem also. So we need to deepen the trochlea, and for that we need to carry out, like we need to create a groove underneath the trochlea, and then we break the cartilage and we create a big trochlea. So this is the whole thing for like we are doing everything in this patient, but this is the extreme habitual dislocation, and in that case we need to tackle all the factors responsible for. Thank you.
I'd like to invite Dr. K.N. Subramanian for his talk on ACL injury in children.
Thank you very much. First of all, my sincere thanks to bringing arthroscopy, arthroplasty, and pediatrics all in one forum. Thank you very much for the Preethi team. And the talk given to me is ACL injuries in children. I think we all think it is very, very uncommon. In fact, it is not very common because ligaments in children are slightly more flexible. They have slightly more elasticity. And they will not rupture that easily. Instead, they will stretch out a bit. But if you see the incidence of it is roughly around 1 to 2%. So more sports awareness is there, and hence there is gradual increase incidence of ACL tear. And roughly I do about 2 or 3 cases in a year. That's the maximum number that I do. So this is a rough incidence. But what is the all objectives in pediatric ACL tear is, number one is we need to get the stability back. Because once ACL is ruptured, the stability is gone. Number two is we should avoid growth plate damage. These are the two main concerns that we have to address when you are thinking about any patient coming with a pediatric ACL tear. Very important to understand how much is the growth contribution from the knee joint. So, for example, about 65% of the growth occurs from the knee joint itself for all the normal human population. 37% occurs from the distal femur and about 28% occurs from the proximal tibial basis. So, this is something you have to understand. And how close is the ACL to the growth plate? So, if you see the femoral attachment of the ACL, it is roughly within about 3 to 5 mm. There is a very small margin of error when you are doing ACL reconstruction. So this is an important message one has to understand is that the ACL femoral attachment is very close to the growth plate in the posterolateral aspect. That is one point I have to emphasize. And what if significant growth plate gets damaged, then they will have neck length problem or a valgus from the knee joint or a tendon recurva. These are the three common problems that we can encounter. But how common it is not that very common, because all these problems occur only in those group of population like 6 to 12-year-old age group. Majority of the patients that we see are around 12 to 16-year-old age. So we don't come across that many problems. But what is the scale of damage to growth plate in ACL reconstruction? It depends on the graft size. For example, if somebody is using an 8 mm graft, there is a rough area of damage occurs only 2.5%. And if it is a 11 mm graft, it's 7.8%. This is an important message also. So up to 7% of growth plate involved only occurs even if you use a 10 mm graft. Normally we don't use 10 mm graft for a pediatric. Pediatric population normally is around 7 or 8 is the maximum graft that we use. So is there an option to manage non-operatively? There's a common myth saying that once a child gets injured, wait for until maturity. Actually, that's not an appropriate take-home message. Take-home message is any child coming with the ACL injury, they have a very high chance of developing a further problem due to instability, either a meniscus tear or keep on having any further damages. So it's not a wise option to do non-operative management. There are several papers about it, and even they have, when they get a medial meniscus tear, they will get irreparable medial meniscus tear. So there is no point in waiting for a child to have a non-operative management. It should be addressed as soon as possible. That's the first message one has to understand. Managing non-operative is not an option for a pediatric population. Okay. Next is going to the reconstruction techniques. I think there are two types. One is complete transfer as the conventional ACL reconstruction system. Other is a ACL sparing, where you don't want to damage the facies at all and do ACL reconstruction without damaging. These are the two major techniques that we are all using. Let's see what if I do the conventional technique. In a conventional technique, there are two ways we are doing it. One is the transtibial, another is the anteromedial portal technique. Traditionally, we all did the transtibial technique. In that, we do transtibial technique for a given dimension of the drill diameter. There is less damage to the growth plate if you do the transtibial technique because the tunnel orientation is vertical. Same thing, if you do the technique that we are doing nowadays, anteromedial portal technique, where the tunnel goes in an oblique fashion, then the amount of damage that occurs will be slightly higher. So the first paper is about the vertical tunnel, second paper is about the oblique tunnel that we normally use. So there is a chance of growth arrest when you are using here conventional, now routinely used the anteromedial portal technique. If you use a vertical tunnel, there is less chance of growth arrest, but chance of graft failure is there. Use the vertical tunnel. So we have to balance between which one to use. So now to avoid all these things, we have developed new techniques now. So when can we do transfacial? Like when a child is looking like an adult, like a tan at stage 3, or is a grade 4 or 5, then already the child is become like an adult. So those who have crossed more than 14 or 15, 14 in a girl and 15 in a boy, then you can almost do like a normal adult only. You won't have any problem at all. But those who are around the 12 to 14-year-old group, they are going to have the growth spurt. They have to be very careful with this population. Then you have to think about doing a transdeprivation technique or facial sparing technique. So how can we prevent the growth arrest in those kind of population? I will talk about around the 6 to 14-year-old group. That's the growth. That's the population where they are going to get a growth arrest. How to prevent is use a soft tissue graft is better than the bone block. Not to use a BTB. BTB will cause definite growth. Not use that one. Avoid screws over the growth plate. Because the diameter of screw that we are using around 8 mm, 9 mm, all can cause growth corresponding. So avoid using those kind of screws. Using a bigger cut than 11 mm should be abandoned. You can't use a graft like 11 mm for pediatric problems. Should be around 8 mm. Beyond that is they have a high detrimental for the growth plate damage. So now the current technology that we use is all inside ACL reconstruction. This is definitely a reasonable option. Because in all inside reconstruction, what happens is we are maximum using only about 4 mm grip through the growth plate. So the chance of growth arrest is very, very less. Even if it occurs, it's only around 1 to 2% of growth plate involvement. But that is the current standard that we use for patients who are coming with a facial, where we are trying facial sparing ACL reconstruction. Other option doing the facial sparing technique. This I have done in few patients who are coming around the age group of 7 or 8. The least age I have done is only 6.5 years old. I'm not the age below the age group. So this is around 7 or 8 year old or 9 year old. We can do the facial sparing technique, where we totally avoiding the growth rate at all and using the epiphyseal window to put our bones on us. That's why it's been done. So remember this window. How much epiphysis is there in the distal femur? How much is there in proximal tibia? In distal femur, we have only about 20 millimeter window. And proximal tibia, we have about roughly about 15 to 16 mm window. So we have to do our tunnel in that window so that we can avoid the growth rate. That is the one way of doing a trans epiphyseal ACL reconstruction. So it will look like this. Here we are looking in the epiphysis of the femur, also the tibia. The tunnel will be going horizontally in the epiphysis. In the tibia, it will be going slightly obliquely, but it will be avoiding the physis totally. I'll just show the video how it is done. So, what we are doing is using the X-ray to identify we are going on the epiphyseal window. So here also in the femoral side also I use the epiphyseal window. So you are going from drilling from outside to inside and identify the spot of your femoral entry point and pass a drill which is about 2.8 mm diameter only, and then retrogradely do the femoral drilling. So about desired diameter, maybe up to 20 mm usually do. So we are totally avoiding the facial window at all, doing just below the faces. The usual diameter that we get is around 7 mm only, 7 or maximum 8 mm. So this is a 7 mm graph that I am putting in, and try to do it in the retrograde fashion. And in this particular case, I am not using screw at all, using suspensory device on the femoral side as well as the tibial side. So there is no chance of having any facial damage at all. Because even if there is a facial damage, it will be only soft tissue there, not the bony clot there. So that's the tunnel where I have made with totally avoiding the faces. So this is a button going through the tibial side and then passes through the femoral side. And then we really pull from the tibia also. Now doing the tibial tunnel now. So that's the final picture of the ACL graph. Yes. Only few more slides. So that's the current state of management for patients who are coming in the potential age group of growth plate damage is the transfacial ACL reconstruction. Transepiphyseal ACL reconstruction. That's what I demonstrated the screen for you know. If you do that kind of technique, almost there is no patient who will get growth arrest, and the good clinical outcome in terms of stability is also almost guaranteed. There's another option. So the rules to follow is like transepiphyseal tunnels should be filled by soft tissue graft, not to be filled with screw or bone block. Avoid over tensioning of the graft because the child is growing. Over tension the graft, they will end up in sickness also. The Geriatrics. There's one more option that you should think about is doing a primary ACL repair. This is possible in children who are around the age group where they are having a type 1 tear. type 1 tear, the tear has occurred over the femoral attachment side. There you can actually, without even damaging the growth plate, you can attach the from native ACL to the. Let's see whether you can play that one. This one, what we are doing is we are attaching the ACL directly to the femoral side itself, the native ACL. In that way, it's a very simple method. It can be done for a selective group of child where they are having type 1 type of tear in the ACL. This is another option for pediatric age group. So just to conclude now, active reconstruction is advised in order to reduce recurrent instability and joint damage or meniscal damage. Surgical management in Tanner's stage 3 or above is transfacial. Conventional technique can be used in those who are already mature. Properly performed facial sparing result in excellent stability and functional result. This is for the age group of around 6 to 14-year-old age group. Recently, there are reports on showing excellent functional outcome even in Tanner stage 1 and 2 for where they are doing all in technique, where they are saying there is no growth errors even in Tanner stage 1 and 2. But you should take it as a pinch of salt, but it might, the future will tell us what the scientific basis behind it. Risk of growth disturbance is minimized when transfacial tunnels are kept small and completely filled with soft tissue graft. Fixation devices like bone plugs should be kept away from the faces and both the chips should be avoided. That's the take home message. Thank you.
Thank you, Dr. T, for your elaborate lecture on PCA. Any questions from the floor?
On the people side, people side you use people side use inside post
the tibial side, the tunnel length will be very small. It will almost become like horizontal. Normally we keep about 55-degree angle for a tibial knee. That is conventionally that we all practice. You have to reduce the angle to about 40 degrees and keep it slightly medium. Then only you can avoid that. You have to check with X-ray imaging this way to see whether you avoid the growth better. It's slightly difficult only. And the problem with the pediatric is we don't get that many number of cases. So there are very only few people are doing many number of cases unless they get a referral back. We get about 2 or 3 only in the maximum area. That's all of that.
You need to avoid the tension on the graft. That's what we told you.
That's why this all-inside technique, what we are doing, we are using suspensory device only in the tibial femoral side. There will be slight laxity with it. It won't over tension. That's the advantage of using the if you fixing the screw, you get over tension. The all-inside technique, it cannot be over tension at all.
Very nice presentation there. So as you told, actually, in our practice, we come across very less pediatric age group this time. So recently, when I was doing VISTA meeting, where there was a session on pediatric ACL injury in the Paris. So what they were coming across a lot of sports injuries, lot of pediatric sports injury kids. So they were of opinion like, as you told, surgery is better because it leads to subsequent injuries and all. So getting the confidence of the patient, they were initially treating conservatively for most of the period, but still their coaches and their parents were asking for the surgery. So that was one thing, and their graft also, like they were having options for allograft, but still they avoid allograft for pediatric injury. For pediatric, they were preferring autograft only. So just want to know, like, what is your take on allograft or autograft?
No, there are a group of people who are using live allograft, which is from father or mother. And it has been very well been documented, and there are a couple of surgeons I know who are regularly using mother's allograft for doing the facial reconstruction. And they are also pretty satisfied. I think as we know that there is live liver transplant is happening, live kidney transplant is happening, like that. Live allograft is also the next thing which is being done, especially for those age group around 8 or 9-year-old age group, where you don't want to take the graft from the child, and the graft thickness will not be adequate also for the child. So they prefer mother's milk.
These kids will be most of the time hyperlax. You see, so any special precautions you want to take when you
For preventing hyperlaxia.
no, these kids will usually be hyperlax. They will have some hyperlaxity, generalized ligament laxity will be there. So when you are doing reconstruction, any special tips?
I mean, in a sense, this hyperlaxity, what will happen is by the time they are becoming mature, the laxity will become improvement. The laxity will improve also. So, to be honest, you don't have to over tension it. Compare the laxity. Just be normal, you will be fine.
And we have any special things? Post-operative we have.
Rehab is first 6 weeks you try to do protected rehab, not aggressive rehab, because children are already doing aggressively. So if you tell them to do aggressive rehab, they will go too aggressive. So do for a protected rehab, say use a knee brace for about 2 to 6 weeks, then make them to complex.
Suppose if you are doing, you probably do a bicycle sparring tibial tunnel. But some saying is that like predominantly they focus only on the femoral side, and tibial side they say when you make a tunnel, keep it in the midline, don't go to the medial side or lateral side. What is your take on that?
Tibial side what?
So normally when you do a tibial tunnel in the bicycle sparring technique, you do it throughout entirely through the bicycles. But some say in young age also it doesn't matter whether you do a bicycle sparring when the tunnel is small. Transfical, you can make the tunnel through the physis, but keep it in the midline. Don't take it medial or lateral. What your take on that?
No. Even if you are doing a all-inside technique, our drill hole is only about 3.5 mm or 4 mm maximum.
Yeah.
Okay? Maybe 4 mm, maybe slightly bigger for a child.
Yeah.
If you want to avoid it, you can totally do the trans.
Right.
Where you have to adjust the angle of the jig.
But yeah, doing an entire two bicycle is a little bit difficult. So that's what I want.
We have to explain to the pros and cons of each procedure and then.
Sure.
Thank you, sir.
Thank you.
For talk on discoid meniscus.
Everyone. So after the geriatric age group, now we have been an excellent section on pediatrics. So I just we have then KNS has put some scope in the knee joint. So I just do some arthroscopic topic, which is both pediatric and adult involvement. So discoid meniscus is again most common condition, congenital abnormality we come across in the knee joint. So it was in way back in 1889. He first described it in lateral meniscus, and later on Watson Jones described it in 1930. So we all know that discoid meniscus is more common in Asian population than when compared to the Western world. And it is always mandatory that you should examine the opposite side, because 80% of these conditions are bilateral. So before understanding what is discoid meniscus, we will just try to understand what is a normal meniscus. So if you understand, if you see, they are semicircular fibrocartilage structure, and if you see on the lateral side, these have a peripheral rim of about 4 mm and they are width of about 12 mm. So why we should understand this, we'll see in the subsequent slides, and it covers about 70% of the tibial plateau. So when compared to lateral, the medial meniscus is more stable. It is more has the capsular and attachment, so it is more stable. and it covers up to 50% of the tibial plateau. So these meniscus have a very structured collagen fibers. They have the type 1 collagen which are oriented in the radial fashion with few radial fibers in between. So this gives a very strong configuration of the meniscus which creates a hook stress which helps in even distribution of the pressure, joint pressure. It absorbs the shock, acts as a shock absorbers, and also provides joint stability and proprioception. So this is what happens in a discoid meniscus. When we come across a discoid meniscus, so if you see the normal meniscus, we have about 70% of the tibial plateau we can see, but in incomplete discoid meniscus, it is up to 80% coverage of the tibial plateau. And in complete discoid meniscus, the entire lateral tibial plateau gets covered by the meniscal analog, meniscal tissue. And when it comes to the morphology, so the beautiful radial fibers and longitudinal fibers architecture is lost here, and they are very much disorganized, and which is the cause for developing the tear. And also they have that mucinous degeneration. So this will make these tears more prone for developing tears in the discoid meniscus. So what are the various theories that has been described for the development of discoid meniscus is by Smiley et al. They showed that there might be an absorption failure in the central part of the meniscus which may cause discoid. Kaplan described that there can be a deficit posterior Risberg ligament, that is posterior meniscofemoral ligament, so which can produce an unstable type of discoid meniscus. And if you see, they are very common in heredity. So they run in families, and there are very several literatures where even the twins or both have a discoid meniscus. So there is a strong hereditary predisposition, and few theories have shown that there is a hypovascularization which leads to discoid meniscus. So we all know that we have to classify these meniscus to have a common deliberation and to define the treatment. So Wattenberg gives a very beautiful classification. It's like a complete, when it completely covers the entire tibial plateau, then it is incomplete when it covers around 80% of tibial plateau. This is the most unstable type, like it is called Risberg type, where there is the posterior meniscofemoral ligament is absent, and it is called Risberg type. Jordan et al. Realized that this may not be sufficient, so the stability of the ligament is important. So they described it as a stable and unstable variety. Then Ahan et al. Have come up with a very beautiful MRI classification where they have seen that depending upon the tear in the discoid meniscus, there is shift of the entire meniscus. So we will see in our case also. So they based on, if there is no shift, there is no tear, there will be no shift. If there is a posterior tear, there will be anterocentral shift. If there is an anterior tear, there will be posterocentral shift, and there will be central shift when there is a posterolateral tear. So it is very important now that you classify them as complete and incomplete, stable and unstable, and based on the type of tears you classify them. So what is its biomechanical importance? So Lin et al. Have studied that they produce an abnormal gait cycle. So they have also studied that there is some difference in the heel strike and mid-stand space of the gait cycle when in all the patients who have a discoid meniscus. So coming to the clinical features, it is most of these kids come into the adulthood and they remain asymptomatic except for having a snapping. So most of them will complain of snapping in the knee joint or click like sound in the knee joint, and also it is commonly known as snapping knee syndrome. So when the pain or the problem starts is once they develop a tear in the discoid meniscus. Once they develop a tear in the discoid meniscus, all the problems starts. Develop pain, effusion, loss of flexion extension, locking kind of symptoms. So it is very important you to classify the tear as we discussed before and the age of presentation so that you can give him the appropriate treatment. So there was a study where they have tried to find the predictive factors which would involve the cartilage injury. Like if the body mass is very high in the female gender and when the symptoms are persistent for a long time, these all will have an implication on the cartilage. So how to diagnose this? So the plain X-ray will give you the diagnosis. If you carefully observe, so there is this widening of the lateral joint space. So this is so typical of the discoid meniscus, and the fibula head will appear higher, and there is a squared lateral femoral condyle. There is also hypoplasia of lateral tibial spine and lateral femoral condyle notch, and there will be cupping and obliquity of lateral tibial plateau. So these findings can be picked up on the X-ray, and they can give you the diagnosis of discoid meniscus. So Ha et al. Have shown that the positive predictive value of these signs is about 10 to in the age group of 10 to 16 is about 76%. So coming to MRI, now MRI has become very important aspect to decide the treatment because if the patient is symptomatic and if the patient has a tear, then you try to treat it. So Silverman et al. Have given a certain criteria to diagnose discoid meniscus when there is a presence of band from anterior to posterior in 3 consecutive sections of 5 mm. So you diagnose them as a discoid. Also the bow tie side. So this Somato et al. Have given another criteria where they calculated the meniscus width to the ratio of the tibial plateau. So this ratio, the D by E into 100 on the sagittal view, on the coronal view, and on the sagittal view, this meniscal width, total meniscal width like A anterior horn and the posterior horn, that is A plus B by C. So these ratios, they have come that there is a sensitivity of predicting discoid meniscus is 95 to 97%. So after diagnosing it, so how to approach this? So this is our treatment algorithm which we described and we follow. So most of the time you try to treat conservatively. As long as possible, you try to treat conservatively for all the discoid meniscus. Only if they have a tear symptoms and there is a tear on the MRI, you still do rehab and try to give conservative line of treatment. If they don't appreciate, then you switch on to the surgical type of treatment where you do a meniscal saucerization, repair or fixation of the stability. So this study by Logan et al. They 18% were treated conservatively, of which again 40% needed surgery, and 82% which were treated surgically. There was a reoperation rate of about 17%. This is our case, which we had a bilateral affection of both the knee joints and he had a meniscal tear here on both the sides. So we did a arthroscopy for him. This was the right side where we did a saucerization procedure for him. So if you see, we started taking off the meniscus. So we really don't know what is the end point. So we have to keep taking gradually. So you can, you should really have a very good basket punches to take off this thick discoid meniscus here. So if you see, as we went ahead, we noticed there was a cleavage tear here. So that is the horizontal tear was deep seated here, and the ligament was stable here. So what we did is we further debulked it here, and then it depends. If you want to repair this horizontal tear, you can repair the horizontal tear, or you can, even if it is an unstable flap, you can just excise that flap all as well. So repair can be done by hashtag technique. So I decided to excise that so that the we could say this patient had bilateral affection, so we planned for bilateral. So now you see you were able to gain good complete discoid. The tibial plateau space was achieved, and this was stable enough.
So this was the same patient with the left side. So we started similar debulking procedure here for him. Sorry, just take. Because this is the interesting case where this was an unstable type. So there was a horizontal tap in this as well. Yeah. So there was a horizontal tear here as well. So we started debulking it here. So here we have to be little careful here because otherwise we try to resect the entire meniscus here. So if you don't realize that it is an unstable type, so we end up in removing the entire meniscus. So we took up a stitch, stabilizing stitch. We retracted the meniscus behind outside in technique, and then we repaired the posterior horn by all inside devices. So we used two all inside devices here to fix the posterior horn, and then two outside in devices, one in the body and one in the anterior horn, to again stabilize the entire meniscus. So if you see at the end, we did a micro fracture to provide some biologics for the healing of this meniscus, and this was the final thing. So we were able to debulk majority of the meniscus, and also we were able to repair. So this was the follow-up, and this patient is really doing good. So rehab is again important. You follow the same principle which we do for a meniscus repair. So this is the various literature, and they have told that saucerization and stabilization is a good technique, but also you should explain that there is a reoperation rate. The patient may develop a re-tear in about 17 to 32%. So the take-home message is the discoid meniscus is again a common congenital malformation. So the clinical presentation, we have to classify them as complete, incomplete, stable, unstable, presence of tears. And X-ray and MRI are very beautiful investigation modalities where you can identify them. Evaluate both the knee joints, and arthroscopic evaluation, saucerization, and repair is the standard procedure. Thank you.
Thank you. Any questions from the floor? Thank you.
Thank you.
Then I will come to the last talk. Professor Arivasan. Professor Arivasan to talk on knee dislocation.
First, I thank organizer, Pragala, and Professor Sivakumar for giving this opportunity. Sorry for giving congenital dislocation. So, it is a rare condition. It's very well diagnosed by birth. It is manifested by hyperextension of knee joint with varying degree of
tibial displacement. It varies from genorecurvatum to subluxation and dislocation. As far as epidemiology of the knee congenital the disorders concerned, it occurs in 1 lakh live births. The incidence is less than the incidence of congenital hip dislocation. Then it is commonly associated with, in 47% of the cases, hip dislocation in up to 50% of the cases. As far as etiology is concerned, several etiologies have been suggested. Main is mechanical causes where decreased intrauterine space and malposition of the fetus probable etiologies. As far as pathology is concerned, it is commonly associated with softish crowd. There is a fibrosis or contraction of the quadriceps and the anterior capsular contraction. Then the posterior placed hamstrings is not positioned anteriorly. It is acting as an extensor in spite of flexors. Then the intra-articularly the cruciate ligament is absent. So we have to address all the defects so that we can get very good results. So some of the cases associated with the syndromes, arthrogryposis, Larson's, resistance, Behr syndrome, Ehlers-Danlos syndrome. If it is associated with this syndrome, we cannot expect very good results. Then as far as clinical features is concerned, it is very simple to diagnose on inspection. There is a hyperextensive contraction with the transverse anterior spring fold due to short-turned limb. The deformity mean hyperextension can be so severe. In some cases, the feet is placed on either side of the head. So tibia have rotatory and valgus deformity. The hamstrings displaced anteriorly act as extensors. There may be general laxity of cruciate pathology and displaced productive ligaments. As far as investigation point of view, we can diagnose intrauterine life with help of ultrasound. The diagnosis of the CDP is primarily clinical, but confirmation by X-ray. But there is some role in arthrography in knee joints, where the pathological anatomy of the knee joint prior to surgery is we can understand. But there is some dispute for its usefulness. So the congenital dislocation of the knee is classified by CDK grading system into 3 grades. It's based on availability of the range of movement of the knee joint and X-ray. In grade 1, the range of movement of the knee joint is more than 90 degree. The X-ray findings there are the simple recurvatum. In grade 2, the available range of movement is around 30 to 90 degree. But there is a manifestation in radiology, the subluxation dislocation. In grade 3, the available range of movement is less than 30 degree dislocation. So as far as treatment point of view, most of the cases can be managed conservatively. Genital manipulative reduction, management of the reduction by cause is sufficient. So, if both knee and hip is dislocated, we have to treat knee first. As far as surgery is concerned, what is the indication for surgery? If the failure to gain 30 degree of knee flexion even after 3 months of conservative management, the aim of the surgery is to get 90 degree of flexion. That is our aim. So we have to address all the problems of the knee joint, that is quadriceps contracture, anterior knee capsular contracture, hamstring anterior placement, collateral ligament tightness, ACL absence by quadriceps lengthening, anterior capsular release, hamstring tendon posterior transposition, collateral mobilization, ACL recursion. So, as far as the operation is concerned, there are two procedures advised. One is percutaneous quadriceps release, as described by Roy and Crawford. In this technique, the IC has to hold the leg with knee maintaining maximum achievable flexion. The transverse is made one patella length superior to the patella in midline. The fascia of the rectus femoris is divided. Medial and lateral stab incision are made at the superior part of the patella to divide medial lateral quadriceps and retina. Then knee is forced into flexion. Reduction is felt. The next procedure is Paediatrics. The norm described Curtis and Bishop where long and midline incision made central portion of quadriceps tendon is incised in the patient to allow leeway advancement. If the release is not sufficient, a iliacal band is also released. Knee is divided transversely as far as collateral ligament and quadriceps muscle is mobilized. Knee is then reduced, flexed to 90 degrees. The quadriceps is resutured with the knee. But the Professor Benjamin et al. Proposed some modification. Laterally placed incision through which more extensive release of quadriceps can be performed, progress can be included. The advice extraphyseal non-anatomical ACL reconstruction. So all the procedure is successful, but the post-operative rehabilitation is very essential. So we have to immobilize knee in 30-degree flexion for 3 to 4 weeks. In older patients, CPM machine can be used to regain the motion during the first 3 to 6 weeks after surgery. Long leg brace is used for 6 to 12 months to prevent hyperextension of the knee. Some of the case from our institute, 4-year-old female child diagnosed congenital dislocation of left knee. Managed with a preoperative X-ray. Surgically by quadriceps. So intraoperative. So it is flux in 30-degree flexion. The flexion is managed with KY. So next case, the right side congenital dislocation of knee is 4-year-old female child. Immediate post-operative X-ray. 6 months follow-up X-ray. So patient is getting 30-degree knee flexion. Third case, syndromic child with multiple deformities of the joints. The knee deformity was managed with pyropic cross immobilization. The pre-manipulation X-ray. 2 months follow post-manipulation X-ray. 6 months follow X-ray. This is 6 months follow clinical picture where we can get 45 to 60 degree of knee flexion. Okay, thank you.
Yeah. So one thing is most of the cases as you said, conservative line of management is better. Should be try out. Sometimes over enthusiastic flexion or fracture also. Is there any is there any guideline to say that you have to stop like this? That's what. Anything like that.
So, gently we have to do. Move still with the child. So if you want to do any manipulation, come up not block patient. So gentle manipulation without damaging patients. So aim is to get 90 billion plus. That is sufficient. So we are going to give more stress, there's chance of hydrogen injury to the patient.
Now I request our chairperson, Professor B. Sivakumar, to honor Professor Ayush. We request Dr. Prahlad Kumar Singh to honor chairperson Professor B. Sivakumar and Dr. Ashok. Thank you, sir. Dear faculties and delegates, we cordially Thank you, sir. Dear faculties and delegates, we cordially invite you for the lunch. Kindly return back by 2:30 p.m. for the next session.
Hello, say, hello. Hello, say. Hello, say, Iran. Hello, say, hello. Say, Iran.
இது இது 3 நாள் சார், கோயம்புத்தூர் சார். இன்னும் வரல. நாம தான் பேசுறேன். ஒரு இடத்துல என்ன இருக்கலாம்.
சரி எங்க ஓ பாஞ்சு இது குளோரி வாங்கி வச்சா அது அப்படியே வாங்கிட்டு வச்சேன் சரி 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 தக்காளி மட்டும் தான் வாங்கிட்டு வந்துச்சு சரி சரி ஆ ஆ சரி 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 அது இப்போ நீங்கள் தானே தூக்கிப்பீங்க ஜெனடிஸ்க்காக ஒழுங்கா இருப்பீங்களா சரி சரி ஜெஸி அங்கிட்ட ஓடிக்கிட்டு இருக்கியா நினைக்கிறேன் சரி சரிங்களா சரி ஓ சரி சரி எங்களுக்கு 4 மணிக்கு முடிச்சிடுவோம் நான் 6 வீட்டில் போய் ஜாமான் வச்சுட்டு வசேன் எங்களுக்கு வீடியோ கிளிப் கான்ஃபரன்ஸ்ல தேட்டருக்கு வந்துடுறேன் தேட்டரில் இது கான்ஃபரன்ஸ் பண்ணுறாங்கன்னா வேற ஏதாவது இவங்க ஒன்று மாற்றி இருக்காங்க அந்த சரி நெட்டை ஆன் பண்ணி அது ஒர்க் பண்ணி பேசிட்டு சரி 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 நான் ஒரு 6 மணி 6 வரேன் எல்லாத்தையும் இருக்கு
Am I audible?
Yes, sir, you are audible, sir. Hello.
Sir, 2 minutes, sir, we'll start your session first.
Okay, okay, no issue.
Okay.
Sir,
Good afternoon.
good afternoon, sir.
Okay, it's very nice meeting you.
Thank you, sir. I miss you all. Because of unforeseen circumstances, I have to join you all virtually. Really, I miss you all, sir.
One thing, Malta, two people have attended the hybrid meeting when we started. One is the Richard, and the other one is you. So, we keep in the same platform because he is also doing robotics. You are also doing robotics. Let us keep in the same platform, okay?
Thank you so much, sir. Thank you. I'm just watching the program in Auto TV. Program going on well. Waiting for my turn.
Thank you, sir.
Yes. Good afternoon, sir.
Welcome. Look forward for a great session.
Thank you so much, sir. Thank you so much.
Yes, sir, we will move to the last session of the CME. It's on trauma. We invite Professor Rajmohan sir and Dr. Raja Manigandan sir to chair the session. Okay, sir. So you can start sharing your slides.
Okay.
So welcome you all for the post-lunch final session, trauma session. Where I thank the Professor Dr. Ashwin and the Preethi team for giving me this opportunity to chair the panel session. It's a very planned CLE program, E360. So that the trauma sessions, I think all the PGs will be more interested in day-to-day scenarios, more into the trauma. So first, the topic is a little bit of change in the program. First will be the talk by Mukesh Mohan via Zoom. It is about medial wall augmentation of distal femur fracture when it is needed. So you can start, sir.
Okay, thank you so much, sir. Good afternoon, everyone. I'm very happy and privileged to join you all. Even though I'm joining virtually, my heart is like there. Thank you, sir, Shivkumar sir, and Shobhekar, and the entire team of Preethi for giving me this opportunity. My
Given topic is the role of medial wall augmentation in distal femoral fracture. As we all know, distal femoral fractures is a As you all know, the distal femoral fractures are complex fractures where the treatment has to be individualized and depending upon the pattern of the fracture. For example, if it is a quickly articular fracture like a COPA, it needs an arthrotomy and screw fixation only. Whereas a simple extension into the supracondylar region needs an additional approach, also as an additional plate fixation, thereby increasing your surgical time. Even after technical advances, technical expertise, and lot of newer implants, distal femoral fractures always remains a dilemma to treat because of high incidence of non-union, implant failure, knee stiffness, and associated vascular and neural injuries, and thereby the high chances of infection. So when we need newer plating, as in any other articular fractures, the fracture extending to the metaphysical region, we can divide the femur into medial and lateral failure. So it is not only mandatory to restore the articular alignment, but also to movement metaphysical failure, so that to form a continuity to diaphragm, the weight bearing process should pass normally through the bone without affecting our provisional fixation. So, coming to the biomechanical aspects of distal femoral fixation, the comminuted supracondylar fracture is a special case where, because the region itself is a high stress region because of large forces acting at that region, a large quadriceps muscle and your adductor group of muscles, and also your gastroc muscles, each having a different deforming forces and creating a high stress region and that region. So that we need an adequate stability as well as strong fixation and reliable bony continuity has to be there. So, again, whenever there is a loss of medial column, these fractures are liable to fail. And if there is an associated osteoporosis, it can lead out to a poor fixation and distal fragment, resulting in fixation failure. And a special variety called a low spondylar fracture, where there is a less screw density in the distal fragment, again our fixation may fail. Again, our overzealous use of our locking plates and filling all the screws with locking screws, making the assembly a too rigid assembly, results in asymmetric union, resulting in a lot of implant failure and plate breakages. Which acts at this region, which makes these fractures a difficult fracture to treat. One is the cantilever process and another one is the compression process. And there are a lot of biomechanical studies which has analyzed the usage of single plate as well as a dual plate. And Adam et al. In a clinical biomechanical study, they have proved that if you use a single lateral plate, the distal fragment experiences a displacement of 0.4 mm under cantilever bending and 0.6 mm under compression if there is no medial void. If we use a bilateral plate, the fracture gap motion was significantly reduced to 0.13 mm, which shows that it is a stable fixation. What is the importance of medial fracture? Again, Masaya et al. Has analyzed the gap in medial side, and they have found that in a comminuted fracture, if there is more than 5 mm gap in the medial side, they result in more non-union. In a simple fracture, even more than 2 mm has caused more non-union rather than the plate span length. And the associated risk factors like smoking and uncontrolled blood sugar are additional risk factors. Again, Gotlang et al. Has evaluated the medial bone strength. They have evaluated the lateral walking plate fixation strength in a fracture model with a bone defect of about 1 centimeter. They have noted a displacement of 0.3 mm with an axial force of 400 newtons, which was acceptable range of micromotion if the gap is less than 1 centimeter. But alarmingly, if the defects of more than 1 centimeter, then the displacement was accelerated. So they have recommended bone graft if there are bone defects of more than 1 centimeter. Again, when to add medial plate, our Professor Rashid et al. Has published in Archives of Orthopedic Trauma and they have suggested that the gap is more than 2 centimeters to add a medial plate as well as bone grafting. And in a case of low transcondylar fractures, it is better to add one more medial plate. And periprosthetic fractures, where if we fix with only lateral plate, we may not be able to mobilize them as early as possible in the immediate post-operative period. But when we add a medial plate, the weight bearing process can be started early and the rehabilitation will be better. And in the case of paid lateral plate fixation, it's not non-union. We need to add a medial plate while we revise the fixation construct. And if there is a large medial hopos fracture, it's better to add a medial plate so that the continuity of the medial pillar is restored. And Sanders is the one who started with dual medial plating, and he has recommended dual plating for comminuted A3 fractures. So, what are the concerns about medial plating? What is the unfamiliar approach? Is the newer approach? So, whether we have a bit of the neurovascular structures in the medial side, and there is a belief that among surgeons that it would compromise the medial vascularity. There is a strong recommendation that we should maintain the medial soft tissue envelope, preferably not to use dissect the medial side so that the vascularity is preserved. But there was a study which by Rolling et al. They have found the retention of blood circulation after plating and addition of a medial plating. In that study, they have found that there is a 21.2 reduction in the distal femoral arterial contribution if they fix the lateral off plate. But if they add a medial reconstruction plate, it led to a total reduction of 25%. So, contrary to the belief that medial dissection is the one which causes reduction in the blood supply, the study shows that a lateral plating itself can cause disruption in the intraosseous blood supply of the distal femur. So this is a slide which shows the vascular pattern of the distal femur, which are analyzed for MRI as well as CT angiogram and gelatin angiography, and they have found that majority of the vascular insult occurs because of lateral off plating and not from the addition of the medial plate. And they have also noted that there is a safe medial interval even up to 16 centimeters proximal to the adductor for plating with little danger to the femoral artery nerve and their branches. And again, one more study, like the Geriatrics study, they said that whether lipo can be used on the medial side of the femur, and they have done the study in a cadaver and they have plated by lipo approaches. Plating, they have injected the contrast and they have dissected the specimen, and they found that there is no distribution of deep femoral artery because of our plating. So they concluded that lipo of the femur via medial approach is a feasible option, and distal 60% of the femoral length is safe for this approach. So what we use, like we usually use the patient in a supine position, we have to use a knee frame or pillow. Either we can use a single incision or dual incision. If you want to use a dual incision, we can use a routine lateral incision as we do for a distal femoral lateral plating, and we can add a medial incision under CM control. So these fractions can be done in a MIPO fashion also. If you want to use a single incision, it is better to use a midline incision. Either we can use the medial or lateral approach, the transarticular approach, and retrograde right axis. But we can do a midline incision, we can do an extended medial paravertebral approach, and we can entirely visualize the articular fragment. You can reduce it very well, fix it, and then you can provisionally fix it with your lateral plate, and then assess the medial column, and if you want, you can do at medial plate. In a case of stiff knee, previously stiff knee, or if there is a periprosthetic fracture, we want to have an extensile approach, then you can have an extensile approach with a medial osteotomy. Imagine distal femur like your distal humerus, where you can add an osteotomy for improved exposure. Likewise, you can add a tibial osteotomy for increased exposure. So my preferential approach would be a TARPO, where I make a midline single incision, and based on the severity of the condylar fracture, whether it is medial and lateral components involved, I will choose a medial or lateral fracture and do a provisional fixation of your particular flap. Infrapatellar release can be done to aid in further exposure. Like I said, even if you also have to be needed, we can. And after reconstructing that particular block, the lateral pillar is reconstructed by a long lateral distal development bed, preferably 10 to 13 hole, and it's passed in a submuscular pattern under image control, and the proximal fragment is fixed with either spanning or clustered screw, and the distal fragment is also fixed with the blocking screws, preferably five numbers. And after reconstructing the lateral pillar, then I would like to assess the medial soft tissue, the medial column. If there is less than 1 centimeter gap with stable fixation, then we don't need to do anything. And if the gap is less than 2 centimeter, we can add additional bone grafting. If the gap is more than 2 centimeter, definitely it is worth to add a medial plating and bone grafting. The plating can be done either in a parallel manner or in an orthogonal manner. So this is an example of the midline incision, and the exposure is an extensile approach. And you can do it also with the minimally invasive through the medial window. Here, this is the software. Yes, we have to mark the incision is just made at the medial border of our medial side of the knee, and the exposed and retracted as we do in a subfracture. We can expose the distal femoral condyle, and epiperiostally we can pass the plate towards your proximal femur, and at the middle of the thigh we make an incision to the lateral side of the sartorius. The sartorius along with the neurovascular bundle is retracted medially, and then we have to split the vascite, and we can reach the bone very well. So it's an example of a infomedial plating, proximal incision. So this cadaveric dissection shows that the medial plate and the neurovascular structures are very well far away from your plate and bone. So we can very well do it without any risk. Coming to your simple case example, is a 21-year-old male with floating knee injury. He had a grade 3A compound fracture with significant bone loss, but luckily he didn't have any neurovascular involvement, but he had an associated comminuted patella fracture. Half of the patella was already lost, and he had comminuted proximal metaphyseal fracture also. So initially wound debridement was done and knee spanning X-fix was done. Once wound debridement was done, and the lateral distal through the midline incision are exposed and reconstructed the pillar and plated the lateral side. Along with that, we plated the lateral tibial column also. Once fixing the first stage was over, we have reassessed and we found that there is a large gap in the supracondylar region, and so we planned for bone grafting along with our tubular graft. So the third stage, again we re-explored and debrided, and tubular grafting was done at the supracondylar region, and additionally added medial distal femoral plating. So this is the medial column is well restored with the tubular graft. The tubular graft is stacked up between the proximal end of the femur and also the medial condyle. So even that was very strong, and to protect that graft, I added medial distal femoral plate. So this is the post-operative X-ray, and you can see that medial locking plate is placed and lateral plate is fixed, and I have the medial tibial plate also, and along with the bone graft is also kept inside. This is after 4 months. There is consolidation occurring at the supracondylar region as well as the tibial condylar region, and this is the 6 weeks recovery, having a good range of motion, and the wounds are healed completely. This is the midline incision showing our top. And luckily he didn't have any neurovascular injury, and he is having a full flexion of the knee. But since he had a comminuted patella fracture, I have reconstructed the quadriceps tendon along with the patellar tendon, but still he has some amount of weakness of the quadriceps. So he is having a slight recurvatum deformity, but he is able to walk comfortably without any pain. So to conclude, the distal femoral medial plating is not risky and approach, in my opinion, makes intraoperative decision making easier and it avoids separate medial incision and additional time. And indications are very clear. If there is more than 2 centimeter medial void or no transcondylar fracture or a periprosthetic type C fracture with osteoporosis, it is better to add medial plate. And all the evidences in all the literature show excellent human follow-up of dual plated femoral fractures. Thank you for all patience here. Thank you.
Thank you, Mukesh. It was a nice presentation. Especially the fact that need to do a medial painting and well thought presentation and also a nice personal case presentation. Are there any questions?
Especially in young patients where medially proximally is much more bulkier. What's the trick in
A little bit louder.
Sir, I'm not able to hear you. Sorry.
Sir, good afternoon. Somsekhar here, sir. Especially in young muscular patients, proximally, how to avoid means what is there any trick to find out means you are not doing because it's much more bulkier. Distally, it's fine. You're going to be one or two planes muscular say. Whereas in the proximal end, there will be so much of muscles there. Is there any trick to dissect it out or how to do a safe passage in that window so that you can put at least 2 screws proximal end?
See, if I am very doubtful about the plane, then what I make is in the proximal middle third junction, I make a general incision and I usually identify the fascia and dissect it suprafacially to identify the muscle layer. And sometimes, if you are very concerned, you can use intraoperative ultrasound also to identify the vascular structure. So that you can very well go laterally to that. And you split the fascia vertically and then you can identify the sartorius. He is finding the sartorius. You find the sartorius, it is very, very easy to retract it laterally. The sartorius will push all the neurovascular structures medially and you will bang on the fever. You have to dissect the back side. Definitely there will be some amount of bleeding, but you can very well do it. Thank you.
Dr. Sir, Dr. Steve here. So one question is, you have said that effect of more than 2 centimeters, you take account whether to go for medial plating. What is the limitation? 2 centimeters is okay, more than 2 is okay. If it is more than 8, more than 10 centimeters, still prefer a medial plating with tubular bone graft or you have any?
Yeah,
the limitations
in the case example which I showed, the defect was more than 6 centimeters. So I relied more on tubular graft rather than the plate. The plate is to just support the tubular graft, and that is not always the truth. Like we have to jack up the tibia from the medial end of the condyle to the proximal end. You have to feel the rock hard of your graft not fitting. Then you have to support the graft along with your plate. So definitely it's a high stress region. This can also fail. If your biology fails, all our fixation are going to fail. So we have to rely more on biology. The fixation is just going to help along. So if there is severe loss, then you have to add either allograft or autograft. Autografts are always better. But in cases where the autograft is not feasible, then you have to add allograft with the risk of infection and delay remain and all.
Coming to the plating on which surface you prefer, most of the times when we plate immediately.
Sorry, I'm not able to hear you.
If you are putting a plate on the medial side, which surface do you usually prefer? It's more of an anteromedial or exactly on the medial surface?
Yeah,
because countering of the plate is more important here. However you counter, whether you take a 3.5, 4.5, the anterior edge of the plate is seen more prominent in most of the patients. So you prefer an actual medial surface plate or an anteromedial?
In the distal region, you need to ask in the
distal region, medial.
Okay. The exact medially we cannot go. And if you go exact medially, the proximal fixation will be a difficulty. Either you have to twist your plate to get a hold in the anteromedial portion of the proximal fragment, and I usually place the plate in the anteromedial portion of the distal tract. But if you keep it exact medially, the proximal fixation will also lie exact medially, and that will be a difficult way to put a screw. So it is better to fix the plate if you have a large bending pliers.
For questions, we can go for next topic. Thank you, Mukesh Mohan, for a nice presentation. Joining.
Thank you, thank you, thank you.
We invite Professor Mohan for his topic on periprosthetic fractures.
Teachers and colleagues. This is that the post lunch we are having this session, we know pretty well that we feel rosy, including me. Right. However, we make it more interesting. This topic can be attached to the replacement session also. Fractures around the knee, which we commonly encounter scenario where we have a lot of cases done by the mass insurance schemes, and even the urban, semi-urban areas, we have a lot of knees done. What is important is after the knees, the rehabilitation, post-op rehabilitation is very important. Should have understood properly so that the patient does not have a stiff knee or restricted range of motion, other issues related to it. So what is important is the prevention of those problems which will prevent the periprosthetic fractures. In this introduction, I will proceed for the epidemiology. Roughly, the percentage of periprosthetic fractures will be 0.3 to 2.5% of all PKS, which can also vary in the tibia, more in the supraphalangeal region, and somewhat less in the tibial region. And these are the risk factors where which could be avoided or which should be identified at the early stages so that these patients do not develop this periprosthetic fracture. Say, for example, intraoperatively, more of a medial tibial tracheitis and poor bone quality is osteoporosis, elderly individuals, long steroid use, rheumatoid arthrophytosis or joint stiffness, stress shielding between two implants, one proximally and one distally, local osteolysis, stiffness, and neurological disorders, and ultimately the notch, the tunnel notch, which you do regularly for all the cases. Sorry, notching which you check regularly for all the cases. So the evaluation should be pain. The patient comes with pain in the you must and you must take proper X-rays, which I will do in the next slide. The laboratory values, you are always the confused that whether it's infection, pain is due to infection or some loosening of the implant or a fracture, periprosthetic fracture. The pre-injury mobility should be assessed because most of the time the patient can have a stiff knee only with 20 degrees or 30 degrees of movement. Some people will be having a tissue section deformity for the knee replacement, and that's a very important factor which should be studied. And instability. So we have to study the stability and also the fracture. Radiographs, of course, a proper AP and lateral view of the knee is to be done. The full length of the femur and the tibia is, if possible, is better to be taken, and the previous X-rays should be studied before planning the management for these cases. CT scan, of course, will be able to tell the exact fracture line and the component and the implant design, the dimensions also will be told. So previously, we used to take stress X-rays, but after this CT, especially the artifact spanning cuts, the CT, you will be able to identify whether these implants are stable or not. That also should be well studied with the CT. And the open box or closed box, the tunnel components, you must look for the open box. If there is open box, it's well and good. You can plan for an intramedullary implant. You can do intramedullary implant if at all patient has these fractures. Coming to the supracondylar fractures, it's in the periprosthetic region. Thoraback, this classification is a nice classification. One will be the undisplaced, and two will be the displaced fracture away from the implant, and the three will be the implant which is unstable. So this is the Thoraback's classification, and of course the treatment is the same. I mean, what I put in the lower aspects. If it's an undisplaced, better go for a conservative line of management. You all know the conservative line of management helps a lot, especially in osteoporotic individuals. If you want to go and stabilize, sometimes you may do more harm than good to the patients. So you must be very cautious. So in some patients, in undisplaced fractures, you can go for conservative line of management, and distal femoral logging compression plate or intramedullary nail can be chosen as implants of choice for fixing the extraarticular fractures. And when they are these implants are unstable, you have to go for plating or with the revision or distal femoral resection. So if the implant is stable, and this is the slide to show that if the implant is stable, these are the various options. If it is in the metaphyseal region or with bone loss, where there is severe osteoporosis, revision arthroplasty, right? Distal portion. And the fractures at the level of the proximal cut. The plate, you can use a plate, and just proximal to it, you can go for intramedullary nail or plate. And the intramedullary nails are advised, even though it's there in the theory, but in practice, most of the time we always go for So this is the algorithm for the supracondylar fractures. You accept whether the femoral component is stable or unstable, and if the femoral component is stable by PT, if there is a displacement or conversion based on that you decide. If there is no or minimal displacement, you conserve. If it is displaced but still reducible, you go for either a plate or a nail. And if there is severe displacement and the bone quality is poor, you go for a revision TKA. Coming to the tibia, periprosthetic fracture, and this is the useful classification for the periprosthetic fracture of the tibia. One will be at the level of the base plate, and two will be at the level of the tip of the stem, and three will be in a fracture distal to the stem, and four will be some apophyseal injury like tibial fracture. So based on these, we have to plan the location of the fracture. We have to plan the fixation modalities. So if it is stable, you go for the, say if it's a tibial plate, then you go for that. And if it's unstable, you have to go for the other one. So like that, based on the location of the fracture, either the tibial plate or adjacent to the stem or below the stem. You have to see the three things of categories of implant or looser implant or intra fractures. Of course, a well-fixed implant, if it is undisplaced, it's stable, I can go for a conservative line of management. If it is displaced fracture, you should go for a fixation, and if there is any intra fracture, if this is the line of management with the tibia, either on the tibial plate, adjacent to stem or below the stem. This is one more classification which has been also published, which goes by the mnemonics of ABCD here. The A will be apophyseal, the tibial tubercle fracture, and the B will be the bed or the tibial tray or the base involvement. C will be the clear of the implant bed, that is distal to the implant, and the D will be dividing. Sometimes the hip and the knee come together, and you will be having a division area where you can have a D and E, each of the two bones. You have to plan the management, and you have to be facing articular surface. That is the patella and receptors patella when you go for a fracture. You have to plan the procedure based on the merits. That is about this unified classification system for periprosthetic fracture. So the principles in open direction interpretation of periprosthetic fracture will be: identify the location, where is it, located, and then you have to plan it, either intramedullary vein or LCP. And TKA implants should be stable for this form of restore the mechanical axis and the joint line axis, achieve a very stable fixation, span the entire length of the femur. So that's very important, and I show you where we have spanned the entire femur so that the patients don't have stress. This is one of the cases, a 60 years old female who underwent a total knee replacement all for 4 years before. Sustained a trivial fall at home. You know, these are all like immunity fractures. They have a trivial fall and sustained fracture. And type 2 treated with the distal femoral locking compression plate and synthetic bone grafting. Because of the osteoporosis, we have done a synthetic bone grafting here. With another case, a 70-year-old female underwent TKA 5 years earlier. Patient came with the fall from a bite. Again, it's Geriatrics type 2, where the bone stock was reasonably good and we didn't graft it. You'll be able to see the entire length of the plate, spanning the entire femur. And you'll be always able to see the last screw as a monocortical screw to prevent the stress shielding of the implant. That's the so this is a 2 years follow-up. Another case, 70-year-old female, bilateral bicompartmental OA. We posted for the stage bilateral TKA. First, we started with the left, and while doing the procedure, after the procedure, we always check with the CM, always we check with the CM. We are able to find a fracture distal to the stem. So that was the fact that we identified. We immediately plated it. And this patient was immobilized with a long knee brace only. And only the weight bearing was delayed for some time, say for example, for 6 weeks, and then the patient was given a full weight bearing. And this is the follow-up which you see. Patient fracture as united. Patient happily came for the right TKA also, which means the team here is able to convince the patient very well. So that's the So this is a tuberosity fracture, a revision TKA, an intraoperative tuberosity fracture. So after removal of the spacer, cement, we have gone for a fixation. So where this actually the patella, there will be a tightness of that, and once we did a reversion, the tuberosity was fractured and we have fixed. Another case, a 66-year-old female, history of trauma 4 years earlier, underwent multiple screw fixation in some other center. She came with progressive pain and inability. We will be surprised to see such fixations in the scrotangular region. And the plan was to do a metal exit and totally replacement. So here, when we did a total knee replacement, the medial condyle got fractured, so especially in the articular region, and the patient was then ablated. So these are all the intraoperative fractures which you should have to keep in mind following the stiff knee. So when to do a revision or a distal replacement? So when the implant is very loose, with insufficient bone stock, not sufficient for osteoporosis, and unable to handle multiple surgeries, severely osteoporotic bone, multiple failed osteoporosis. So these are the situations where you may have to go for a DFR, and you must plan for a DFR. So the post-operative management, you must following the fracture fixations, you must go for an immediate and rapid mobilization. DVT prophylaxis is mandatory, and weight bearing and active movement after the fracture again should be started. So to summarize, the incidence will continue to grow, as you all know. The number of cases and the number of surgeries done are increasing, and preoperative evaluation is a must. You must evaluate what the reason for the pain and what are the fractures. You have to evaluate the fracture configuration and the level of the fractures, and then you have to plan it. LCP can be a multi-pole, multi-directional plate. You have different plates. So you should not think only a single plate or a mere plate alone is sufficient. You must keep the longest plates. Sometimes you may require long cables because you may have additional fractures when you go inside. The beauty of these fractures, periprosthetic fractures, you may have to be prepared for the additional fractures whenever you go inside. And the plate or intramedullary combination or plate combined with intramedullary nailing confers the greatest stability, like what Kesh was telling. So instead of the intramedullary nailing, he was using the tubular grafts and plates. So that's it gives an additional biomechanical strength. So the plate with the intramedullary nail combination sometimes confer greater stability and strength. And the DFR, distal femoral resection, allows early repairing, but even though the technique is very much demanding, and one is indicated cases you have to go for DFR. Thank you very much. Thank you.
Thank you, sir, for making this session very interesting session. Any questions from you?
Like how long it would stand up, like you are doing that, like so that so is there any thing how long training or
the literature or anything supports span the entire length of the femur.
your fracture was just above the right, but you have put such a long plate. Can we put a small plate at or we need to really
It's even when Mukesh was presenting, set prices are very high in stock on it. So it's better you go to the proximal diabetes. So once you go to the proximal diabetes, again the set prices you have the supplemental treatment also. So it's better you expand the entire length of the femur. Whatever plate which is longer, you should keep 30 more or even more than that. It's always safe to do that.
That is the point, because unless they say the literature like expand the entire region.
Sir, other than fracture pattern, how do you assess the component stability?
That's what we told. The fracture line extending in the X-ray also will be able to identify. The next thing is you have to take a stick, especially the artifact sparing cuts, CT sections you have to take, so that you will be able to assess whether the implant is loose or not. The pre-existing grooves of loose implant will be definitely revealed.
Here says shows administration at progressive lysis artifact sparing CT should ask greater than this. Sure that the matter the implant basis is that is there then in terms of basic function. Plan accordingly means it should not be treated as another. It has a revision. Yeah, and probably we will be writing basic.
So any experience in correlation with the nature of implant use? Yes, CR information. Very classic.
So the box, especially the debut implants, we have box so that we can do that box, and you have an additional only to open the intramedullary. But I don't know how far it is possible to use a dot nail or supracondylar fixation. That we are not used that nail. However, there is a intramedullary nail there. Even then, for extracondylar fractures, now the implant of charges will be one with the LCD band and intramedullary nail, whatever it is. Rather than any disadvantage. So, I personally, I don't have any experience by opening the box and doing it.
And fractures. Those patients who had those patients have fractures. Is that if you have undersized your notching is a CRPS, theoretically, if you medialize a PS box, then you can have a fracture. Inside, if the techniques are very right, regarding box cut and distal nail, the diaphyseal fractures can be treated with that. Whereas if you are just near the metaphysis, it will not be able to negotiate plate distally, or you will not be able to get so you won't get a typical rotational as well as axial stability that will not be able to maintain that. That situations are experienced only plating plates or plates nails.
Last one.
Okay.
Especially comes to periprosthetic fractures. You see the recent increase of periprosthetic fractures for the last 3-4 years. It's still one of the modifications of the Aurora. Because if you take a time 3 Aurora back, there is more any fractures which occurs below the condylar femur cell plate. So only a lateral plating will cause failure. It's one of the great advantages what we have. Because my topic I was going through. Any fracture, I think it's a modification of the Aurora back. I think it's going to come in stage 4. It's modification of stage type 3 plus. It's medial condyle below the plane of the femoral cell. Put just a lateral condyle, it's going to go for failure. So you need to add a medial plate again. And the length of the plate, if you see the principles of LCP, it's always 2.5 to 3 times the working distance. So almost at 7 cm it comes to 30 centimeters, it's almost 30.
There are no more questions. Thank you, sir. Thank you for your overall. So our next talk is column specific fixation of proximal tibia fractures by Professor John.
Now, first of all, I thank my professor and mentor, Professor and my partner, Professor Sudhakar, Kerala sir and his team for giving me this opportunity to be part of this CME. After extensive discussion and limited analysis of pediatric and geriatric knee problems, we have come to the bread and butter trauma, and most of the candidates are nowadays taking tibial plateau as destination. Let us see what is three-column concept. It really improves outcomes or not. So it's always a challenge to treat a complex tibial plateau fracture. We all know. The short cell classification is based on X-ray alone. It aims to identify the integrity of the posterior articular surface or posterior column. So this results in failure of restoration of alignment and results in inconcurrence of the articular surface, thereby leading to osteoarthritis. So with the advancement of 3D CT imaging, 3D reconstruction technology, the tibial backbone is being better evaluated in a multi-planar operation. So the idea of proximal tibia, three-column structure, opens the door to new fracture understanding. So these are some of the fascinating facts about the tibial plateau. I'm going into the details. What is more important is these 2 points. The tibial plateau angle, that is 87 degree, and the tibial slope angle is 9 degree. These two values are very important. We are going to go through the column concept. So the classification, we all know the short skirt, the AO, and then Polar move. What are the deficiencies? They are based on X-ray and 2D CT, and there is very poor understanding about the fracture pattern, and it doesn't address the posterior fragment at all. It doesn't guide in treatment protocol. So the idea of proximal area as a 3-column structure opens the door to a new fracture understanding. So it is a slew this theory of 3-column concept. We consider proximal area as a triangular trunk and divide it at transection as 3 columns. So we will go to the basic definition. What is a column? The column is defined as an articular depression in combination with the wall fracture. So that leads to a pure articular depression, which is the short skirt type 3. It is not a column fracture at all. It is classified as 0 column fracture. The column walls, otherwise the borders, are demarcated by 4 points on the CT image. What are the 4 points? Point first one is O. It represents the artificial axis of the 3 columns and is defined as the midpoint between the 2 tibial spines. Column point A is on the anterior tibial tuberosity. Point P represents the posterior surface of tibial plateau. Point C represents the most anterior border of tubular vein. And point D represents the posterior junction of proximal tibia. So based on that, we are going to divide the area with the 2 lines. The line AB divides it into medial and lateral segment, and line OD separates the much consistent posterolateral fragment, and line OC divides the much smaller posterolateral fragment. So what is the proposed advantage with this used theory of 3 column? More detailed information pertaining to the fracture morphology. It gives in-depth idea about degree of joint depression. It gives an idea about decision making on choice of implant as well as surgical approach. So let us see into the column as such. The 0 column corresponds to your short skirt type 3. It consists of a disturbed articular surface with intact walls. With increased sensitivity of CT to detect cortical depression, it has shown that central depression is not as common as previously was thought. So what is 1 column fracture? The short skirt type 1 and 2 are classical 1 column fracture as far as lateral column is concerned. The posterior shearing fracture is a 1 column posterior column fracture which is not included in short skirt classification. The isolated occurrence of medial condyle fracture or medial column fracture is very rare. So what is 2 column fractures? There are 3 types. The most common bicondylar fracture. The next one is anterolateral fracture with a separate posterior articular depression with a break in the posterior wall, which is considered as a 2 column fracture consisting of lateral and posterior column fracture. The more common typical 2 column fracture is the anteromedial fracture, a separate posteromedial fragment, which is a consistent finding which traditionally belongs to the original short skirt type 4, otherwise called as the medial condyle fracture. So the 3 column fracture, to consider this as a 3 column fracture, it should have at least 1 independent articular fragment in each column. So the most common 3 column fracture is the traditional short skirt type 5 and type 6. It was observed that there is existence of 30% to 60% of posteromedial fragment in all type 6 fracture and 45% of posterolateral fragment in all lateral tibial plateau fracture. So this is the overall summary of 0 column, 1 column, 2 column and 3 column and its corresponding short skirt subtypes. So now we are going to the mechanism of injury and fracture pattern. So it is considered as a applied axial load with the position of knee during the axial load. So the axial load can be varus or largest character deforming force. The flexion and extension of knee is determined by the slope angle as measured on the lateral radiographic X-ray or on CT. The varus valgus force is determined by the medial tibial plateau angle, again measured on the CT or in the AP plane of the X-ray. So the posterior tibial slope angle again is defined as the angle created by the tibial plateau on the long axis of tibia in the sagittal plane. It is classically decreased or going to a negative value from its normal value if the injury occurs in extension mode, whereas if the value increases, then the injury occurs in flexion mode. Moving on to TPA, the decreased TPA indicates obviously it's a varus fracture, whereas normal value or increased value indicates it's a valgus force. So based on that, what are the fracture pattern we are going to get with the mechanism of injury? In one column fracture, the lateral column fractures are caused by valgus and axial force with the knee position of extension, whereas the medial column fractures are caused by varus and axial force with the knee position of extension, whereas isolated posterior column fractures are caused by mere shearing force due to axial load with the knee in a degree of flexion. Coming on to the two column fracture, lateral and posterior column. The lateral column fracture extending to the posterior column are the most common type of two column fracture. It is always associated with much articular depression. So if it is an extension and valgus force, you have to look for increased TPA and decreased DSA. If it is a flexion and valgus force, you have to go for increased or normal TPA and increased TSA. Coming on to the medial and posterior column, if it is an extension and varus force, the TPA will be decreased and the TSA also will be decreased. If it is a flexion and varus force, the TPA is again decreased, whereas the TSA will be increased. If it is a lateral and medial column, then you have to look for the wall. If the lateral wall is completed, then the force is extension and valgus. The medial wall is completed, then the force is extension and varus. The three column fractures are most complicated. Can be a combination of valgus, flexion, extension, varus, valgus force. So the same formula is applied as we applied for the two column fracture. So this is the chart depicting how we are going to evaluate a tibial plateau based on three column concept. So what are the cardinal rules of treatment? Always the primary fracture column should be recognized and tackled. The surgical approach is based on the column involved, and you have to look for the fracture whether it is failed in compression or tension mode, and it is to be noted and fixation is to be applied accordingly. So you have to always look into posterior column, and it has to be properly tackled. The soft tissue envelope should be handled with utmost care, and high velocity injuries and complex fractures are to be initially managed with the knee spanning exits, then go for definitive fixation. So treatment concept for zero column fracture, you have to go for stabilization is performed by minimally invasive technique. You can use the rafting screw, which is the keyword concept in this zero column fracture management. For one column fracture, the implant should be placed in a position to buttress the lateral column and prevent secondary valgus deformity via a standard lateral or anterolateral approach. For medial column fracture, a medial based implant should be applied to prevent varus deformity. With medial column fracture, it is important to note any concomitant posterolateral soft tissue injuries, and it has to be addressed at the time of surgery. For the less common isolated posterior column fracture, it has to be operated and plated from posterior surface to the anterior surface. So coming to the two column, we take the medial and posterior column. We have found out the values of TPA and TSA. For the extension and varus, you have to go for medial locking plate, whereas for flexion and varus, you have to go for medial and posterior locking plate by appropriate approach. For lateral and posterior column, for primary plating, the extension and valgus, you go for lateral column plating, whereas if it is flexion and valgus, you go for both lateral and posterior column plating, and choose the approach appropriately. If it is a medial and lateral column fracture, we will look for the wall combination and decide the plating. If it is a lateral wall combination, then it is an extension and valgus type, go for lateral column plating. If it is an extension and if it is a medial column combination, go for medial column plating. And the mechanism is extension and valgus. And what is the indication for secondary plating? If there is combination of medial wall, there is on the tension side, we go for secondary plating. Whereas in medial column fracture, if there is combination of lateral wall, go for secondary lateral column. So for three-column fracture, the same rule is applied. The implants is being placed as per the treatment algorithm. This is the overall algorithm for column concept management of all fractures. So how are you going to tackle the associated ligament and meniscus injury? All ruptured meniscus are to be repaired on the day one itself when you are tackling the fracture. The lateral collecting ligament injuries are to be repaired when the knee is found to be unstable to varus load, whereas the medial collecting ligament can be managed conservatively. The cruciate ligament are to be injuries are to be noted. It is to be repaired at a later date. So what are the concerns of this management of three-column fracture? Obviously, wound adhesions, plaque necrosis, infection, hardware irritation, neurovascular injury, implant failure, knee stiffness, and osteoarthritis. What are the solutions? Go for use of low-profile implants. Go for column-specific fixation based on compression and tension failure mode. Use modified approach. Have a 3D knowledge about the fracture pattern. Respect the soft tissue injury. So what are the newer techniques available in managing three-column fracture? These are the various newer techniques available. So this is a floppy lateral decubitus position for management of three-column fracture. There is another new approach called the posterior unital L-shaped approach. The patient is kept in a lateral decubitus floating position. Go for subchondral clustered KYS. Jail screw technique, where you put the screws in the form of jail doors. And the embedded rafting screw technique, which we already discussed. And inflation osteoplasty, where you use of an inflatable bony tamponade to elevate the fragment. Arthroscopic assisted reduction and internal fixation. What is in situ autograft technique? This involves mobilization of cancellous bone from the inferior and opposite part of the metathesis using an osteotope and elevate it to fill the defect. Direct posterolateral approach with the tubular osteotomy. Anterolateral approach with the femoral epicondylar osteotomy. A word of caution: you have to completely understand the concept before going for decision making. Always consider the mechanism of injury, status of soft tissue, 3D morphology. There should be individual skill and experience. Always don't hesitate to go for external fixation before going for any definitive management. If the soft tissue envelope is not good, and always be ready with all kind of implant armamentarium. What is the take-home message? So this three-column concept it gives new insight into the treatment of tibial plateau fracture. It again demonstrates higher inter-observer reliability. It supplements the conventional short-set classification. It is clinically relevant and guides the surgeon in preoperative planning. But the long-term effectiveness is to be proved by satisfactory radiological and functional outcome. However, this newer concept, together with the newly developed implant, can substantially improve the clinical results in complex tibial plateau fracture. So what next? Cross et al. Mapped the tibial plateau into 10 segments. This is the newer concept. So the three-column concept, it does and will improve the outcome. Thank you.
Thank you, sir. Thank you, Dr. Sir, for the useful information you gave. Any doubts from the group?
How does this definitely help in planning the approach? Like, when would you like to take such cases? Like, will it help us, like, suppose type 3 column fracture is there? How early you want to fix, how late you want to fix? That timing also will, this classification helps.
classification will give an idea about the column injury. So apart from that, you have to take into mind the of overlaying soft tissue. The soft tissue envelope is adequate and it is good, then you can go for definite fixation area. It is not good in most of the cases, it will be somewhat compromised only in 3 columns. So in that condition, they prefer to go for the settlement of the shock. So this column concept definitely helps and motivates doing plating. What I have understood, like whatever columns are there, you open that column and fix it. Is this for plating, or we can even utilize this for doing any minimal invasive technique like Elizero and all? And can we use this? No, they have not mentioned this for Elizero. They have mainly mentioned it for plating. You can use go for minimal invasive plating. For technique, it also. They have not mentioned this for plating. Elizero to take some decon.
What about the experience about the hybrid fixation? Minimal plate fixation, hybrid fixation. Minimal internal fixation and basic fixation.
Can be done. Can be done if you go for. You need not go for plating and all. You can go for hybrid fixation alone. But these are all further development into the concept availability of low profile implants, and the implant thickness is very minimal. You assess the fracture pattern. They are deviating away from this Excel fixator concept. They are using this Excel fixator only for temporary. They are not permanent fixation.
Sir, there was an X-ray showing 3 plates in proximal tibia. It should be started and post-immediate training in the lateral training. In case if you want to add the post-immediate, what is the order?
That's why we put this treatment algorithm. It depends upon how we are going to assess the fracture based on the unit column fracture. We assess the fracture based on the 2 angle values as well as some of the mechanism of injury, and based on that, you take the decision whether it is necessary to move or based on the findings to the decision.
So, what is the order like? We start with the post-immediate plate.
Yeah. It all depends upon the mechanism of injury. If the mechanism of injury is favoring post-immediate plate, if it is favoring some other plate, that would prefer as a first fixation, then you go for it. Then you necessarily go for it.
Yeah, hello. So, thank you, sir. Thank you, sir. We are going to the next topic by Dr. Sudhir Kumar regarding distal femur non-union dual fixation.
Good afternoon, everyone. We concentrate on acute fractures. Move on to the complications. So, without complications, for any such as orthopedic surgeon to practice, he is not getting any complicated cases, which means he is not doing any cases. He is an extraordinary, outstanding surgeon. The more complex cases you do, it means the more primary cases you are handling more. So before I start my topic, I would like to quote these beautiful words from Castiglione. He is one of the beautiful and handsome designer, Italian designer, who has given these words where he says there has to be irony both in the design and in the objects. But I see around me a professional disease of making everything too serious. One of my secrets is to joke all the time. So what does he mean? What does this picture with one eyes closed? Any implants, any design which comes to the market, initially once it becomes famous, it becomes this indiscriminately it has been overused. So obviously over a period of time we tend to get more complications. So the same history or revolutionary repeated in locking compression plate, where Krieger et al. In a series of 123 distal femur fractures, the first published literature in Journal of Orthopedic Trauma. Just look at the results. 96% healed without bone graft in a type C comminuted fracture. So, what is the world missing? So, there was a thought, all locking compression plates, use all distal fractures, use locking compression. But the whole world of the young surgeons forgot to know the concept of how to apply the principles of it. This was one of the main reasons to go for failure and eventually get a lot of complications in the subsequently published literature. So, obviously, you get more complications. What is the reported literature rate? 20%. Till date, if you take any literature, the amount of acute fractures in distal femur itself is 3%. But the surgical related complication itself is 20%. Way too high. So, before we go into the depth of treatment, we need to know why it fails to unite in distal femur fracture. Because it has got a more rigid construct, or is there a more instability fracture patterns as in K3 or C3, or sometimes could be a patient related fracture. Sometimes it could be a mixture of all three patients going for failure. So always remember, any fracture it heals primarily by compression or lax. A transverse fracture you achieve compression. An oblique fracture you achieve lax. But in distal femur it must be rigidly immobilized. Take an example of this patient. A long oblique fracture distal femur extending into the articular surface. The surgeon has used 2 lax screws, long plate, beautifully spanned. And with a good lax, good rigid fixation, eventually it heals. A same 53-year-old long oblique distal fracture, very beautifully reduced, use 3 lax screws. But if the patient starts weight bearing, it goes for failure. So what are the reasons for failure here? So once you see a retrospectively why it failed, the surgeon has used a rigid construct, putting all the screws proximally. Okay, then that is a too rigid construct. Then comes to see the working length of the plate. If you just see the fracture is extending till here. If you see just the length of the plate, it's very too short. Whenever this patient was obese, he went on to failure. So always never blame the plate. The plate is very too thin, it's not a company, it's not bad. Okay, there are certain plates which can keep alone, but it basically lies in the principles of applying the FCP in order to avoid complications. The short plate, poor working length, both the factors led to failure in this patient. Another case, a distal femur, comminuted fracture. Again, the surgeon used a short length plate. The patient starts weight bearing, it goes for failure. And we need to see retrospectively what has happened. Again, the medial comminution, short length of the plate, and the shaft is lateralized. You carefully see the shaft is lateralized here. And one remember, screws, anything which is closer to the fracture site, it gives more rigid to the fracture. So eventually it goes for failure. So always remember, any comminuted acute pressure, it better heals by micromotion mode of healing. So what do you mean by micromotion mode of healing? It's a non-rigid fixation with a long plate which induces calcium formation. So how do we achieve micromotion? As I said, the length of the plate, take always a long plate. It should be minimum more than 10. How do you decide 10 or 12 or 13? It should be 2.5 to 3 times the working distance of the fracture. So if the fracture, if you measure in the articular surface, it is around 10 centimeters. So you need to multiply by 3 times. So 30 centimeters. So 30 centimeters roughly for our Indian scenario, it corresponds to 12 hole or 13 hole. So this should be the principles. Then the other design will be always put the screws on alternate hole and start from the proximal. This is mainly because to allow a micromotion, so there is even distribution of stress across the plate. So this is how you get a micromotion. But to the same construct, you can make it more rigid. How? Put all the screws above proximally. That is, you are increasing the proximal screw density. Obviously, it becomes a too rigid construct. With too rigid constructs, there are high non-linear rates. So your primary fixation becomes one of the reasons to go for. If your primary fixation is solid enough, the number of non-linear cases you tend to get it less and less. So always remember, the plate has got no character here. It's the screws, how we put gives character to the plate. Whether it's a condylar screw, whether it's a locking screw, whether you do open or you do a before. The principles of applying the plate should be very clear. So if you take other instability patterns like fractures, open fractures, metabolization conditions like A3 or C3 with a medial defect of more than 2 centimeters, fracture defects at the previous TKR, there are factors which can also give rise to non-linear. So coming to the first day of the principles of treatment, the most challenging two things for the operating surgeons when you are dealing with an established non-linear osteopenia and bone loss. Why? Because of the compounding 2 surgeries, previous surgery, surgery 1, revision surgery 2, revision surgery 3. So it goes, the distal femur goes on for osteopenia. Why bone loss?
because of the varus collapse, there is a medial cortical attrition. Slowly the defect starts to creep up. So any surgeon you want to have it, you want to address the non-union, you have to take these 2-3 points in consideration. The first thing is modification medial bone loss, where you need to have it aggressive tubular structure, and you need to improve the biology. How do you improve the biology? Use the ideal daughter. You need to provide a stable rigid fixation. You want a rigid fixation in non-union. However, when you compare an acute comminuted fracture, you want a non-rigid fixation. Why rigid fixation here? It has already failed. You have to take graft and you are creating the environment to go for it. So let us come to the examples which I already mentioned here. Look at this. We went in and used a long plate. See the length of the plate used here. So we, along with the length of the plate, we use an intramedullary tubular graft. The amount of callus it is growing. 3 months old post of it. The same what I discussed, short plate. Revised with the long plate, use the intramedullary tubular along with the it went on union. So next coming, apart from once you have put an isolated working plate, the other options would be any indications for medial plate. As already Mukesh sir has said, in acute scenario, in non-unions, any non-unions, once you go in, when you debride all, remove all the next main aim will be to realign. So once you realign, it is medial malalignment or medial comminution gap, and then you get a defect of more than 2 centimeters. Again, you need to put a medial plating. It's all more or less the same indications will at least for acute scenario. So dual plating, we have known it has shown to a very good resistance to lateral bending, and it's got a very good stiffness. The construct stiffness is very high. So again, coming to a few examples, the 53-year-old comminuted metaphyseal fracture, type A3, fixed with a short plate. Patient starts weight bearing with plates. There is a race between union and the plate to hold. This is exactly after 9 months it gets failed. Eventually the plate has to give up. The surgeon again goes in, puts the same graft. What is the biggest problem here? The same length of the blade is being used. Eventually this also fails. So when the patient presented to us, we did nothing. We need to use a routine non-union process, remove all the fibrous tissues, open up the medullary canal, use the long blade laterally immediately with back graft. This is the union what we get at that of movement. Same another patient, 50 years, CKD, having dialysis twice a week, C3 fracture, diffuse osteoporosis. The primary surgeon has used a retrograde nail, failed miserably because of the complexity of the fracture along with osteoporosis. Since we have a very good anesthesia team, we went because we were of the comorbid condition. That anesthesia we went, we removed the nail, we did a TIPO, a minimally invasive plating on the lateral of the medial side with bone marrow. Since the patient had comorbid, we did not take the risk to go for it. Look at the 9 months. As attempted, it has gone for a union. This is a good functional range of motion the patient has. Another young chap, 23 years old, a metaphyseal non-union with attrition of the medial quadrant, complete opus non-union. Same concept, tubular graft, dual plating. Another 41 years, same concept. If there is subsequent primary surgeon trying to collapse to get a fracture union, but it has failed miserably. Again, you distracted it, get the alignment, and put a dual plating in. This is the X-ray you can see last where it has united injury. Another type 3 fractures, any medial plating, even in certain non-union, where you suspect where the patient is going to have a failure when you are starting in and around the bed page, especially a type 3 fracture. So you can even add a prophylactic in order to prevent non-union. These are the comminuted fractures. We did a lateral plating, and at the end of 6 weeks, we added a medial plating, and this is at the end of 8 months. See the solid union formation. So another mode of fixation will be a composite fixation, where you can use a combination of nail and plate. The ideal indications will be when you have a segmental bone loss of more than 5 cm. The only thing is it should not be a circumferential. One contact has to be intact so that you get a good packing of the graft with a nail long plate. Example, 38-year-old male obese, 110 kg, polytrauma. We went and did an anti-grade nail with a close reduction. We may not, at the end of, you can just see this X-ray. It is going to fail when the patient starts weight bearing because there is no hold over the system. So we went after 6 weeks, we went in. The fibrous tissue, once we removed it, it was a huge anteromedial defect. quick graph, the union, what you get when you added to the plate was added, you get a more rigid concept. So what happens when you get a deficit or more loss of more than 8 to 10 centimeters? Very high velocity injuries, and most of these injuries are grade 3 injuries, and 20% of these fractures are. So this was a 19-year-old male, RTA, severe combination, circumferential diaphragm loss. He presented to us only 41 days old. He was operated outside with an orthopedics. So we went in, debrided the whole area, removed all the loose, non-vascular, loose fragments, put a orthopedics, plan for distraction oxygen. So this was on the day 5, subsequent X-ray. See, look at this large, completely distracted. So we got almost length of around 5 to 6 centimeters. The patient still is under follow last month. We have stopped the distraction so that we wanted the fracture to consolidate, and we are planning for it definitively. The other techniques will be a modified Kapanas technique as described by our Dean Dalai from Ganga Hospital. Usually it's a, they use a vascularized tubular graft where they talk in a you need to have a gold band for this. They take a shape of the femur. Intramedullary, they dock the vascularized tubular graft. Then they anastomose the distal genicular artery of the femur. Then dock into the bone blast. Fixed way. They are used in this 19 case series, so it requires a lot of skillful, the complication rates are very high. So the take home message would be any fresh comminuted fracture, non-rigid fixation is the principle. For a non-union, you should have a rigid fixation. General principles like depending upon the defect, what and all you can use for less than 2 centimeters, ideal long SPP is sufficient. For 2 to 7 defects, you can use a tubular accompanied with a middle plating or a nail. If it is more than 10 centimeters, your distraction osteogenesis can be used. Thank you.
There was an extensive and authoritative presentation. Any questions from the
Really, as the person told, it was an extensive and authoritative presentation. Really, you have taken a lot of efforts, and you have really shown like what are the causes for non-Indian and how the principles will influence your outcome and how we can address it. And also, you have shown various ways. So, how we can address the tubular structure, highlighted dual plating, and also intramedullary nail and plating. So I think so it's a complete thing. And as also you told that prophylactic fixation. So we need not wait for the fracture to go for a non-union. So it is better that you go and do a prophylactic fixation. So I think so this thing. So one example like what I have seen there is something called palliative fixation also. So there was a very critically old female, like what you did for the CKD patient. So we try to do a minimalistic approach, and then again you augmented. Similarly, when I was in US, so Professor White, what he did is he had put a cement block. There was similarly osteoporotic distal femur fracture. So he used cement spacer. And he used one intramedullary plate over that another plate. So the thing is, he wanted pain-free thing. So they did not want aim that to achieve the union. I think so. Last one thing you could have told about tumor processes or something. That is then it would have been totally complete. That one thing, even in very complex resistant, yeah, but it's like even for very process, yeah, because we will be worrying about the intelligence. It was a very expensive cost. I think there are a few other techniques. One doctor called Dr. Mukhi from Harvard. He uses the lateral locking, right? And for the tactical of the patient, for non, he uses the mesh cage. Mesh cage, 5 sessions are very important. But even for trauma, immediately it just fixes, that's the mesh cage and puts it in. So there are not large series in that, but these are the various techniques which you should do.
Thank you, Steve. The next talk will be treatment options for HOPAS and missed HOPAS fracture by Dr. T. Vinod.
The name sometimes appears to be included like HOPAS fracture. They may be missed sometimes in routine polytrauma cases due to overlapping images of the chondrite or poor radiology interpretation, or we just consider it to be a other in polytrauma like floating injury, tibial lateral fracture, and it may be. The first feature, so there's a lateral plate avulsion. Second, a complex compound open bicondylar along with the supracondylar extension distal femur. Non-union medial condyle along with the open. And the last picture is where he was already operated with the poor selection of the implant where he failed and underwent for non-union. So, already we know that the mechanism of injury is due to high velocity injury where the position of the knee is held in flexion greater than 90 degrees with the external rotation of the leg, keeping up that head where the knee landed directly into the ground or at the dashboard injury, causing shearing between the tibial plateau and the femoral cordae, and which leads to the HOPAS fracture. 8 to 30% of the fractures are mostly missed. The routine X-ray, which include AP and lateral, should also include oblique view and sideline view to identify the fracture. CT is the gold standard and indicated cases where the suspect ligament injury, MRI is definitely indicated. It may be associated with a floating knee fracture, apart from that, tissue like patellar tendon or quadriceps, then patellar dislocation also may be associated with it. When the soft tissue structure are involved, nearly 50% of this will be incarcerated within the fracture fragment. Therefore, any patient presenting with a patellar dislocation with a suspected HOPAS fracture should not be reduced in the casualty because it may cause further tendon injury. Later in 1970, proposed this classification of HOPAS fracture to three types. Type 1, the fracture line is parallel to the posterior part of the femur. Type 2, where the fracture line is parallel to the posterior condyle of the femur, is further classified into A, B, C based on the size of the fragment. And type 3 is oblique fracture. We declared it to be a prognostic classification because he and Bell et al. Reported incidence of avascular necrosis in small HOPAS fracture of approximately 2%, which was significantly associated with posterior approach while fixing. Since the blood supply to the condyle, that is the HOPAS fragment, is mainly enters the femur throat posterior part by the superior medial and the lateral geniculate artery. The extorsion, introsseous blood supply will be definitely affected in case where the fracture is much more distant. One of the demerits is it does not wait for surgical approach and the fixation treatment. Type 1, type 2, type 3. We think that type 3 is severity and it is complicated. No, type 2 is a bit complicated because type A, type 2A, where the fracture fragment is greater than 75%, will involve the attachment of gastrocnemius and popliteus and there will be minimum blood supply. Where type 2B and type 2C, the fragments are very small or sometimes there may not be any attachment of soft tissue. So it becomes a avascularized or loose fragment. Therefore, the fixation of the fragment will go for AVN around 2%. The blood supply of the lateral condyle is better, therefore the lateral condyle HOPAS is better than the medial condyle. AVO also proposed the HOPAS fracture classification as type 3.3, 3.2 and bicondylar fracture as 3.3. And they themselves also dictated approaches and the various fracture fixation methods. Due to the advent of CT, the extent of classification and the identification of the plane of the fracture, size of the fracture, and the comminution and the extent of the fracture, everything becomes easy so that we may not miss it and we can execute proper approach along with the proper selection of implant preoperatively. Therefore, the management principle includes high index of clinical suspicion and the radiological trauma series, radiograph, proper X-ray, CT, the sagittal and the axial cuts of the CT are very important to know the orientation of the fracture. The goals of the treatment include anatomical reduction of the articular surface, preservation of the blood supply through the use of minimally invasive approach, stable intraarticular rigid fixation is must, and early demobilization for successful outcome. Anatomy of the fracture includes characteristics like size, plane of the fracture, comminution, height, proximal extent, and we have to know the blood supply while going for approach. Right surgical approach is right implant of choice will lead to good anatomical reduction and early mobilization is needed. Based on the size of the fracture, if it is large enough, the approaches can be either parapatellar approach or direct approach or posterior approach can be used. And implant through or plate, depending upon the fracture fragment, can be added. Comminution when involved medial or lateral or intermediate segment definitely warrant additional buttressing plate. Again, the fracture plane will dictate the root trajectory where if not properly applied, it may not go for compression, sometimes it may cause displacement and definitely non-union. And blood supply by during exposure or while predicting AVN so that we can convince the attendant that chance of AVN is this. And again, true or plate depending upon the size of the fragment. Yes, the fracture type dictates the type of surgical approach. So for 1 and 3 where the fracture fragments are larger, anteroposterior screw or posterior anterior screw or cross screw through regular parapatellar approach can be used. In small fragments, less than 28% of the AP diameter of medial condyle or less than 20% of the lateral condyle of femur profile, the visibility is limited with the parapatellar approach. Hence, we may need to go through direct approaches or posterior approaches and we need to fix it with screw. These are the various surgical approaches like medial parapatellar, lateral parapatellar, subvascularis or extensor subvascularis medial approach, direct medial and direct lateral approach, posterolateral approach, direct posterior approach. Sometimes we may need to use tibial tubercle osteotomy, radial tubercle osteotomy. Now they are advancing arthroscopic assisted fixation. Sometimes the fracture may be open, like in this case, where the complete femoral condyle, including the distal femur, are exposed along with the rupture of the patellar tendon and patellar fracture. So we have to use this opportunity nicely debriding. Since the condyle is visible 360 degrees, we can use plate, screws. Sometimes there may be loss of condyle or osteochondral injury, which may be need to document. She et al. Proposed with the 3D mapping of the open fracture. So, preoperative lesions with the various approaches available, the extent of intra-articular visualization of the fragment can be predicted. And sometimes the medial approach discussed by Henderson, we have to go superior and the inferior to the MCL, we have to make a tunnel, we have to use plate or screws and fix the fracture. We need to expose two sides of the fracture, that is the articular part and the non-articular part, and we have to reduce it and check it. Guidelines for determining surgical approach. The first step is predict or determine the size of the fracture using PT mapping. Most large simple open fracture, as said earlier, can be reduced and fixed with the parapatellar approach. This is a patient with floating injury where we have type 3 open fracture with approximately a chapter type 6 fracture. The approach is through the regular distal femur plating approach, like anterolateral approach. We expose it, we reduce it, and fix it with the plate. The plate can be anything like T plate or regular radius, distal radius plate, or recon plate, or mini plate. Second step, determine the approach for reduction. To achieve the anatomical fracture reduction, at least two sides of the bony surface need to be identified. One is non-articular part, the lateral part, or intra-articularly the attachment of ACL and TCL. Another one is articular part, the end-on view, where the fracture extends articular. PT mapping, together with the percentage of visible area of the open fracture as described by Preethi et al., the fracture size, the fracture plane, and the area of comminution together will indicate the proper approach. Comminution in the intermediate zone, combination of the approaches should be used. Sometimes we may use the parapatellar approach to reduce it anteriorly, and the posterolateral or direct approach to put another plate or screw additionally. And again, the position of the patient is also very important. When you need to go for two approaches, sometimes the blocky lateral position may be useful so that intraoperatively we may not struggle to reduce it. Again, the position due to the attachment of the soft tissue like gastronomic and popliteal tendon, sometimes there may be distraction or deforming force. We have to neutralize it with adequate flexion of the knee. We are using regular reduction campus plan 1 or 2 and temporary stabilizing with KY, and we are if the fracture fragment is able to fix with the screw, we use screw. Better to use 2 or 3 screws. Single screw may have problem effect and it may not hold the fracture. Practice also dictated the fracture and the necessity approach and the specific indication and the contraindication. Third step, select the proper fixation technique. Actually, a single 6.5 mm AP screw crossing the fracture to allow the interfragmentary compression may not be sufficient. Two screws are indicated. Definitely, the thread of the screw should be crossing the fracture line. Then only it will cause the fracture to compress and heal. So, simple or minimal, like the listener type 2C or D fracture, when fixed from anterior to posterior, they may not be actually compression. So we have to go through direct approach or posterior approach, and we have to put screw from posterior to anterior. And while using screw, definitely the head of the screw should be countersink well within the articular cartilage. Because sometimes when we use posterior to anterior screw, the head may be prominent, or anterior to posterior screw, that thread may have penetrated the articular cartilage. So while weight bearing and flexion, it will erode the tibial part. Again, anticlase that can be used to augment in large fracture with metaphyseal extension. The selective proper fixation technique. This is a 20-year-old female with medical profession has been identified as lateral contact forepass fracture. She has been fixed elsewhere with screw, but the fracture has not been reduced well. She presented to us after 4 months with the stiff knee, and we have identified the definite case of non-union of forepass. We have exposed it, we have removed the screw, we have reduced it and fixed it with additional buttress plate and lag screw, and she is able to do all the movement. Again, this is also another case of forepass where there is fixed with the posterior to anterior screw. Elsewhere, we can note that the fracture has not been reduced well or due to proper immobilization or something, it has been collapsed. Again, when we open to parapatellar approach, we reduce the fracture, we have grafted it. We have used the mini plate to hold the fracture fragment in position. What are the implications for plate fixation in forepass? When the proximal extension is to metaphysis or there is a large space in the posterior condyle, we definitely have to use plate. Large fragment, proximal extension to metaphysis, associated distal femur fracture, osteoporosis or comminution, definitely we need to fix this plate. These are few of our cases where we have used the plate augment. Screw versus plate fixation. The number of the screw and the diameter of the screw are directly related to fixation stability. That at all demonstrates the friction with the two screw is better than with one screw. The two fixation with larger size. 6.5 mm partially threaded screw has better stability. At the same time, don't touch too much screw because again it may compromise the blood supply, and touching too much screw also occupy the bone volume and there may not be available bone for union. Plates intend to produce butterfly or anti-glide function, particularly in posterior placement or in neutralization decompose in medial or lateral plating or in comminution to provide additional stability. But when the fracture is large enough or comminuted, they can provide additional stability. This is the case with the open grade 3B injury around the knee. He is also a medical. We have identified that the bicondylar open fracture with the Sedgwick under avulsion. Since it's open fracture, we use the same approach with extended. Use the multiple headless screws and the polygon canceller screws, held the fracture in reduced position. At the same time, PCL avulsion as also with the screw, and we temporarily stabilize it with external fixator. Type after fracture along with the lateral condyle forepass fracture, they fixed with the plate. Therefore, the last protocol for the fixation, medial condyle, when the fragment is large, through medial parapatellar or medial subarachnoid approach, use anteroposterior screw, or if large fragment can go for additional plate also. Moderate, that is 20 to 29% of the condyle, go for direct medial approach. We may need sometimes dual approach, as I said earlier, medial parapatellar, but direct medial approach. Use posterior to anterior or anterior to posterior screw per plate. If it is small fragment, go for direct approach, which is posterior anterior screw or sliding plate. Again, in lateral condyle, large fragments will be fixed with the lateral parapatellar approach with anteroposterior screw or plate. Moderate in size, use direct lateral approach or combined approach and fix with plate or screw. Small fragments, definitely posterior to anterior approach will be beneficial. These are three cases of forepass fracture where they are treated conservatively for 35-year-old female. They are persistent pain and instability. In this particular case, we used to take MRI to know the ligament status condition. Also, we can identify the gap where we fixed with the sideboard graph. One point to consider is we should not increase the length of AP diameter of the condyle because during rollback of the femur, it may act as a block and prevent further function. So, the appropriate length of AP diameter of the condyle needs to be maintained. Here we use the Alcman plate so that we have 3 up to 4 grooves in the Copas fragment. Functional. This paper was published by Bagari et al., Indian author in Shikot journal. He proposed the radiological classification and surgical approach for the fracture and what implant can be used for it. Type 1 is unicondylar fracture with greater than 2.5 cm of the fragment height, anterior posterior lag through, with standard parapatellar approach can be used. Type 2, where the fragment size is less than 2.5, with single unicondylar fracture, posterior to anterior through is part. Type 3 is a comminuted fracture, definitely lag through with buttress plate. Type 4A is anterior OPA or anterior plate fracture, where the much more osteochondral injury, anterior to posterior lag through. This can be much dealt with arthroscopic assisted reduction so that we can visualize the perfect reduction, and lag through can be placed with percutaneous approach also. Type 4B is bicondylar fracture, the lag through depending upon the size of the fragment and definitely needs additional plate fixation also. Type 4C is osteochondral Copas fracture, where headless through or bioobservable pin also is irrigated in this case. And type 4D is comminuted Copas with extension into proximal fibula. Lag through which is rigid locking plate fixation.
Thank you, Dr. Ulam, for a very good justice presentation. Any questions? Okay, thank you. We invite Dr. Balthina for the topic on suprapatellar nailing. How is it?
Good evening, everybody. At the outset, I would like to thank all my teachers and my seniors for giving me this opportunity. So, suprapatellar nailing, how much it is beneficial. So, intrapatellar nailing of tibia is the gold standard for treatment of fractures of the tibia, as it ensures the good fracture stability and safeguards against malalignment and allows. So, when we attempt intrapatellar nailing in proximal third tibia fracture, we encounter two problems. One is the apex anterior angulation and valgus malalignment, which is mostly due to the strong quadriceps pull and the posterior gastrocnemius and chest action. So normally we get all these type of malalignments when it is done to an intrapatellar approach, even though there are some modifications for doing it, like taking a intra-articular entry or taking a more lateral entry. So the suprapatellar nailing was first advocated by Tormenta and Collins et al. In 1996 through a partial medial parapatellar with the knee in semi-extended position of around 15 degrees. It eliminates this pull of the patellar tendon, and here the trochlea is used as a bed for the nail insertion. So later Morandi et al. Used it for through a percutaneous lateral suprapatellar. So there were various literatures after that which came which showed that there is no significant difference in pain between suprapatellar and intrapatellar tibial nail insertion. Another paper by Aguncia et al. Where it showed that there is a 25% greater than 5 degree varus malalignment with intrapatellar technique, which can be avoided by using a suprapatellar nail insertion. And this is a meta-analysis of 4 RCTs which shows that the suprapatellar approach is better in case of a proximal third and distal third metaphyseal tibial fracture. So the ideal indications include a proximal third or a distal third metaphyseal fractures, or segmental fractures or double segmental fractures, and in polytrauma situations with multiple injuries where we can plate and nail it in the same sitting. So this is the surgical technique normally we use. We keep it in around 50 degrees of that knee flexion and use the suprapatellar entry through a guide wire, and all goes in, and we do a serial cleaning. And the advantage with this suprapatellar nailing technique is, as the knee is in the extended position, we need less of distance, and we get a very adequate space where we can do percutaneous reduction of the fracture, and it allows a good reduction also. So we can use all the reduction techniques which are available, like using a blocking screws. Percutaneous reduction is possible, and rarely we can use a mini plate or a femoral distractor or a. So the advantages of this technique, so it mitigates the pull of the patellar tendon, it aids easy reduction, it prevents varus malalignment, particularly in distal third tibia fractures. An easy longitudinal traction is possible in distal third fractures. There is a very lesser need for surgical assistance. You can get a true lateral view possible, particularly in proximal third and distal third fractures, and you get a very good adequate surgical space for reduction techniques. So some of our cases, this is a very low distal third tibia fractures, and this was managed close with the suprapatellar nailing technique, and it went on to heal nicely. And this is another bimalleolar fracture. The patient came later with the distal third tibia fracture, comminuted distal third tibia fracture. We removed the distal screws and did a suprapatellar nailing, and it went on to heal. And another, it's a polytrauma patient with a proximal third tibia fracture, and with a femur and proximal third tibia, and it was nailed, and it went on to heal nicely with a complete healing. And this patient is a very 60 years old patient with a very fragile skin with a distal third comminuted tibia, and we did a tense nailing for the fibula with a closed suprapatellar nailing with the 3 distal screws, and it went on to heal nicely. So it avoids a lot of skin complications by doing a minimally invasive technique. This is a segmental tibia fracture, so we managed it with the suprapatellar nailing technique, and it went on to heal nicely. And this is a double segmental fracture, and in these cases, a suprapatellar nailing is very useful because you can give there is an adequate space, the longitudinal traction is possible, and you can reduce the entire fracture closely, and close nailing was done, and it went on to heal nicely. So this is another case of an open fracture of the distal tibia, and initially it was managed with an external fixator and back application with a flap cover, and later we removed the external fixator, and we just did a closed suprapatellar nailing with a bone marrow injection, and it went down to heal nicely. So the patient was avoided of any further plastic procedures. So it went on to heal nicely. And this is another distal third tibia fracture. In the lateral view, you can see a fracture extension into the intra-articular segment. So the fractures are fixed with multiple lat screws along with the suprapatellar nail, and it went on to heal nicely. And here the plating was avoided, and with the minimally invasive technique, skin complications were also avoided in these cases of complex situations. And this patient had a old distal femur fracture with a stiff knee, and he was able to flex only up to 30 degrees. So this tibial shaft fracture we managed with the suprapatellar nail, and the patient is under still follow-up, healing under follow-up. This is another extreme distal third tibia fracture, was managed closed with the suprapatellar nail, and it went on to heal. So the concerns regarding this suprapatellar nail is the injury to the patellar and the trochlear articular cartilage. So always use a proper, it's better to use a proper sleeve, and the injury to the intra-articular structures. There is risk of joint sepsis as we are violating the joint, and there are risks of retained reaming debris within the joint and joint stiffness, and there are problems in nail removal. So some of the practical tips: always look for the patellar mobility before attempting it, and use the proper sleeve, and make sure that your sleeve gets docked proximally in the proximal tibia before inserting the reamer. Preferentially use a flexible reamer which avoids the intra-articular injuries. And assessment of nail length may be difficult initially when you are regularly used for the intrapatellar technique. So always get used to your armamentarium before assessing the nail length. And always we use a drain post-op to prevent at least prevent a hemarthrosis, and it prevents post-op knee stiffness also. And it's very important to vigorously mobilize the patient post-op because there is a risk of getting a knee stiffness. So always after removing the drain, put the patient on CPM and mobilize the knee. So I want to conclude that it's a safe and a viable alternative in metaphyseal fractures in tibia, and it's a bailout option in complex and polytrauma scenarios. And osteochondral injury remains a concern, and when a proper surgical technique is done, it yields very good results. So on behalf of Preethi Hospital, we'd like to invite everybody to the next course, our TNOA basic orthoplasty course. It's going to happen in Preethi Hospitals on 24th July 2022, which is mainly concerned for PGs and junior consultants regarding the basics of orthoplasty. Thank you.
Thank you, Balakumar, for the innovative session. Any questions from the floor?
There are two other advantages which is not mentioned in the literature. We will come across this intrapatellar branch of saphenous nerve, which is getting regularly damaged by this intrapatellar skin incision. The patient will be presenting with some hyposthesia, some burning sensation over the area. It is totally avoided. The other one is this Fopas disease, where you will be invariably damaging this intrapatellar and we are doing an intrapatellar approach. So that is also getting avoided. So all these are in favor of suprapatellar approach only. The only concern, as you told, when you are taking the case for some time when the knee has gone for stiffness, the patella is not mobile, then it is very difficult to take the injury. I think in due course this suprapatellar injury will become obsolete and this suprapatellar injury will become a standard procedure. Are there any contraindications for suprapatellar injury?
Stiff knee problem. The patella is not that much mobile, and we are not able to negotiate the sleeve inside the joint. So in that time, we may be injuring the cartilage.
So they say that whenever you have a patellofemoral arthritis and patellofemoral stiffness, so it's better you avoid because you have to see the patellofemoral mobility. Whenever there is no appropriate patellofemoral mobility, you see you will have very tough time in doing a suprapatellar nailing. So that is one, and so rest you have covered it.
Because in protein the intrapatellar approach, you can simultaneously nail the lower femur as well as the tibia. So you cannot use the suprapatellar nail whenever we are coming across protein. This is a relative contradiction. We are planning for nailing in femur.
You told that knee stiffness is one of the complications for suprapatellar nailing. Have you seen extensor lag?
Actually, no extensor lag when we compare to this intrapatellar approach, because in intrapatellar approach we are going through splitting the ligamentum patellae. So that is one of the final strength point of this extensor mechanism. Here we are splitting the muscle. So the patient is having very good range of movements without any 0 degree lag. Be observed.
Proximal one-third tibia. There is always a edema and confusion whether to go for nailing or plating. But obviously, plating is more easier because you need not struggle with the reductions. Is there any exact anatomical landmark that okay, it's get reduced, obviously with all the reduction tools which are using, where you can go in the proximal one-third region, even in that exact anatomical regions to say okay, you can go into the nailing.
Just below the tibial fibrosity, how up to around 5 to 6 centimeters approximately. Above that, it is better to plate it.
When you are using plating for proximal tibia fractures, so we have been using polar screw techniques and all. So, what is your experience like when you are doing a suprapatellar nailing? Do you still need to put these polar screws or blocking screws, or you can get away with that?
We can use a Steelman pin. We can use a Steelman pin as a polar screw. Actually, you can just insert a Steelman pin posterior. The aim of the polar screw is to just guide the nail anteriorly so that you prevent this affect anterior angulation. So you can just use a Steelman pin as a guide, and after the procedure you can remove.
My intention to ask this is whether you do intrapatellar nailing or do a suprapatellar nailing, you may have to
use the
reducing technique so that you can avoid the effects.
Preethi KNee, because we have this space and osteoarthritis, will be developing arthritis, will have problem, patella fracture, ropes, arthrotic inflammation typically comes with the pain and infection, pain from stairs, climbing up. That means that we have injured their property. The maximum you see these stomachs at 87 point, so you can put down.
Metal exit after supraperennial phobia.
Intraperennial.
Thank you, Bharat, for this interesting session.
Thank you, sir. Professor Chidambaram, sir, to felicitate our chairpersons. Professor Dr. Rajamurli, sir. Felicitate Professor Imran, sir. I request our chairman, Professor Dr. Kumar, sir, to felicitate Professor Chidambaram, sir. I request Professor Chidambaram, sir, and Kumar, sir, to felicitate Dr. Prahlad Kumar, Senior Consultant of Dr. Somasayed, sir, Organizing Secretary, Senior Consultant of Trustee. Dr. Sunil, Senior Consultant, Spine Surgeon. Dr. Vinod, Spine Consultant. Dr. Bharat, Consultant Spine Surgeon. I request Dr. Bharat, sir, and Professor Thiruvancha for President of Professor Zogmaster.
On behalf of Arthur Department, we would like to felicitate Dr. Balaji, who is a senior anesthetist of Preethi. Dr. Suresh, they are the persons who have their ortho and anesthesia are part of all the events here, and they are always together in conducting all the conferences and successful running of the life cycle.
I think they'll get more credit points through ortho conferences than anesthesia conferences. They are with us more often than their own anesthesia. But anyway, they would like to invite for a CME somewhere in August. Tell your anesthesia friends, really they are good. In fact, what we are today is because of the anesthesia team. We are able to operate on a patient who is 90, 60 BP and is polytrauma. He gives regular. We have a lady who is 99, 103. Then ankylosing spondylitis cases, everything. And many of the cases they don't even give spinal, they give blocks, flexor blocks. Even in that we are challenging cases. Even upper limb also, bilateral upper limb cases, they are able to manage one scaling one side and the other side. There are a lot of things. In fact, if you have friends who want to learn blocks, that Balaji and Suri are very good in that ultrasound guided blocks. They'll be able to teach. Yes,
when you giving the mic, say you know he is a HOD, he is in charge of the whole department, top man here, one of the top men. In spite of it, without the ego, he was doing all complete work. He was a fielder. So, you learn from it, you go back to your department, looking more, not going to looking down, looking more learning, apart from the academics, other things also. There is any pitfalls in our conference, we can put forth so that we can rectify in the next one. That's what we learn from our mistakes. Anything also, small things in the listening, tell us so that we rectify in the next conference. Comments from the floor is also limited. Even though maybe junior consultant or PGs, small things you can say. Good things also you can say.
Sit.